Off with a very warm welcome to all of you. Before we begin, I'd like to just remind you to kindly keep your mobile phones in the silent mode. The format that we will try to follow through the day for all our sessions is that I will make the introductions of our speakers and hand over to the chair or the moderator of that session. The chair will then invite the speakers. Have a bell go off as an indication for you to please conclude as quickly as possible. You also risk a likely intervention by the chair if you continue to speak beyond your time. In the end, we will ask the chairperson to share his thoughts, and if time permits, we will have a short interaction with the audience as well. If you've seen the agenda, you will notice that it is a tight schedule, and today in particular, I'd like to draw your attention to a virtual session that we have later in the day. So we need some time to coordinate with our speaker who is overseas, connect with the speaker and coordinate the connectivity, etc. So we would request all our speakers to please not exceed their time slots. Now, without any delay, I'd like to introduce our esteemed speakers to you. Our chairperson for this session, Mr. Manoj Joshi, is the Secretary in the Ministry of Housing and Urban Affairs, Government of India. He'll join us in a short while. Our founding CEO of HSTP, Mr. Rajiv Sadanandan, is a former bureaucrat in the civil service. He's been working and researching in the area of health systems, policy and financing for over 2 decades. He had worked as the Health Secretary of Kerala and the CEO of Rashtriya Swasthya Bima Yojana, India's national social health insurance program, in addition to holding many other positions in the state and central governments. Recently, he was advisor to the Chief Minister of Kerala on the management of COVID and one of the commissioners on the Lancet Global Health Commission on financing primary health care, and is currently a member of the technical advisory panel of the World Bank's Pandemic Fund. I'd like to request him to please welcome our guests, speakers, and participants. Mr. Sadanandan.
Thank you, Renee. Welcome to all the distinguished guests who have joined us today, and thank you for coming. I'll begin by briefly outlining why the 2 studies were conducted and what we had hoped to achieve through them. The Kerala study grew out of the COVID-19 pandemic. Kerala had responded considerably well during the initial period, and the major fact that all of us had talked about was the leadership given by the rural and urban local governments. Many state governments and health led to Kerala doing well, including a request from the Chief Minister of Andhra Pradesh. The Kerala study was undertaken in response to this request, and we hope that what's produced will more than meet the expectations. The Janagraha study was inspired by the initiative of the health grants as allocated to local governments by the 15th Finance Commission. In Bihar, they carried out a landscape study on the role of urban local bodies in managing primary health care. The objectives of the study were to study models of primary health care where urban local bodies were playing a primary role in access to equitable and equitable healthcare services in selected cities. And the details of these will come out later. The Kerala study had quite a lot of objectives. I will not go through all of them. And I must say the study is now complete. 19 peer-reviewed publications have come out of this study, and I'm told that 4 more are in the pipeline. We also expect a book based on the studies to come out, which, as I mentioned before, we hope will address the gap address the gap that was there in understanding how the local bodies had done well. I am happy to formally welcome 2 of my former associates. Sri Vijayanand was my boss in I think 3, 5, I forget how many. And he has distinguished himself as an expert of decentralization. not only in Kerala, but across the country. Currently, so sought after that getting him for a session was very difficult, and we're lucky to have him here. Thank you. Welcome, Mr. Vijayanand, for joining us today. And Dr. Thomas Isaac he was my professor at Center for Development Studies. He made not a very successful effort at trying to teach me macroeconomics, and he was also the minister in charge of finance during the time when I was health secretary for the second time. And if there is one person that we owe so much to the transformation that happened in the health sector in Kerala, it is to Dr. Thomas Isaac, who is very passionate about the health sector. It's an honor to have you here, sir, and welcome to you too. Joining us are elected representatives from many parts of Kerala and other parts of India. There are officials in the state governments, from the state governments, from the local bodies who are joining us today. And most of all, we have the researchers who actually carried out the study. Unfortunately, we have not been able to bring everybody here, and I hope that in a larger dissemination that hopefully can happen in Bangalore or in Kerala, we'll be able to get more people to come. So thank you for joining us, and it'll be your discussion that will be making this discussion fruitful. Once again, welcome to this meeting. Thank you.
Thank you very much, Mr. Sadanandan. Dr. T.M. Thomas Isaac is the former Minister of Finance, Government of Kerala, and an economist by training. He's authored a number of articles on economics, planning, and politics, has published in leading regional, national, and international periodicals and journals, presented lectures and papers at national and international conferences and seminars, and written more than 50 books in English and Malayalam. He was elected to the Kerala Legislative Assembly thrice and was the Finance Minister of Kerala for 2 terms. As a member of the Kerala State Planning Board, he steered the decentralization planning process. I'd like to request Dr. Thomas Isaac to please deliver the presidential address.
Dear Rajesh Sadanandan, S.M. Vijayanand, colleagues and friends, I'm in very good company. Manoj Joshi is expected to come as my finance secretary, and both S.M. Vijayanand and Rajesh Sadanandan, well, I was fortunate to be one of the teachers, and we were co-conspirators in the journey of decentralization in Kerala. Well, let me start with a statement that health outcome is not a mere outcome of the interrelation between hospital, doctor, and medicine. It's a multi-sectoral phenomenon with very important linkages to sectors like sanitation, nutrition, drinking water, physical culture, education, and so on. Now, viewed in this perspective, decentralization becomes very important for health outcomes. For the simple reason, on the principle of subsidiarity, all these sectors I touched upon are best done at the local level. Now, if you take the history of say health development in Kerala, whose outcomes have been fairly exemplary, an important factor contributing to this better outcome has been what we call demand from below of social movements and concerned citizens making demand on the government for supply of health facilities. And it's not just the supply. Even if you supply, it may not be used. You can bring the horse to the water, but not guarantee it will drink it. So there's a very interesting article which I like very much of Professor John Mencher. She was an anthropologist who used to regularly come to Center for Development Studies where we all studied. Professor John Mencher has a paper in mid-70s titled Lessons and Non-Lessons of Kerala Model. She was at that time studying agricultural labor in Tanjavur and Palakkad. So it was a village-based study, and incidentally, as a spin-off from her main study, she makes a comparison of people's action in these two villages. And she says, okay, the PHC in the Kerala village, if the doctor is not there, if there is no medicine, definitely there will be a protest, some dharna, this, that, some racket, so that the health authorities, the district are forced to take action. But in Tanjavur, where she stayed and worked, the doctor would be absent for long, and so nobody cares, nobody comes. Of course, this is Tamil Nadu of late 60s. Tamil Nadu has changed, transformed, which is a wonder in the intervening period, but more based upon supply side action. I don't know enough to comment upon that. So, this is very clear. The intermediation of the people, the citizens, are very, very important. Now, this can be strengthened and say made more fruitful, this intervention, intermediation, if there is decentralization, if there is a local government to which funds, functions, and functionaries are devolved to and empowered to take local action. Because now the concerned citizens can intervene in the local process much more effectively. That's the logic. So, if you take the decentralization experience in Kerala, I am primarily speaking from that experience, say, communicable diseases, they have been broadly controlled in Kerala. And there it is very obvious the people demanding or responding to vaccination drives and so on. The preventive measures cannot be undertaken without participation of the people as such. And this tradition has been best exhibited during the COVID period, of which Rajesh Sadanandan has already referred to. Now, the COVID experience, interregional differences. I think one objective way of assessing it would be the fatality rate, death rate. And there is no way to get exact death rate. But if we assume the excess mortality rate studies, which has been accepted by, methodology accepted by WHO and particularly Hindu newspaper, have carried out exercises on excess mortality by states. While India, excess mortality is 10 times the accepted death rate, in Kerala is only 0.6 times. It's a big difference, lowest. And therefore we can assume that is the best intervention perhaps. And in this process, decentralization has played a very important role. I shall not elaborate it, but will refer to 2020 World Bank report on state of the finances of states, where there is a whole one-page box or 1.5-page box devoted to Kerala and the COVID. How the involvement of the local governments played a key role in, say, breaking the chain, isolating the COVID patients or say quarantining the vulnerables and so on, or providing food. So this is something, in fact, officially accepted as in the role played by local governments. In fact, the role played by local governments also very evident, say, during the floods, great floods. See, not only flood management in the sense of taking care of refugees and so on, but the fact there was no major outbreak of diarrhea or fever and so on, which is very normal after the post-flood period. See, I myself was working in Alleppey, where I was an elected representative, and see, the whole action involved removing around, say, 50,000 persons from a very flood-prone, low-lying area called Kuttanad to higher areas, the camps. Then after 2 weeks, repatriating every one of them back to their homes. Homes which have been totally flooded, slid, mud and so on, laid roads and houses. And we did expect a big outbreak of fever, diarrhea and so on. Therefore, we had elaborate virtual mapping of fever. That is a program anybody could upload the data on WhatsApp and to immediately go into a database and show what is happening everywhere and so on. But no such calamity happened. Simply because I think something like 25,000 volunteers with the local governments cleaned the pathways, the houses, everything, before these 50,000 persons went back to their homes. So this is something very accepted. But now we are having a health transition, and the health transition take place. Your morbidity pattern is going to change to lifestyle diseases and so on. And then many people doubt, then see, when you have lifestyle diseases, the medical response is very different. You need super specialty hospital, special care and so on. And therefore, usual notion is that then the local participation, etc., wouldn't matter much. They are very important only at this primary stage, which it is not. Hello, Joshi. No, come over. You're sitting here.
You're among friends.
You mistook it for 10 o'clock. So, but you know, if you have a public health system addressing the lifestyle diseases, financially it is unsustainable, so costly. Can Kerala ever think of, which it is doing, it I am some bankrupt the treasury, give free treatment for all the cancer patient load in Kerala? Now it does something for like 75% and hopes to reach 100%, I don't know for what. But then it is unsustainable financially unless you are able to bring down the incidence of cancer. So how do you bring down the incidence of lifestyle diseases? Vaccination is a solution. That's where, in fact, local governance system steps in, you see. I have very interesting experience of my own constituency where we try to implement social surveillance monitoring palliative system whose objective was to bring down the morbidity. It has various components. Volunteer for every 20 households who will be continuous surveillance of the household morbidity and so on. Through clinical tests, blood sugar, pressure, cholesterol, data is collected for every individual with height and weight, a database is created. Second, Then you triangulate this data, find out those who are already patients, provide them with medicine on regular basis from sub-centers. And those who are vulnerable, not at there the targets. Some lifestyle changes, counseling, exercise, and so on will the trick that they don't become patients in the future. Strengthening the PHC system to respond to, so that they do the primary check, say secondary or tertiary sector. Also have early detection programs focused upon the PHCs. Fourth, you have very elaborate palliative system. Fifth, you feed them, those who cannot, particularly patients who are bedridden. Let me tell you, for the last 5 years, nearly 1,000 patients are fed, are given, delivered every day, food at their doorsteps, free, with resources raised from locality. So it's a very elaborate program, differentiable. See, if you are thinking in terms of prevention or spread of lifestyle diseases, then the solution lies in local involvement in monitoring and appropriate actions. Then, if you are looking at, say, the future, I think, Dr. Vijay Kumar, I saw you coming in. We all have been involved in, say, geriatric care in Kerala. How to have a participatory approach to it. The Western response has been institutional, okay? While you work, you buy yourself a home in one of the institutions, a room, you retire. I think quality of life in such a situation is so terrible. Well, what are the, besides that, it is almost financially impossible for India to have such a response. We'll have to devise a scheme where they are given the protection and care within their own households, but with community support, you see. How do you raise that? Well, local government will have to play a very central role in this. It would involve that the age were able to get involved in social activities and so on, providing them local space for creative work, participation in social affairs. That's very, very important to feel being wanted. I think that's the most important thing when you become old, you see. So you have talent banks and so on where you are, can register, and then you can get involved in teaching, education, primary health centers, primary, say, Anganawadis and so on, or enterprise development according to your talent and expertise. But there is always an age when you'll have to retire. And I think palliative would play a very important role. Certain health interventions like controlling your pressure and diabetes, etc., can have positive impact upon your dementia and so on, which inevitably comes at the old age. So you build up a palliative network. Well, I think this is the most important health initiative in Kerala in the last 3 decades. Now it is almost universal coverage of palliative system, almost voluntary basis, okay? And the local government playing a coordinating role. Providing nutritious food, diet food, that is very important, you see. Diet food can be on a payment, and those who can afford can be free. assistive devices and so on, or making the public space elder friendly in terms even in your own house. Majority of people have, say, fallen, hurt within their own house. And also public spaces where elderly can come and, say, spend their time. It means elder clubs in every ward, elder, say, neighborhood groups. So these are all interventions at the community level, which will have to be coordinated by a local government. You see. So I'm encroaching into what I think after some time we'll be speaking about the experience of health experience in Kerala. If you take a survey of the literature, initial responses like that of Joy Alaman and so on have been very positive. There are a large number of studies who have been so lukewarm about impact of decentralization, like, for example, Jose Chathukulam and so on. Majority of them then have been highly critical also. Varadarajan from Achyuta Menon Center, his study has been a care. Thangappan, they are all, Thangappan, etc., have been votaries of local government, but they have been highly critical of the health outcomes, which raises a very important aspect, that impact of decentralization, the final outcome have differed from place to place, village to village, town to town, and varied over time also. I'm not going to go into the reasons of that, but it underlines one important fact. Decentralization creates the necessary conditions of good health outcome, doesn't guarantee it. It creates a democratic development space for concerned citizens, organizations to intervene. Wherever there are people, citizens, and organizations who want to use that space, willing to use that space, well, I think improvement will take place, better outcomes will take place. Here in this session, for example, Venganur Panchayat representative is here. He's going to present about the Bud School. It was innovation in a village, say 5 years into People's Planning campaign, where they innovated a local institution to take care of the differently able, particularly autistic children. Now this became the best practice, just scaled up to all of Kerala. This gives you the freedom to innovate like this. Not that everybody is going to innovate, and becomes inspiration for others to take up. During the COVID period, Kerala, the People's Kitchen sprang up everywhere. Nobody went hungry in Kerala because you could go there and have free food if you want. Now this is an innovation which was made in my area. We have a hotel where you can go eat. There are no bill, there are no cashier. There is not even a price list. Eat to your fill and pay what you can. Most people said this is going to fail within 2-3. It is functioning for the 5th year now, going strong. I tell you, this is not a free Kanyi center, rice grower center. If you are providing that, the middle class and rich people won't come to eat. They have to come, they have to subsidize, cross-subsidize. The poor would be eating free. So everybody gets good food. This is a local innovation, which now scaled up to state, all over the state during the COVID period. So this decentralization, local empowerment gives you this democratic space. Now, let me conclude with a brief statement of the impediments which are coming up. I hope S.M. Vijayananda would respond to it. Of course, kind of enthusiasm with which we all greeted 73rd, 74th constitutional amendment is no more in the country. I don't think the present rulers even talk about it. And not only present rulers. 25th anniversary of democratic decentralization, 73rd, 74th constitutional amendment was celebrated only in Kerala. Okay, that's this change has occurred. Okay, that's one thing. But I think there is a positive development also. That comes in the form of increasing devolution by Union Finance Commission, a factor, a thing we had not factored in 1993, 94 and so on in our discussions. You look at the literature at that time, Union Finance Commission doesn't come there anywhere. But now, Union Finance Commission, say even in the case of Kerala, their allocation would come to 1/3 of the total devolution to local government, very substantial. You add to that MGNREGs and other central some schemes. Vijayanand and me had written a note to, not for Manishankar commission report. We said, okay, you can have a minimal planning. Okay, this is something assured. Union Finance Commission, MGNREGs, and certain centrally sponsored programs which can be integrated together. That gives a minimum amount with which you can start planning anywhere in India. Okay, that's the positive thing, anywhere in India. Of course, we can have a total plan as in Kerala, where significant devolution of funds to take place and so on. And certain initiatives were taken by the government also, but this is a possibility. Now, what is the negative thing? The Union Finance Commission award, devolution, for example, health. Health is a major beneficiary, comes with all sorts of strings. They are sitting and planning, the Union Finance Commission, about what is to be done in the health in Kerala and Bihar. How can you do that? Conditions are so different. You take people, local governments into trust here. Don't try to micromanage from the center. And this is becoming fashionable, transferring money directly to local governments because there will be leakages, etc., which are prevented, but which in fact is undermining the best practices that have come about in states like Kerala. Now, instead of a total plan that is being drawn, everybody knows, World Bank with its funds for sanitation, they have their own methodology. It has to be made separate. Then comes Union Finance Commission, which has something very different. So all this undermines the kind of democratic achievements that have been made. So in the decentralization, there are very positive development taking place, but also certain negative aspects which has to be taken care of. I hope the deliberations in this seminar, based upon actual practice evaluations, would contribute to better understanding of the process and improve health and democratic decentralization. Thank you very much.
Thank you so much, Dr. Thomas Isaac. To share with us the strengths and weaknesses of Kerala's 25-year experience with decentralization, we have with us Mr. S.M. Vijayanand, the former Chief Secretary, Government of Kerala. One of the architects of Kerala's democratic decentralization initiative, Mr. Vijayanand was in the Indian Administrative Service and served as the Secretary, Ministry of Panchayati Raj, Government of India. Additional Secretary, Ministry of Rural Development, among other positions. He also conceptualized and operationalized Kudumbashri, a women's self-help movement in the state of Kerala. So, ladies and gentlemen, Mr. S.M. Vijayanand.
Friends, it's a very unusual opportunity in a national workshop to sit with three persons with whom we have associated very closely. Dr. Thomas Isaac, my teacher, my colleague in People's Plan, my boss as finance minister, and now a very thick friend after her retirement. And Rajiv Sanandan, 1 year junior to me in college, friend since 1975. And 3 times I was his boss. That is very embarrassing because in Malayalam, Eda means the closest way of calling. We used to call each other. But when I was his boss, Rajiv couldn't call me Eda. So we had some very embarrassing moments. And Manoj was a member of the 6th State Finance Commission, which I chaired for a brief while before he left for Delhi. Okay, now I've been asked to give an overview of Kerala's decentralization. Nothing to do with health. Overall, a picture of what Kerala did over the last 25 years, the strengths and weaknesses. It is the youngest among the states which did decentralization. Maharashtra, Gujarat were the big 1960s, West Bengal in 70s, Karnataka in 80s, and then Madhya Pradesh started off immediately after the amendment, and 95-96 Kerala went ahead in a big bang way. And it's ironic that a state with a huge public action and political contestation was very late in bringing about local governments. I can never explain that. But when it happened, it came with a big bang. In a short period of about 10 months, most of the powers and funds were devolved without waiting for any thinking. So we reversed it. So that's a big lesson. Whatever I'm saying are lessons for the rest of India. Don't wait for capacity to develop. Capacity cannot be created in vacuum. Capacity can be created only by doing. It can only be learning by doing. So otherwise, you create capacity. So we had a reversals. Trusted, build capacity after giving money, created systems after giving responsibilities. So in a sense, it was a kind of a reversal. But political consensus, decentralization is politics. And political consensus is what will set it going. But it will not continue. It cannot continue for more than few years. So it's a small window of opportunity for others to rush in and realize it. So in Kerala, it was a combination of civil society activists, largely from the Kerala Sastra Sahitya Parishad. Persons like Dr. Isaac, though they were in politics, they pushed the active part of politics, not the partisan politics. And people like us who are in the bureaucracy, we all complemented each other and pushed it to in a situation where you can't go back. Otherwise, decentralization can be withdrawn and nobody's going to cry. Even in Kerala, if decentralization is withdrawn, nothing will happen. So that everybody knows. But to making it, rooting it, will be the work of this group, and that's where people like you come in. Of course, Kerala had the fortune of having late Sri M.S. Namboodiripad, who could give the political discourse, justify it in a party which believed in centralism. And Mr. A.K. Antony, who pushed it from the UDF side. But for them, I don't think decentralization would ever have come in Kerala. And Kerala has political local governments. So it's a moot point whether which is better. A political is, I think, a bit hypocritical. All of them are politics. Political local government means it encourages competition and it encourages accountability, because the parties in power will be hit by a bad performing local government from their party. So I think there is some justification, but partisanship is a big danger. So Kerala had a post-literacy movement kind of momentum, learnings, and that was used for people's mobilization, which resulted in this. And KSSP had done a very rigorous, we all talk of evidence-based policy, a very rigorous methodology development in one village panchayat called Kalyasheri in Kannur, later the atmosphere was created, not just the political atmosphere, the intellectual atmosphere was also created for people's plan. So these are not absolutely essential preconditions, but they help. That's all I wanted to say. So a constitutional, political, intellectual factors converged, and we were lucky. So an active combination of political leadership, civil society, and civil servants stepped in. And Kerala came in with a very, very innovative concept, which you can push everywhere. Nobody will object to it. Government of India adopted in policy, but Kerala forgot in practice what is called voluntary technical code. It is there in the JNNURM guidelines, I guess. It was put in the MGNRE's guidelines, where you bring a body of voluntary experts. They will not be paid, but they don't have to spend any money out of the pocket. And they come and help a village. They can help even a city. I think Bangalore has some semblance of this voluntary action. That is because lack of capacity is terrible in all local governments, including urban local governments. So this voluntary mobilization is a great idea. But since 2013, till 2012, Kerala has forgotten it, and there is nothing. But that is an innovative thing. And it's not just supporting from outside. You are part of the process of approval of plans, of vetting of plans, advice, giving advice, and so on. Even technical sanction used to be given by engineers from outside given in committees. This committee system of technical sanction has a great deterrence on corruption and partisanship and delay. Now, Kerala has given it up for obvious reasons, you can guess. The approach of Kerala, as I said, reversals and campaign. We had a reasonably successful literacy campaign all over India in the 90s. So a campaign for planning is very much there, because that sets the agenda, gives hope, a lot of discussions. So that overall thing, environment building, is very good. And what is the entry point for decentralization? You can have an entry point anywhere. West Bengal had land reforms. Karnataka probably had service delivery. Kerala had planning. The idea was every section of society will be interested in planning. I can hope for something. So that galvanized people into action. And also left idea of Freirean analysis. When people analyze their issues, their situation, and reflect on it, naturally action will come and things will improve. That's a kind of an old philosophy behind literacy. And what is the philosophy of decentralization? At the time when they started this, they said, you are rolling back the state. It's a World Bank prescription. How can left government do it? So we came out with the formulation, we are not rolling back the state, as was mentioned by Dr. Isaac. We are taking the state to the doorsteps of the citizen. From a welfare state to a caring state. Not a nanny state, which gives everything free, but mobilizing people, reaching individuals, attending to individual needs. That's the definition of a caring state. And then the values and principles are articulated upfront. That is again very important. You just don't do some namkevasa decentralization. You tell them what you're going to do and what are the underlying principles. If you do a content analysis of Kerala's government orders, they are in thousands. You can see some things. One, participation. Everywhere there is a conscious attempt to create participation. Then inclusion. The poorest of the poor, SC, ST. Transparency and accountability. You read any order, any rule, including the act, they try to bring all these kind of things. And accountability, processes of accountability are very, very critical. So beneficiary selection is a very simple thing where there's a lot of partisanship everywhere, but there's a due process. You have to come out with criteria, eligibility criteria for any scheme. Maybe if there are 10 houses to be given and there are 60 applicants who are eligible, then there is something prioritization criteria. And prioritization criteria are marks arranged in such a way that the total comes to 100. So it's a weightage. That weightage can be decided by the panchayat. And we used to jocularly say it could even be party membership. If you are a party member for 10 years, you will get 10 marks. If you have 6 years, you will get only 5 marks. So have a norm, that is joke, but then some norm and ultimately read out the thing. So it is local, in a sense, local policy making. And what is the role of government? Creating capacity, guiding without directing, enabling without restraining. I did all this, it's not easy. We tend to tell them do this, but you have to advise them, but not direct them. That's very, very difficult. But a very important thing, many of us don't realize, all our administrative operating systems were designed for centralized governance. There is nothing Kerala has not succeeded in that. A lot of efforts are made. I am still a part of it in many things. A system which is robust, which can be managed by a Gram Panchayat, not in Kerala, by a Gram Panchayat in UP or Chhattisgarh, where there's hardly one staff. That is a system we need for local governments, which kind of meets all the constitutional principles. That is very a big challenge which we have not been able to do. So we created interim operating systems and proactive troubleshooting. A secretary local government would have 10 times increase in his work after decentralization, because government will be on its toes, at least in the first 10 years. We tend to make a lot of mistakes, a lot of confusion. Clearing it on a day-to-day basis is a very, very important kind of thing. And another important feature, which I think is very strongly necessary, even in Karnataka or Tamil Nadu or Maharashtra with big cities, there should not be any urban and rural difference in decentralization. It's one big principle, but of course, certain local variations are very much possible. Then what are the learnings? Of course, some of the learnings I gave. I'll give you Dr. Isaac mentioned about funds, functions and all that. I have devised a 9F framework, just for fun of it. No, it's not a very rigorous theoretical kind of thing. F1 is functions. Clarity of functions. That's the biggest thing. PHC is with you. CHC is with you. Taluk hospital is with you. District hospital with you. Medical college is with you. Absolute clarity. So in terms of institutions and infrastructure, the clarity is perfect. In terms of services, little overlap. In terms of economic development, lot of fussiness. Who will do agriculture? Everybody will do agriculture, including Government of India and sometimes bit of it by FAO. So in these kind of things, this is very important. What Ministry of Panchayat Raj at one point of time, I think mistakenly called it activity mapping. Actually, it should be responsibility mapping. Activity doesn't mean much. So there Kerala got it fairly okay and is put in law. Then the functions which you give. What are the functions you want to give to local governments? Kerala took a conscious decision. There's a political decision. All the people-related functions, schools, hospitals. Kerala's development is on the basis of its human development. And all the human development institutions are with the local governments. Anganwadi, schools, up to the higher secondary and secondary health. So what does it imply? It's a big risk. After 25, 30 years of or 50 years of decentralization, if there is any slippage, who goes to government institutions? The bottom 1/3 of the population, in mostly. So if something happens to Kerala's poor, the blame should go to the local governments because they didn't manage health and education properly. So it's a big devolution, taking a huge risk. And more to the cutting edge. The most powerful local government in Kerala is the village panchayat. I don't think district panchayats are very powerful in Kerala. Even the block panchayats, because of their very nature of Kerala, they can't be very powerful. So it's a Gram Panchayat which is very powerful, gets 70% of the funds and most of the important responsibilities. So that's a big learning, more to the bottom. And the quantum of decentralization is there. But did we decentralize perfectly? Kerala did not decentralize water. Why? Not because panchayats and municipalities cannot handle water. Can I openly tell them? The power of the unions in the Kerala Water Authority. That alone determined that water will not be given. It is not given even in Jal Jeevan Mission, where it states that the panchayat should be consulted, panchayat should decide, and panchayat will do nothing. That's sometimes. So which shows, even in a state like Kerala, there can be countervailing forces, even with EMS there and political will, there could be risks. So that such risks lie lurking everywhere. That brings me to the second F called functionaries, the staff. We had a very simple principle. The words were coined by Dr. Satyabrata Sen, who happened to be heading a committee, of which I was the member secretary, which laid the kind of ground for the institutionalization of decentralization. He said, work and worker will go together. So you don't create, and he used the word, there shall not be any net addition to staff because of decentralization. Somebody is doing work somewhere, let them go. Now, all over India, there's fiscal crisis. You can't create staff, so we can only decide who is doing the work, and they will go. And Kerala had a via media, which purists like Raghunandan criticized very strongly. We said, we will continue to, you will continue to belong to the state cadre. Your placement will be by the state, and you will be governed by the state pay commission recommendations. So your career prospects are not damaged. There's nothing at risk. So the doctor becomes the DHS, but you'll work under the panchayat, you'll work under the block panchayat, you'll work under the district panchayat, then move on to the state. So that thing was very, very important to get the support of the officials. But dual control, of course, it can be falling between two stools at times, but dual control means both of them have control, professional control from the department, administrative control by Gram Panchayat. But the control is well defined. What is the control of the Gram Panchayat? You can assign any work to you, but within your sector. And for the work assigned to you, you can review, you can inspect, you can pull you up. And if you don't perform, you can even have a minor penalty, which of course only 2-3 panchayats have imposed in the last 25 years or so. But this is there. Absolute clarity on what is your control. And department officials are ex officio secretaries to the panchayats. So the PHC medical officer is ex officio health secretary. So it's a kind of secretariat. And since the panchayat secretary is not very senior, it's the panchayat president who becomes the kind of a chief secretary and the chief minister together. And again, after 25 years, if you look at it, departments don't automatically work very closely with the local governments. For example, the allopathy department. The first department to work very closely was the animal husbandry department. Then came the Ayurveda and homeopathy. So after first 4 years, these departments used to swear by local governments. Decentralization has helped us, has saved us. But allopathy kept on like that, dilly-dallying. Because of government's political pressure, they worked. But they were not very happy with the local governments. Till about 15 years after People's Plan. Now they work as closely with the local governments as with anybody else. I think there are testimonials given by doctors on what it works. But agriculture department, even after 25 years, is not very close to local governments. Individuals vary, but collectively they don't work together. So that's a thing you want to know. So the biggest lesson comes from our fiscal decentralization. That is what you can give. The third F, what's called finances of funds. It's perfect. The OSR is reasonably good, but still local governments collect only 10% of what their total expenditure is, including Narega and all that. But still they are collecting more than any other state, the rural part. Then the devolution is classical. You can write a textbook. I have verified it with textbooks on fiscal decentralization. Kerala satisfies most of the norms. The quantum, adequacy. Kerala devolves, it still has a plan, the only state to have a plan. Devolves 26.5% of the state's plan untied. And if you look at the state shares of various central schemes, it's more than 35%. Then it gives 6.5% of the state's own tax revenue for maintenance. 4% for own tax revenues, around 50,000 crores now. It went down a bit during COVID, but it'll go up soon. And 6.5%, 4% for roads, and 2.5% for all the buildings transferred to the schools, hospitals. And 4% as it's like state's own, panchayat's own resource. It's called general purpose fund, non-lapsable. So it's a substantial devolution is there. Transparency. Every single rupee goes according to a formula. Whether the panchayat is of BJP or CPM or Congress, they will get the same amount, same formula. And we say it is not the finance minister or the LSG minister who allots, it's a computer which allots the money to the panchayats. As perfect as that. Last 25 years, this is one of the sacred things of Kerala's decentralization. So it goes according to a formula with weightage, almost 40% weightage for backwardness. So backward panchayats get more. Then there is freedom of use. It's fungible. It goes as a lump. You can spend it for health this time or that time with some framework saying that you should spend at least 30% for productive sector, not more than 40% for infrastructure, etc., etc. Equity, as I mentioned. Assuredness. It is budgeted. There's a budget document which gives, it was decided by Government of India, it was enforced by the 13th Finance Commission. I don't think any state is implementing. Each local government allocation is put as a budget document and presented on the floor of the assembly by the finance minister along with the state budget. So and this is non-divertible. So you cannot divert a local government allocation. So there are so much of ring fencing. Predictability. Kerala is the only state which has been agreeing to Finance Commission recommendations. So the panchayat knows, yes, for 5 years I will get this. That's very important for planning. Otherwise you'll get this thing and next year it gets cut. And free flow, it goes every month automatically, you don't have to ask. And very importantly, the same policy, same rules for the state and the local government. State is undergoing through an unbelievable fiscal crisis now. So if state cuts something, the same percentage will be cut for local governments, but not more. So these are some of the positive points of this. Then the F4, I'll quickly rush through, another 10 minutes only. F4 is framework, which means you have a strong legal framework. But the most attractive and well-known form of Kerala's framework is a planning framework, which of course you'll hear in great length. So much so, I don't know if all of you are away from outside Kerala, all the 255 or more thousand Gram Panchayats in India prepare what they call a GPDP, Gram Panchayat Development Plan. The methodology is a adaptation of Kerala's People's Plan methodology. So which means it is validated. And it's been going on for 7 years, and nobody has found any significant fault with it. Then freedoms. The fifth F is freedoms. So the local governments can spend within a framework. Decision making is absolute. They don't have to take anybody's permission. The DPC approves only whether it is according to the guidelines. They can't change a priority. And very importantly, a local government decisions cannot be cancelled by even the cabinet. It can be cancelled only if it is found to be illegal. You give a notice to the local government, get the recommendation, get their response to an ombudsman who is a high court judge, and with the ombudsman's comments only you can cancel a local government resolution. Nowhere, even the state government does not have this kind of protection, and even a local government cannot also be dissolved. So, and another important freedom is, all over India, barring Kerala, I think, there are a hierarchy. They are a hierarchy. The CEO Jilla Parishad has control over the Gram Panchayat and the intermediate Panchayat. They are, in a sense, hierarchy. In Kerala, they are independent spheres of governance. That's a very, very important decision taken in the beginning. F6 is what I call facilitation. You give all powers, give everything, local governments cannot function. So government has a facilitating role without interfering. That's a very difficult thing to do. I mean, we all bureaucrats tend to direct. That is what happened to the 15 Finance Commission health grant. It's made a travesty of Finance Commission grants and inter-government transfers. So somebody sitting and writing, you do this, you do this, you do this. It's illegal. It's unconstitutional, but that's a different thing. So we have what is called a coordination committee for fast-tracking issues of local governments. Fast-tracking it, you'll get it within 3 weeks or 4 weeks. And nothing is a special order. What applies to one local government applies to everybody. Then we have a state development council on the lines of the National Development Council, but not functioning too well. And so facilitation, also nurturing beacons. There are some good panchayats. So they are supported. You learn from each other. Some of the best panchayats are here on health. So they learn from each other. That is facilitated by government. So a lot of active facilitation. Then F7, I can go on adding what I call fraternity. Decentralization requires a lot of people to support. Unfortunately, supporters are very few. And among the civil servants, I must be one of the youngest persons supporting local governments. So Manishankar used to bemoan, new generations of civil servants are not proactively local. So that's a big gap. But what is a fraternity? Very important thing is there are local government associations on the Western model in Kerala. 5 associations for mayors, for municipal chairpersons, panchayats. Many of them predate People's Plan. Very strong associations. Supra-political. And they lobby and the government discusses with them formally. And many of them are included in government committees ex officio. President of the association, secretary of the association. And the only state to have very active associations. But the biggest fraternity, is a lesson to all of you, is a partnership with SHGs. A formal partnership. And our SHGs predated decentralization. So in 1997, he was calling me a co-conspirator in decentralization. The government set up a committee with Dr. Isaac as chairperson, me as the convener, and the then NABARD CGM, who later on became CMD of NABARD, Prakash Bakshi as a member. So we wrote what should be the relationship between the SHGs and the panchayats. We said they are autonomous, but they work together. It's mandatory to work together. But one will not be under the other. So Kerala has the most successful SHG partnership, but unfortunately, NGOs are not very enamored of panchayats all over India. There's a big problem. NGOs somehow are not trustful of panchayats, and also academia have not worked very closely. Eh?
Vice versa also.
Yeah, vice versa also. Panchayats also don't trust NGOs. So that is again the 6th F, 7th F. And F8. What could be F8? Because I didn't get any another word with F. It is. KSSP, but they don't like Seva. They don't identify, but they're an NGO. They're a civil society organization. MAS, they call it a people's organization, people science organization kind of thing. The F8, would I call it functionings. You know, Amartya Sen said capabilities, in a sense it's potential. Capabilities need to be converted into reality, and reality is functionings. So converting the capabilities of local governments, which I mentioned, that is with a function of KILA, and what has been the big achievements, I don't have time to list all of them, but which will happen all over India is diffuse economic stimulus. Now funds go only to states or regions which have the capacity to absorb them. Funds don't go to UP, Bihar, Madhya Pradesh and all that in spite of politics. Even Narega. Kerala spends 5,000 crores under Narega. It should be spending less than 1,000 crores if you look at the poor. But that is because of the administrative capacity. But with decentralization, funds go to the nook and corner of Kerala, the poorest panchayats getting more, and there is some kind of a local economic stimulus. So that's the big achievement of decentralization. Pro-poor expenditure, basically on basic minimum needs, but very important for the group here, improvement in service delivery. First 10 years, nothing happened. They constructed buildings, they painted buildings, but later they got involved in service delivery. Now there is data to prove. In 1998, when the Kerala Shastra Sahitya Parishad did a survey, 28% of Keralites were using a public health facility. 72 were depending on private. At the time, private had not become so big. Then, in 2013-14, I think it's an NSO data, which gave 33.5% of the people were using public health services. And 2017, it has become 47.5. From 28 to 47 is not easy. People coming back, reverse voting with the feet, it doesn't work. Even in schools. In the 90s, there were talk of closing down government schools, saying that people will not come. Private schools are coming up. Now there is a return of students to government schools, not as dramatic as hospitals. So which means service delivery. It's not just the panchayats alone. It's a group of things working together. But I would say decentralization, the speed of service improvement is due to decentralization. Otherwise also it would happen, like Tamil Nadu showed fantastic improvement without any decentralization. But here it was hastened, and a lot of other things where people demand factor came up. Then schools, Anganwadis, the COVID thing, Patrick Heller, very good social science expert on Kerala, he's from Brown University, he said, he gave a beautiful theoretical thing. With local governance, the surface area of contact, that's the word he used, between people and government, it widens, it increases, and the distance closes. That's the best thing of this. And they have been very good in what I call care and compassion. Palliative care of Kerala got a 3-page mention in the Lancet Commission report. And it is 100% done with under the leadership of local governments. It's a model in itself. I think it will be explained later. But school, Ashraya, they are all being explained. Poverty reduction. Poverty reduction is very sharp. Improvement of everything, health and all that is up to a point after which it becomes, the last mile is the most difficult. According to which I don't believe in it. I would say it's 1/10 of it. The Niti Aayog says Kerala's multidimensional poverty is 0.7%. I would say it is at least 7%, isn't 5%? 5 to 10%, but but India's is 25, and Kerala's is 0.7. So see the relative part. And who pushed it? A lot of things, including Gulf, this, that. But the local government Kudumbashree partnership took it to this level. And voluntary action, improved targeting, and the most important thing, talk to any of them independently, the capacity of the elected leader. So you are creating a new generation of political leadership. That was EMS's ambition, which understands development issues, not just talking divisive politics. They understand development politics. So that is again a big thing. Then mobilization of resources. That's a very funny thing. User charges are mobilized. In urban areas, people pay 200 to 300 rupees. I saw a PVTG paying 30 rupees a month for taking plastics once in a week. So it's accepted. To Kudumbashree, that partnership. And local, like surrender of land, everything. But tax mobilization, I would say our local governments are mobilizing only 50% or 60% of what they could be mobilizing without increasing the tax rates. So that is again a big lesson. And the two big outcomes, the planning methodology and the SHG partnership have been done, but there are a lot of issues, which one is constituency-based spending of money. So you will not have big schemes. This is a big problem. Then you are interested in an annual plan, not in a 5-year plan. And you don't use much of data, though a lot of data is around. So it's negotiated priorities. These are all things which you'll find when you go for decentralized planning. And you're not interested in spatial planning. In the beginning, infrastructure focus will be very high. And you will not be interested in, I don't think any panchayat really prepares a health plan. They prepare some plan which goes to the health. That's a big difference. And I think Kerala can prepare a health plan. And multi-level planning is ultimately, planning has to be multi-level. You can't prepare at a level. That is also relatively weak. Economic development in terms of jobs and incomes. In terms of poverty, yes, but in terms of jobs and incomes, much less. The new area, big area all over India, linked to health would be environment and climate change. But the sad fact, for which I should hang my head in shame, our Adivasis have not benefited from decentralization. And in a sense, our traditional fisherfolk, two of the outliers, have not been benefited. Has decentralization led to more corruption? That's my last point. Totally it has brought down, but from 96, there is an increase. But it is far less than what government thinks. And what do you need for local governments? We have been teaching them how to plan. We have been teaching them how to do all this. But now we have to go to a managerial focus. How do you manage an institution? How do you manage funds? So local government management gets priority. These are the points. I think I exceeded by 2 minutes. Sorry for that. I think there's a question and answer session or no time? Okay, there's no time for the question. There's supposed to be a 15-minute question and answer session. So this is an overview. I'm here for both the days. If you have any doubts or clarifications, I'm free to answer later.
Thank you so much, sir. Ladies and gentlemen, we are joined by Mr. Manoj Joshi, the Secretary in the Ministry of Housing and Urban Affairs, Government of India. A senior bureaucrat, Mr. Joshi has previously been the Special Secretary in the Ministry of Food Processing Industries, and being from the Kerala cadre of the Administrative Service, he's been at the helm of several state industrial enterprises. So I'd like to now request him to please make the closing remarks.
Thank you, Mr. Vijayanand, for a wonderful talk. Kerala is a sui generis model. It's a very different state, and what works in Kerala need not really work anywhere else.
It's all about carrying Kerala to the rest of it.
When I first went to Kerala in 1990, I was pleasantly surprised to see very strong panchayats in those days also. And decentralized planning has really strengthened them with providing additional funds, additional mobilization. But urban local bodies is an area which probably the larger the distance they were from people, the effect of decentralization positive probably was not as emphatic as what you saw in Gram Panchayats. So the wonderful work which even today Gram Panchayats are doing, whether in health or in education in large number of areas, uh, couldn't really translate so much in urban local bodies. That's one of the weaker points in Kerala's decentralization. As Mr. Vijayanand said, also that Jila Panchayats and Block Panchayats couldn't replicate what Gram Panchayats did. So probably the strongest component of Kerala's local body system, which existed before decentralized planning, continued to become more and more strong. But rest of the elements probably didn't gain so much. And as Mr. Vijayanand said, you need to move to the managerial side. And urban local bodies particularly failed to move towards the managerial side. That the service delivery concept, you would find many states in India where urban local bodies are far more strong and far more efficient than Kerala. So that's a weaker part of Kerala's local body system. Probably Kerala always had a very strong decentralization, whether it's in the CPM as a political system or coming from that in the Congress or any other party, the district level leaders or local area committee leaders, the amount of power they always held in the political structure. I don't think anywhere in India so much of power is so decentralized, even in the political structure. So that's why it was natural for Kerala to adopt to a decentralized planning and decentralization and funds and all, because of very, very strong decentralized political culture, which is quite unique. One more thing I just wanted to point out in this context is, as Mr. Vijayanand explained, the entire movement of devolution of institutions in Kerala took place based on political expediency. That unlike, say, what you see in Gujarat, Maharashtra, classical Bombay state model, that the local bodies have their own hospitals or schools or institutions where the staff belongs to them. They do the complete funding. They completely own those organizations. So when Kerala went into transferring institutions, it could only do what was acceptable to unions, some sort of a nominal control by the local bodies, but primarily they continued to be state institutions. It changed in smaller organizations like PHCs and all, because of local bodies, panchayats providing funds and local involvement. It got far more decentralized. But the larger organizations, whether particularly for the district panchayat or corporations or municipalities, that transfer of institutions just didn't work. So probably, which is a better model, where this institution completely belongs to a local body, obviously would be a better model. But you have to see a political expediency as to what is feasible in the political environment. So that's what the team of Dr. Thomas Isaac, Mr. Vijayanand, and Mr. Nambudripad, in those days, his son, where you started in 97. I was collector in Calicut and saw the entire movement coming from your side, from the other side and all. It was a wonderful experience seeing so much of a decentralization happening in Kerala, and in some areas producing remarkable results like SHG movement, primary health care, preventive health care. I think these are the areas, improving the schools. These are the areas in which remarkable work took place. But another factor, I think it's difficult to keep apart the effect of decentralization and increased state investment in healthcare system. I think 90s was one of probably the worst period of state investment in healthcare system all over India, including in Kerala. Hospitals just didn't have any allocation other than paying staff salary from the state government. And I think in the 2000 decade, with different Government of India schemes and state schemes coming, the amount of investment which went into healthcare system, so the data which we see, it's a combined effect in Kerala of decentralization as well as very large state investment coming back into the health sector. And I don't think you can really differentiate what improvement in health system took place because of what. But yes, Kerala health institutions, their SOPs and work culture is far, far superior to what you see in large number of states in India. That's what sustained Kerala during COVID period. The medical institutions in Kerala's, I think the work ethos and SOPs are really outstanding. That is, if you see in a medical college or a district hospital, the way the treatment is done is really very good. The systems are very functioning. So local bodies add to the funding of these institutions and lead to some improvement in their functioning. But I think it's a PHC level where the maximum improvement has happened in functioning with the local panchayats chipping in, both in terms of manpower and enthusiasm and funding. That is where the Kerala story is quite remarkable. Thank you for Mr. Vijay Anand for sharing his thoughts on this. Thank you.
Thank you very much, Mr. Joshi. I'd like to now request Mr. Rajiv Sadanandan to please present mementos to our speakers. First to Dr. Thomas Isaac. To Mr. Joshi. And to Mr. Vijay Anand. Ladies and gentlemen, I'd like to request you all gentlemen to please step forward for a photograph of the Friendship Forum, as it were. All the friends to please move forward. And as they capture that image for posterity, ladies and gentlemen, we are trying to curtail the coffee break that we have. Just 10 minutes for tea and coffee, and if you could please return so that we will be in time when the minister arrives. So tea and coffee arranged for you at the rear of the hall. Please be back here quickly. Thank you. All those standing at the back, please be seated. We're going to have the presentation soon. So on stage, we have Mr. Srikanth Vishwanathan and Dr. Raman Kutty, along with our chair, Dr. T.M. Thomas Isaac. Ladies and gentlemen, Kerala has been a leader in devolving power as well as resources to the local governments, especially in the service sector that includes health and education. In health, institutions like primary health centers, community health centers, sub-district hospitals, and district hospitals were transferred to respective tiers of local governments with transfer of assets as well as resources for planning new initiatives. Health Action by People, supported by HSTP, conducted a study to understand the impact of this policy on the health sector of Kerala. Janagara Center for Citizenship and Democracy is supporting the state government of Bihar, especially the health department and the urban development and housing departments, to facilitate the implementation of the 15th Finance Commission health grants to strengthen primary health care. And as part of this project to better understand decentralization and growing urbanization in Bihar, Janagara also undertook a study of the financial sustainability, accountability, and current capacities of ULBs in the state to manage healthcare delivery. The study also draws lessons from other ULBs in the country that have successfully led healthcare delivery for the past few decades. So I'd like to now invite Mr. Vishwanathan, Mr. Srikanth Vishwanathan, the CEO of the Janagara Center for Citizenship and Democracy, focuses on the urban sector, especially on city systems and their reforms, spanning Janagara's flagship report, the annual survey of India's city systems and municipal finance reforms. He works closely with the government and constitutional bodies to shape and implement long-term reforms to municipal finance and city governance in India. I'd like to request Mr. Vishwanathan to please share the key recommendations of the study on the role of urban local bodies in primary health care.
Thank you, Rini. Thanks to leadership by Rajiv and HSTP and to HAP for considering us as partners in this initiative. We are an organization that works on urban governance reforms and citizen participation. It's quite intimidating to be speaking to a room full of public health experts. This foray of ours into primary healthcare in cities is just over a year long. So we are still babes in the wood. But our proposition really is not to look at urban health only as urban health, but also as a governance challenge. So we are hoping that we are able to make some progress in strengthening governance of primary healthcare in India cities in a holistic place-based manner, rather than looking at it in a slightly narrower sectoral sense. So we are essentially trying to explore the intersection of city systems and health systems. That's really our endeavor. As part of the study, so I'm actually not going to focus on some of the detailed findings of the study. The study is going to be made available to all of you. It's a 190-page report, I understand. There's also an executive summary. But I'm going to focus on some of the meta recommendations and approaches that we can take to solving for primary healthcare through a governance lens. As part of the study, we looked at 22 municipal acts. We evaluated 22 municipal acts of 16 states. We looked at town and country planning acts of 10 states, state finance commission reports of 16 states, and then field studies in 9 cities of Bihar and in Bengaluru, Bhubaneswar, Chennai, and Pimpri-Chinchwad, as a combination of large cities and cities with smaller cities with interesting models in governing primary healthcare within the city. The timing we think is great because for the first time, 26,000 crores have been allocated under the Union Finance Commission grants to urban local bodies, and they've essentially suggested that this money be spent through urban local bodies. Of course, the operational guidelines issued by different states have somewhat tried to restrict the role of urban local bodies, giving greater primacy to the district and the state especially given the fairly nascent maturity of urban local bodies in the urban health domain. But we still think it's a great beginning that has been made, including highlighting the Kerala model with a fair bit of detail relating to the involvement of urban local bodies, self-help groups, RWAs, and so on by the Finance Commission. I'm going to focus on 4 key city systems which we believe underlie most areas of urban infrastructure and services, including urban primary healthcare. One is urban planning and design. The second is urban capacities and resources, essentially focusing on municipal finance, municipal staffing, and other administrative capacities. The third is political leadership at the city level. And lastly, transparency and citizen participation. We call these 4 as city systems. And we think these underlie, these are in some ways what are below the iceberg, what determine the quality and nature of service delivery in our cities, including for healthcare. Beginning with urban planning and design, like I said, we're fairly early in this journey, so please indulge me and bear with me, and of course you can go through the report and give us feedback. Town and country planning acts in India do not consider public health as a major priority. They do talk about sectoral adjacencies like water supply, sanitation, waste management, etc. But public health, primary healthcare does not lie at the heart of town and country planning acts. That's a key missing link, because the town and country planning acts of cities pretty much determine the form, shape, and future of cities over a long period of time, over a 20-year period. There are several other agendas for reforms with respect to the TCP acts, but the absence of public health as a major focus is quite problematic and needs to be fixed, particularly because, like you mentioned, Dr. Isaac, non-communicable diseases are expected to become an epidemic in our cities over the last 20 years. Hopefully we can prevent it, but the expectation is that NCDs are going to become a focus area in cities in primary healthcare, and walkable streets, open spaces, parks and playgrounds, mass transit, which can address air pollution and also create non-motorized forms of transit, will all become important for non-communicable diseases, is what I understand from public health experts as well. But currently the integration of the thinking about preventive healthcare at the city level and hyperlocal levels with the planning and design paradigm in cities currently does not exist. Therefore, this is not just about coordinating and integrating functions like water and waste management in cities with the urban health function, which is very important, but it goes beyond that, including into design of streets, making our streets walkable, ensuring that public transport in our cities is able to deal with air pollution and creates walkable and healthy cities. In fact, it's quite interesting. 10 years ago, I remember a major push towards what are called complete streets in the US was actually led by the Surgeon General of the United States. Because the public health system in the US felt that the form and shape of cities, making cities walkable and focus a lot more on NMT, what is called non-motorized transport, is an important ingredient in the fight against non-communicable diseases. The second point I want to focus on within the capacities and resources section is on municipal finance. And I feel, particularly with respect to urban health, given the variety of challenges in municipal finance that urban local bodies are already undergoing, I think the catalytic reform agenda with respect to financing of healthcare would lie in public finance systems and better management of budgets with respect to state health budgets. I understand, I'm not sure about the situation in Kerala, but in large parts of India, I think even though health allocations are fairly small, the budgetary management around health allocations and public finance systems are fairly nascent and basic. Not much work has been done in that area to ensure that the current budgets are well utilized and focused towards citizen outcomes. If there was one agenda that I think can catalyze other reforms in the short and medium terms, it would be around health financing. It would be around public finance management around health and focusing on strengthening state health budget systems and thereafter the ULB systems on health as well. With respect to municipal staffing, our study in Bhubaneswar has indicated an interesting model where for a smaller city, in a relatively smaller city, in a less urbanized state with limited capacities, they have figured out a partnership model between the health department and the urban department where specialists in health are deputed from the health department, but to work along with and under the supervision of the city management of the city. So, and that appears to be working well. And we believe that We need to innovate with respect to municipal staffing. India's cities and states do not have the fiscal headroom to fill all the vacancies that are there. And another emerging idea, which also the Finance Commission has pushed, is that of municipal shared services. Our independent study, not as part of this study, appears to suggest that 92% of India's urban population, including census towns, lives within 1 hour of 500 large cities in India. There are roughly 470 cities in India with a population of 1 lakh plus. And if you use them as a center of a circle and draw a 60-kilometer radius, assuming a travel time of 60 kilometers an hour, 92% of India's population falls within that catchment. So our approach of building capacities need to be building shared capacities, looking at municipal shared services. I do not believe we have the ability, either in terms of availability of talent or finances, to build capacities one by one in each of the 4,800 ULBs in India. So we'll have to adopt a cluster-based model, looking at spatial contiguity of urbanization. And I feel there are several savings that can come from it and efficiencies that can come out of it. The next important piece is we heard from Mr. Vijayanand about the role that elected representatives are playing in Kerala in providing leadership to primary healthcare at the local government level. This has also been appreciated by the 15th Finance Commission. This is a huge area of improvement for most of India, except Kerala perhaps. We think that there's a need for a systematic counselor leadership development program in focusing on how urban primary healthcare can be mainstreamed into at the ward level and at the hyperlocal level. There are about 87,000 odd wards in India, and we have women leadership. We have strong women's leadership at the local government level, and there is evidence that suggests that when women have powers over resource allocation, they are more likely to invest in social infrastructure rather than physical infrastructure. And we should remember that the only level of government in India where there is constitutional and statutory reservation for women is the local government level. No, it's emerging evidence, sir. Emerging evidence, but I believe JPAL has written some papers on it. I can share that separately with that. But 45% of councillors in India are women, despite the minimum reservation actually in many states being only 33%. But we have 45% representation out of the 87,000 odd councillors being women. So there's a huge opportunity for the multi-sectoral kind of approach towards human development that you had alluded to. And we feel councillor development programs in general are missing. In a study that we undertook across, I think, 14 odd cities, and we produced a report called City Leaders Report. There's a lot of latent demand among councillors for a systematic leadership development program over their 5-year tenure. That can also kind of catalyze demand for decentralization at the grassroots political level as well. While most of the municipal acts do have a provision for public health to be handled by urban local bodies. In fact, unlike several other functions, by and large, public health does find mention as one of the functions which are devolved to urban local bodies in municipal acts. However, the role of standing committees is fairly ambiguous or totally absent. So there's an opportunity and a need for standing committees to be strengthened. In cities like Chennai, we found that the elected councillors outside of Kerala are fairly hands-on and involved in primary healthcare in their respective wards. So empowering the standing committee is another important aspect. We know that Rogi Kalyan Samitis and Mahila Arogya Samitis are working probably in parts, working well in parts with depending on who are the partners working in those ULBs and the leadership of the ULB. But one thing we are noticing is a fragmentation of citizen participation without having political or place-based platforms, except in the case of Kerala and now increasingly in Odisha, where they have a somewhat analogous program in Jaga Mission, not exactly on the same design as Kutumbashri, but a slightly differently designed program, but a statewide program for citizen participation involving women self-help groups at scale across cities, and also slum dwellers associations in 3,000 odd settlements. In most other states, there are no place-based, community-based platforms which are integrated. We are creating independent sectoral platforms. So for health, you will have Rogi Kalyan Samiti and Mahila Arogya Samiti. Now for sanitation, you will have different platforms. For water, you're likely to have separate platforms and so on, which is not feasible or desirable. In fact, the Kerala model of ensuring that the Kudumbashri groups have a mainstream role in ward development is, I think, key. I've been issued summons by Rini. So I just want to close by saying, focusing on healthy cities in an integrated, holistic manner And looking at the intersection of city systems and health systems would be critical to the future of India's cities. We look forward to your feedback and engagement, including on our report, but also other aspects over the next 2 days. Thank you.
Thank you, and I'm sorry that I had to curtail you a bit because the Honourable Minister is on his way, and we were hoping that we'll finish with this session before he comes in. So I'd like to just quickly introduce Dr. V. Ramankutti, who spent a major part of his working life in research and teaching in public health. His research is mainly centered around the epidemiology, economics and policy relating to the growing importance of non-communicable diseases among Kerala's population. He was instrumental in setting up the Achyuta Menon Center for Health Science Studies, a public health research institute. And before this, public health was considered a subspecialty of medicine in most universities in India. Mr. Ramankutti is one of the founders of Health Action by People and its current chairperson. I'd like to invite him now to please present to us the study on key recommendations of the study.
Yeah. Whichever. Huh? No, I can't. I mean, I'm just for my own. In the interest of time, I'll try to be very brief because these are the distillations from our study, the report of which is being presented today, and it will be available for free download as soon as possible, and an executive summary will be shared to all the participants. These are recommendations mainly pertaining to Kerala. We recommend that the working groups for health at the panchayat level, the local government level, should be strengthened. It used to be very strong at the initial levels of starting of decentralization process in Kerala. But now I think we have fallen back on that. So we need to strengthen the local expertise available and strengthen the database on health using all the available data at the local and state level in the electronic format. Have a 5-year perspective plan for health rather than going from year to year, because to coincide with the planning cycle, which again was the initial idea, but now I think we have fallen back on that. And another important thing is incorporate social determinants into the planning. So we don't usually, we plan very technically, for each objective, whatever. But we have to, what emerged from the study is that the social determinants are very important at determining the health status. So try for projects which will reduce inequality, bring in inclusiveness, etc. So integrate central, state and local health plans towards the common objectives. Practice multi-level planning, which already has been mentioned by Mr. Vijayanand, and serious rethinking on reforming the urban health system, which seems to be the weakest link in the local planning process, especially in health, because they are totally ineffective. So we have some learnings for the rest of India also. We can, I think the states can follow the Kerala model in participated planning at the local level, and wellness centers to be brought under the overall supervision of the primary, the Gram Panchayats, and utilize the self-help groups more effectively. Resource allocation should be increased for health, which is very important across the board. Capacity building training for Panchayat members is very important, which we have done in Kerala, but I think it should have an all India span. That is, everybody, all the local politicians should be trained in development planning, and the campaign to launch participatory planning should be, it's in a campaign mode, and rather than being a routine activity of the government, it should become a very important campaign of the local governments. I think that's all that we have. As I said before, the whole report will be made available, and we also will have another session discussing the study in the afternoon. So for the I think for the time being, these are the main recommendations which I am putting before this audience. Thank you.
There couldn't have been more perfect timing by the Honorable Minister. Ladies and gentlemen, we are joined by the Honorable Union Minister for Housing and Urban Affairs, Dr. Hardeep Singh Puri. We heard Dr. Raman Kuti present his study on decentralization and local decision making in health, the Kerala experience. We have with us now the Honorable Minister. So I'd like to request the CEO of Health Systems Transformation Platform, Mr. Rajiv Sadanandan, to please make a brief introduction about the two-day seminar for the Honorable Minister.
Thank you, Rene. First of all, thank you very much, sir, for putting us in your very extremely busy schedule. These are two studies independently carried out, which looks at the impact of decentralization on health sector. So one looks at Kerala's experience starting from 1996 till now. Mostly the emphasis has been on the rural side. And along with that, we have Janagraha, who looked at the impact on health in the urban area after the Finance Commission's devolution that happened. In the process, we also took a look at the impact of or the objectives of the 73rd and 74th Amendment, the extent to which it's been carried out, the political process that went into it, and finally, the impact of this has happened. So we just had these 2 days are going to be a presentation on the results of these two studies, sir. May I invite you to, Rene? Yeah? Release them, yeah. Sir?
So as I had mentioned earlier, the method and impact of decentralization on primary healthcare has been studied extensively, and we now have the reports here for release. The first report, the Health Action by People and Health Systems Transformation Platform, studied the impact of decentralization of health administration in Kerala to rural and urban local governments. Dr. Raman Kuti, if I could request you to please come closer for the photograph with the Honorable Minister. Yes, they will get, sir. There are copies, sir. Yeah. Janagra conducted a qualitative study titled Role of Urban Local Bodies in Primary Healthcare, covering the current roles of urban governments, locating them in their evolution of progressive roles in health, and developed recommendations on the intersection. Mr. Srikanth Vishwanathan, CEO, Janagra Center for Citizenship and Democracy, with the report and the Honorable Minister releasing this now. We have copies of the two reports available at the registration desk outside for all of you to collect later. Thank you very much, Mr. Minister, sir. May I request Mr. Hardeep Singh Puri, who's had a distinguished 4-decade career in diplomacy, spanning the bilateral and multilateral arena, having held ambassadorial posts in London, Brasilia, and as India's permanent representative to the United Nations in both Geneva and New York, to please say a few words now.
Dr. Thomas Isaac, my friend Srikanth, Mr. Rajiv Sadanandan ji, Mr. Dr. Raman Kuti ji, friends, ladies and gentlemen. A question that I'm often asked, and to which I frankly don't have the answer, is that what is it that will ultimately determine in terms of sensitivity, quality of life that makes us truly a developed country. One is an easy explanation. The explanation could be that, when our GDP reaches levels which are characterized by the GDPs of what are now called developed countries. But that may also not be the answer, because you have countries like the People's Republic of China, which has a GDP today, I think, of $12 trillion. But I think there are aspects to that society which don't answer the developed sensitivity, ease of living, a number of criteria. My submission to you is that at the end of the day, the two areas where, we will be a Viksit Desh, as the Honorable Prime Minister says, by 2047 or way before that, because of the rate at which our GDP is growing. But I think even before that, what will make a qualitative difference are two areas. One, I think, if I submit, because this is a highly professional group of participants who are domain experts, and in over 2 days they will deliberate on these. One is education and the other, I think, is healthcare. And on healthcare, I think the fact that you are looking at healthcare today, both in terms of the rural and the urban. Now, if you look at globally, I have had the privilege of working about 39 years in the Foreign Service, then 5-6 years thereafter in related fields. I've traveled the world over. And some of the best healthcare systems have not come from countries which are highly industrialized, as it were. And I'm in a professional audience, so I don't want to say anything which may be politically misunderstood. I lived for a while in a country where I was posted not too long back, where the National Health Scheme appeared very good, but the fault lines in the National Health Schemes were visible for everyone to see. And today that particular country, we overtook them to become the 5th largest economy a little while ago. They want to tie up with our healthcare systems for, quality aspects in terms of knee operations, instead of a number of others. You could go into that area, people want to come here. But where we are doing very well, I think, and I want to come back to the experience of the last 2 years, is we have to universalize that within the country, both in terms of rural and urban. There's another country I worked in where the healthcare is supposed to, in terms of very high degrees and level of medical science, cutting edge on everything, whether it's in the pharmaceutical sector or in terms of the kind of hospitalization, etc. But the diagnostic skills are, I think, not up to the level of which the reputation of the system is there. What did we do during the last 2 years? We touted a lot of models as very successful, but when the pandemic hit us, and I want to make this submission to you, 2 or 3 realizations we faced straight away. One is that the vaccine manufacturing capacity which existed in the public sector in India had been dismantled before the pandemic hit us. It was dismantled within a period. Again, I'm not making a political point. I think it was a very serious mistake. Because if you have a facility in the public sector, you have a slightly better chance of dealing with it. This is my submission in the case of the vaccine manufacturing. I was Civil Aviation Minister then. We brought in 1,500 tons of medical supplies from outside. We flew 947 metric tons of supplies within the country. The Honorable Prime Minister, I think, took a number of very decisive steps. Some of our political opponents were saying, why are we expediting some clinical trials in one particular vaccine manufacturer? I wish they had known the facts. Because what would you have done then? You have to accelerate. We're not saying do away with the clinical trials. So we had two manufacturers, one vaccine manufacturer in the private sector based on research done at Oxford University and by AstraZeneca, if I remember correctly, a licensed manufacturer here, and another purely indigenous manufacturer. And today you can look back at that period, 220 crores or upwards of vaccines were produced and distributed free of cost. Not only here, we sent them to other countries in the world. I don't want to go into long achievement, but that is what distinguishes a system which is functioning from other systems which ostensibly are well organized and not functioning. Now, decentralization. When my friend Shrikant asked me to participate here, I asked him, seriously, do you think I have a role in this discussion? And I meant it. But then when he explained to me, and when two of his colleagues explained to me, I said, no, I think there is a very strong possibility that we may do some... Look, when we did some research, we found it was the British physician John Snow who is credited by being the world's first modern world's first urban planner. And he undertook geographic mapping to locate the sources of a cholera outbreak in the city of London and identified public water as the outbreak source, eventually leading him to the water pump that had circulated the bacteria. This led him and others to devise norms and safety standards that became the precursors to what we know today as the discipline of urban planning. Now, it seems very easy. But if you have an experience like that of India, which in 1947 had what, 17% of its population out of a base of 350 million, which was so-called urban. The rest of India lived in rural areas. I think the predominant focus of our planning, both at the policy level and at the political level, was on rural India. I think Mahatma Gandhi thought and genuinely believed salvation would come from there. Many of us still think that that's where the answer lies. But in any case, what governments up to 2014 had done, and this I say with a sense of responsibility because I have the figures, they ignored the urban space. My colleague Shashi and I, when we start doing the numbers, we come to a very interesting conclusion. The entire urban spend in the 10 years between 2004 and 14 was 1,57,000 crores in 10 years. Along came Mr. Modi, first realization the urban space had been neglected. He's too polite. I'm a little more blunt. It was criminal neglect of the urban space. The urbanization that took place was autonomous. These were autonomous, robust demographic shifts from the rural areas to tier 2 and tier 3 cities to semi-urban, from semi-urban to urban areas. Cities were growing and sprawling. But where was the central fix on that? Anyway, we got started much before my time. So I came on the scene only in 2017. In 2015, all the urban schemes or the flagship mission started. Today, again, I have to check myself. The expenditure as against the 10 years of 1,57,000 crores is about 18 lakh crores. Where 1,57,000 crores in 10 years, here in 8 years, it is 18 lakh crores. But this is just the beginning. I mean, I cited this gentleman who traced the cholera outbreak onto the thing. What is the focus of this? Swachhata, Swachh Bharat Mission, Amrut. And you know, I don't want to go into the details. I think the success of the Swachhata mission is that from a policy of the government, it has become a Jan Andolan or a people's movement. And as a person who served in different countries, I've always believed that when a government scheme can be embraced by the people. So the answer to that is not just in the amount of allocation you do. The allocation we have done for Swachh Bharat Mission 2.0 and Amrut 2.0, which deals with water tap connections, sewage treatment, etc., is a whopping 4,71,000 crores. The these problems today, if you are able to walk around, I don't see a single mask here. And our airports are full, the airports are back to right. It's something we got right in the healthcare sector. I just make that submission to you with all humility. But we need to go down to the decentralized level. And that's where the 15th Finance Commission comes in. I have some statistics here, which I shall find. Yeah. The allocation of over 70,000 crore rupees under the 15th Finance Commission to local governments presents a massive opportunity to reform urban service delivery in previously underfunded municipal functions such as primary healthcare. And the Pradhan Mantri Ayushman Bharat Health Infrastructure Mission has allocated over 19,000 crores to local governments. I'm just citing an example. I don't think cutting-edge progress at the grassroots level comes from government allocation. But I think government allocation, whether it's the experience of Kerala or anywhere else, is absolutely necessary. Now we are looking at green hydrogen as a fuel of the future. There's billions of dollars of global finance which will follow that. But at the end of the day, the government, through a cabinet decision, allocated 19,000 crores, 19,700 crores for the manufacture of electrolyzers under the PLI scheme. I am very pleased to find that whilst we are doing well, we should not remember that even very recently as 1994, we had a plague in Surat. And as we move forward, the pandemic has certainly revived the debate around densification versus urban sprawl. If we can, thanks to these studies, I must confess I've not read the studies, but I will, I can assure you on that. If we can lend through academia, through research institutes, through these two organizations on which I was reading this morning, a helping hand which not only helps resolve the issue, but which will act as a catalyst. Today I'm told that these studies I've launched demonstrate successful models of decentralized healthcare across Kerala, Karnataka, Tamil Nadu, Maharashtra, Odisha and Bihar. You know, if it succeeds there, I can only name one or two other places where you need to take this and you've got an overall success on your hand. So I'm sorry, I probably spoken longer than I had intended to. I told my friend Shrikant that I don't know whether I'll have anything useful to say, but he insisted on inviting me, and I think from my point of view it's been useful. I would have liked to show up here after your 2 days of deliberation so that I can hear from you what transpired during the 2 days. But I have no doubt, looking at the young and, if I may use the word, and even at the intense people, that everybody is dying to, make a contribution to that. So thank you very much, and I wish the deliberations all the very best. Thank you.
Thank you very much, Mr. Purisa, for having shared your thoughts as well as releasing those two reports that we have. I'd like to now request Mr. Rajiv Sadanandan, the CEO of HSTP, to please present mementos to our esteemed guests. And we'd like to start with the Honorable Minister, Mr. Hardeep Puri. To Dr. V. Raman Kutty. And to Mr. Shrikant Vishwanathan. Thank you very much. I'd like to now call upon Dr. Rahul Reddy, National Coordinator, HSTP, to please give the vote of thanks.
Thank you, sir, and thank you, everyone. Honorable Union Minister of Housing and Urban Affairs, Shri Hardeep Singh Puri ji, for obliging our request and being here. Your keynote address, sir, highlights the importance of role of decentralization in development journey of India in Amrit Kal. More so, the role of local governments play in enabling an ecosystem for growth trajectory in the health system of this country. The research reports launched today shine light on the way forward for local decision making and planning for health services in rural and urban areas. Thank you very much for bringing focus on this issue with your presence here and motivating us to work together as we progress. Thank you very much, and we close this inaugural session. Yeah.
So if I could request you to please just pose for a photograph. Thank you very much, ladies and gentlemen. Thank you to the Honorable Minister for attending the inaugural ceremony of this two-day conference. Kindly remain in your places until our chief guest has left the hall. We will continue with the proceedings. Yes. Right, sir. Thank you so much, sir. Thank you. Thank you, sir. Yes. We will continue with the proceedings as soon as we've made the stage ready. We'll start our session on decentralization journey of 3 cities. Dr. K.V. Trilok Chandra, Ms. Astha Joshi, Dr. Lakshman Gophane, Dr. Balasundar, and Dr. Jagadishan. Please come up. So welcome, ladies and gentlemen, to the session that looks closely at the decentralization journey of 3 cities, Bengaluru, Chennai, and Pimpri Chinchwad. Chairing this session is Dr. K.V. Trilok Chandra, the Special Commissioner of Health, as well as the Zonal Commissioner for the Mahadevpura zone at the Bruhat Bengaluru Mahanagara Palike. He oversees BBMP's health department and its public health initiatives and has been instrumental in the launch of Namma clinics in Bengaluru. Dr. Chandra is from the Karnataka cadre of the IAS and has held several important positions in the state before being appointed as Special Commissioner of BBMP. Before we move into the panel discussion, we have with us Ms. Astha Joshi, Associate Manager, Janagra Center for Citizenship and Democracy. She's a part of the State Program Management Unit for implementing the 15th Finance Commission reforms in urban healthcare in Bihar. She has previously worked with Wipro Technologies and across India and other countries in the Asia-Pacific region. Astha will first share the study of decentralization in 3 cities, and then we will introduce our speakers in the panel. Astha?
I hope everyone is having a pleasant day. A lovely good afternoon to all our guests. My name is Astha Joshi, and I'm currently working as an Associate Manager for Public Healthcare Reforms Team Janagra. So I'm here to take you through the findings we explored during our study, which was released a few minutes back. So these findings were on the basis of the cities who are leading in service delivery and community engagement in urban primary healthcare. So we are going to look into 3 cities basically. First is Bangalore, Chennai and Pimpri-Chinchwad. So let's have a look into a little bit of the background. As we all know that India is rapidly growing, urbanization is at its pace, and we are currently 469.3 million people who are basically living in the urban agglomerations of the country. Also, we are supposed to be 50% urbanized in the year 2050. So, as we all know that 74th Constitutional Amendment Act of 1992 laid the framework for the urban governance in India, and also public health was listed as one of the 18 items in the 12th schedule of the Constitution. Then we also have this Model Municipal Law of 2003, which has categorized a lot of components of the public health into its different categorization, like other functions or core functions, and also additional functions. Then our Janagra study on the role of urban local bodies in primary healthcare, we tried to establish an integrative approach where we believe in strengthening urban local bodies in providing primary healthcare to ensure that last mile connectivity at the grassroots level. So a little bit about the brief of the 3 cities which we are going to discuss in our subsequent slides. Chennai, we all know, one of the oldest municipal corporations in India, and they serve around 11.50 million population, divided into 140 wards with 140 UPHCs running in the city's ambit. Then we have Bangalore, also shares a long history of municipal governance, and they are divided into around 198 wards with 170 UPHCs running in the ambit of the BBMP. Pimpri-Chinchwad is little new to the game, and as they got recognition in 1982, currently they are divided into 128 wards with 21 UPHCs running in the ambit of the PCMC. So this slide in the health governance at city level tries to capture the governance from the health's perspective, from the health's point of view. So in all the 3 cities, a commissioner level officer leads the health portfolio, and each of the 3 ULBs have verticals within the health department which are categorized into clinical service delivery, and other is focusing on the public health deliverables. Then health management is decentralized to the zonal level, where a zonal or a deputy commissioner and a deputy health officer takes care of the health. The infrastructure management, procurement, disbursement, reporting, and to some extent the financial powers are delegated to this level. Also, the cities have City Program Management Unit, which is funded under the corpus of NUHM, and they usually consist of city accounts officer, accounts assistant, M&E officers, data entry operators, and they all are funded from the source of the NUHM corpus. So moving on to the financial component, so mostly the financial resources come from ULB's own corpus, NUHM, and central sector and state level schemes which are being implemented at that point of time. Although BBMP, apart from paying salary, they also make provisions in the budget for the purchase of drugs in case of any emergency. Then PCMC, other than the corpus, they also collect some user fee for the health services that goes directly into the PCMC corpus to a large extent. Then I'll move to the few So we'll move into the city-specific components a little bit. Okay. Yeah. So in Bangalore, ward level committees are functioning effectively. Bangalore ward level committees are functioning effectively, where health is like one of the key agendas. And also we saw this collaboration between the ward level committees, resident welfare associations and people at the grassroots level, where they managed to pass information very quickly in the times of COVID. So they played as an asset during this pandemic time for passing the information and guidelines on a quick basis. BBMP has also effectively used public-private partnership, and they have partnered with many of the corporates where they have got this funding for renovation and infrastructure management in some of the selected UPHCs. Then GCC, they have this standing committee for various matters in which the health is being one of the mandate. And Tamil Nadu also has this medical recruitment board where the recruitees and deputies, they requisite for the staff, and this ensures the transparency in the staffing and recruitment manner. So this operational model for ULB slide is basically a holistic view of what we discussed in like the previous slides. Only two additional points I would like to discuss. First is that they have a centralized procurement of pharmacy and consumables at state level. Also, they have this concept of polyclinics at the selected UPHCs. So they render the kind of specialist services depending upon that particular UPHC, and that too on a roster basis, where they hire private specialists to provide that particular services at fixed fee per day basis. So this was something unique. Then again, the resource pooling, the kind of corpus they get, and the planning, budgeting, drawdown, disbursement, and utilizations, they are particularly reported by ULBs from time to time. Now I'll go a little bit on city basis, because we are talking about these three cities specifically. So in Chennai, lady medical officers are trained to conduct ultrasonographies. Then urban health nurses, they create RHCID for all the pregnant women, and they try to embed them on the PICME app. So this ensures to track the whole cycle of that particular women in a one go. Then they do have a cadre of community volunteers, and they are created, equipped, and they are trained to screen the patient coming for non-communicable diseases. Also, they have organized this self-help groups, which are now acting as a Mahila Arogya Samiti. So this gives an edge to the people who are already the part of system to do something new, where they exactly know about the system, what is going on. Then BBMP, they have a very well functioning Janarogya Samiti, and they usually meet once in a month. Then they do list this important list of information in every facility, and these informations are like the list of governing people, the list of staff they have, the list of drugs available, the list of diagnostic tests that are available in that particular PHC, to ease the thing for patient when they come, and it increases the transparency and increases the accountability at the administrative level. And PCMC has this feature of facility-based screening for NCDs and primary level care for hypertension and diabetes at UPHC for the people who are aged about 30 or 30 years of age. Then they do have urban PHCs delivering the services as per the CPHC guidelines. This is our final slide where we talk about the key takeaways. So the planning of health infrastructure and services is done in Bangalore on the basis of the projected population of 2030, and also the geographical expansion of the urban agglomerations are taken into consideration while planning. And Bangalore, they issued an executive order in 2007 to prioritize the public health delivery in the ambit of the BBMP. Then Chennai, as we have discussed, they have a separate cadre of human resources for GCC, and health is like one of the key mandate when it comes to the standing committee's agenda. And also elected representatives have active involvement, and they work as a quick interface between the administration and the people at ground level. Then Pimpri Chinchwad, they have shifted their focus from MCH services and some vector control activities to holistic healthcare services. They are starting this household-based population enumeration, where they are also going to use this data for implementing the other social sector schemes. Also, in the era of digitization, PCMC plans to digitize all the healthcare records. Also, they are planning to have this household-based mapping where they can have this patient mapping on the basis of that particular area. So this is from our side. Thank you everyone, and we have an interesting panel and chairmanship to talk and deep dive into the context. So I will request our moderator to proceed with the same. Thank you.
Thank you very much, Asta, for really fast-forwarding the presentation. I'd like to now introduce our panelists to you. Dr. Lakshman Gopane leads the Department of Health for the Pimpri-Chinchwad Municipal Corporation. He has also been instrumental in responding to the exigencies of the COVID-19 pandemic in the Pimpri-Chinchwad region, earning the distinction of establishing one of the first COVID care hospitals in India. Dr. Balasundar is an anesthesiologist and chief health officer of the Bruhat Bengaluru Mahanagar Palike. He has served as a medical officer and the district health officer and zonal health officer of the BBMP. Dr. Jagadishan is a medical doctor who began his career by teaching community medicine. He moved on to work with the Center for Disease Control and Prevention, Chennai, and contributed to expanding their HIV/AIDS program. He has also worked with UNICEF as a health specialist and is credited with developing and designing healthcare systems at the Greater Chennai Corporation. At the end of the panel discussion, if we have time and the chair permits, we will have a few questions from the audience. I'd like to now request Dr. Chandra to please set the tone for the discussion and then invite the speakers by turn. Thank you. You'll speak first, no? Sorry, what did you say? We can give them a cordless mic, but they've got they might want to speak from here. I mean, we can leave it to them. Yeah. For the panel discussion, we'll have it here.
Good afternoon, ladies and gentlemen. It's my proud privilege to be chairing this session on the experiences and the success stories in decentralization of healthcare. As Martin Luther King Jr. said, of all forms of inequality, I think injustice in health would be the most shocking and inhumane. And though the World Health Organization envisages health as not just merely absence of disease, but a complete state of physical, mental, and social well-being. But from the public health perspective, what we are focusing right now is only on the absence of disease. I think as a society, as the Honorable Minister was saying, as we move upwards in the trajectory of, in the journey of becoming a developed nation, the qualitative aspect of health also becomes very, very crucial. And the top-down approach, which most of the cities and the states follow, I think that will be a far-fetched idea that a top-down approach would able to meet that goal of a healthy society as such. Though the 74th Amendment provides for public health as one of the crucial duties of the local body, it is quite interesting to note that most of the urban local bodies are not devolved with that responsibility. That is the first aspect. And even if they are devolved, they are if I'm allowed to use the word, they are forced to depend on the state resources for their even basic functioning of the public health services. That creates kind of a dependency syndrome, and also the kind of synergies or the innovations which our honorable panelists in the morning inaugural session envisaged, that curbs their instinct and also the innovations which are very, very crucial for public health delivery. So as the Ms. Astha had presented, the three municipalities which have been the torchbearers in the success stories in decentralization of public health care, I think the most important thing which I would like the panelists to focus on is, apart from their brief introduction on their success stories, but also it would be very important as to how much percentage of their budget they're using for public health delivery. That is very important. That is one part. Second is how much is the state government assisting them in their public health delivery, what is the kind of financial devolution which is coming forth, and also the what is the level of local citizen involvement in formulating the policies or the programs. And also particularly I would like to dwell on Namma Clinic, which we launched this month in Bangalore. We have totally 243 wards in Bangalore. As of in the first stage, we have launched 108 Namma clinics in the 108 wards. It is more of a mini public health center which has been developed in the in a particular ward with all the basic diagnostic and drug delivery, and which we hope to make it into a model healthcare system in particular every ward, apart from the public health center which is there. So, given this perspective, I would request each of these panelists to dwell on these, and then we would take specific issues based on their initial discussions. Thank you.
Good afternoon. I am Dr. Lakshman Gofne from Pimpri-Chinchwad Municipal Corporation. We are having a basically a supervised by the municipal commissioner, and under his medical officer of health downstairs, we are having one super specialty hospitals, 7 other multi-speciality hospitals, and 29 different types of dispensaries, which was the UPHs. Last 1 year, we new initiation we are taking, that we are made a Jizao clinic, which was like a mohalla. But the mohalla clinic in Delhi, which was only the curative stage, we are making it as a both way, curative as well as both the prophylactic, means all the national programs are functioning in the Jizao clinic, which has taken place in the small cities, small places where the dense population, slums, and slum-like population, which are made. Now the 10 are in under construction, started within 2 to 3 months of age. Basically, Pimpri-Chinchwad is like nearby the Pune and the new city, around 27 lakh populations. And we do a 4-tier system of primary, secondary, and tertiary care, in which the primary level we are having this Jizao clinic and UPSCs, which was 29 UPSC, and above level is of secondary multi-speciality care. We are having 4 multi-speciality hospitals, and 3 are maternity homes. And above level, actually, we are having a tertiary PG postgraduate institute of a 750-bedded Yashwantrao Chavan Smriti Rugnalaya, that was in the Pimpri YCM hospitals. And sir, as sir is saying that our budget, which was total budget of around 5,000 crores, in which more than 7 to 8%, that is around 400 crores, which was budget given by the municipal corporation. All these are services given by the corporation only. State government only only NHM, which was 15 crores fund are given by the state government. Sir. Slight new initiative which has taken by the Pimpri-Chinchwad municipal corporation to go the base level, that also we are giving the services like a cardiac care center, which is our PPP model. We are giving the space to the any agencies, and started this model. And cardiac care unit, which is made at PG Institute level at YCMH Pimpri-Chinchwad, they are well functioning since last 7 to 8 years. Also, on PPP model, we are giving by estimated rate, small rate by MRI and CT scan services. We are functioning of separate 50-bedded eye hospitals, which are having a specialty and super specialty services of eye. Also, we are proposed of new cancer hospital, which are under construction. Also, the one of the new initiative, that is all the facilities which are there in Pimpri-Chinchwad Municipal Corporation, we can make it at digitalization. We start functioning that also. Under some days, we already do. we do courses start in our hospital like DNB, CPS, all these are. The HR concern is more probably a big issue in Pimpri-Chinchwad. That HR we are taking regular basis, only the 1,000 HR is there, which are the regular, but outsource basis, we take around 2,000, 2,050, 2,500 new HR is taken, in which the medical and paramedical staffs is there, outsource housekeeping is there, and all other services which are given by the PCMC, that is registration, birth and death registration, marriage registration, as also the biomedical agent. Thank you very much.
Good afternoon to all of you. Ma'am, a small correction, ma'am. Ma'am, a small correction, ma'am. But it's very important. You said I'm an anesthesiologist, and they must be wondering why anesthesiology is there in a public health conference. I have done public health also from Kolkata, from All India Institute of Hygiene and Public Health. Okay, basically I'm a public health cadre officer in BBMP. First point I would like to say is that BBMP has a separate cadre and recruitment rules for health department, and all the officers who get promoted from general duty medical officer post to the highest level or should be, I mean, it's the essential qualification is that they are public health qualified. So I don't think even state government of Karnataka has it, because many clinical side people are there. So essential qualification to become an officer in public health department in BBMP is public health post graduation. That's very important. So all the health programs and all other public health activities, primary health care delivery systems are supervised by qualified people. First of all, I would like to say one important thing, that the public health department of BBMP, the main responsibility was solid waste management. So most of the officers and their time was involved in solid waste management. Every day go in the morning, see whether the road are swept, solid waste is collected from houses. So that was the thing. The basic, the name of the department is public health, and the public health services were not delivered because of the responsibility of solid waste management. So in 2009, there was a remarkable and a wonderful, great decision was taken by the then commissioner to withdraw the responsibility of the solid waste manager from public health department and create a separate solid waste management cell. So that was a very good decision, and then after the decision, executive order was passed, and the clear functions of the public health department was drafted, and all level officers were given different responsibility in public health only. So then our work started with real public health, and all officers started dedicating their full time to public health, like primary health care services, all laboratory diagnostic services were improved. So this decision helped in smooth implementation of urban health mission during 2014. Before 2009, we had only around we had 140 UPHCs, and all our urban primary health centers are the local body institutions. We don't have any state government run institutions in BBMP for primary health care. So after NUHM was implemented, we had mainly the problem of HR, because in our C&R rules, the sanctioned posts for medical officers, the staff nurse and the different paramedical staff was less. So we moved a proposal to amend the C&R rules in 2015 so that new permanent posts are created. So until that time, so we had taken the HR from Urban Health Mission, and we started laboratories in all primary health centers. We presently have 240 BBMP till 2022. It was only 198 wards. Now after delimitation, it has become 243 wards. With a vision of making one UPHC to each ward, presently we have 140, so we have, government has given grants this time of up to 123 crores to have new setup. So we are coming up with around 40 UPHCs in next 2-3 months, and we have also proposed in this present budget to give us provision for 50 crores for another 63 UPHCs. Hopefully, in another 1 or 2 years, all wards of BBMP will have one UPHCs. And as sir was saying, we also, with the help of 15 Finance Commission funds, 243 Namma clinics have been started in BB. I mean, it's approved, and we have already started 108 Namma clinics which are running successfully. It was opened on 7th of February this month, and probably 20-day-old Namma clinics. Today also I read in newspaper in Deccan Herald that it is a success story, and our Honorable Chief Minister has I mean, ordered to open all other remaining also. So these Namma clinics will be like a sub-center level. The only Bangalore, what was it, I mean, it was missing was that the sub-center level concept was not there in the city. We had primary health care, we have secondary health care, we have tertiary health care. But as in rural areas, sub-center level concept was not there in Bangalore. And with the introduction of these Namma clinics, they serve for 10 to 15,000 or 15 to 20,000 population. They will help, I mean, easily accessible, approachable. Hope this Namma clinics becomes a big success story for us, because in the sub-center in the rural areas, it's manned by a paramedical worker. But in Bangalore, we have given one MBBS full-time medical officer with a staff nurse and a lab technician. We were asked to take office assistant, but we took lab technician because we wanted to start laboratory services also. So we have made provision to procure different reagents for 14 rapid tests, like malaria rapid test, dengue rapid test, GRBS stripes, urine 8 parameter tests. Like that, we have 14 different tests which are readily done at the Namma clinic level. Yes, sir. So we also have 6 referral laboratories, high-tech laboratories at the 6 referral hospitals. So we have hub and spoke model of like collection of samples from the UPHCs and taking to the mapped referral hospitals, so that many tests to secondary to tertiary level tests are also done. So we are also coming up, with a proposal to create one Bangalore health system, which is a new innovation wherein all primary, secondary and tertiary care will also be brought under one head of municipal corporation. That is our chief commissioner, sir. So it is still under review. Hopefully that also comes, and the whole Bangalore city health system will be with one supervision and one administration, so that we will be able to track the patient who is referred from primary health to the tertiary care. For example, he goes for a orthopedic surgery and comes back to the primary health central. We can give the physiotherapy services and other yoga activities and other things. So that will help us to track the patient. So with these remarks, I would like to thank you all.
Respected Chairperson, dignitaries on the dais and off the dais. Good afternoon to all. So I am Dr. Jagadishan from Chennai Corporation. So I will touch upon a few points about Greater Chennai Corporation. Thank you also for a briefing about Chennai Corporation. So we have a separate act by Chennai City Municipal Corporation Act, which is one of the oldest acts. So health officer post, one of the earliest posts created by the act. So this is from 1880s. So that's why we enjoy the independence of corporation, wherein about all the functionalities, about our expansion of health facilities, addition of health facility, health services, kind of thing. So earlier we used to have a dispensary kind of set, then IPPY came, then they established a health post and emergency health obstetric units. Then we got NUHM, which reorganized all the systems. We brought into single system kind of thing, urban primary health centers, urban community health centers, and so on. So this is how our overall period of time, our health system transformed over a period of a thing. And we also have exclusively a communicable disease hospital wherein it helps us for all the pandemics, all the outbreaks kind of thing, where we treat all the communicable disease hospitals. With respect to involvement of local bodies, so we have a mayor and council. Below that we have a standing committee health, which deals exclusively for health and solid waste management. Then we have zonal committees and go on. With respect to same hierarchy follow setup, our commissioner and we have additional commissioner health, then city health officer at the headquarters level, then we have zonal health officer at the zonal level, and below that we have other paramedics and other medical staff. We have primary health centers and go on. So same hierarchy continues from the headquarters to the zonal level so that it's easy to follow it up. And with respect to manpower, manpower is mostly recruited by the Greater Chennai Corporation because it has got an independent thing. But manpower sanction, number of manpower to be sanctioned is with the state government. So state government allows number of people to be sanctioned. Accordingly, the Greater Chennai Corporation recruits with the help of other staff. And similarly, with respect to finance, so whatever additional services we want to create. For example, during the COVID period, we wanted to establish an RT-PCR lab. The RT-PCR lab was established with the GCC funds. Then we wanted to give auto analysis a laboratory the laboratory capacity enhancement. So the laboratory capacity enhancement done by the GCC funds. So the GCC has got a lot of financial autonomy so that we can, whatever facility we want to expand, we can always expand with the GCC funds. Whenever the policy direction happens, we will get it from the government. So we get a clear guidance from the government, so whether it is NHM or directorates. So Tamil Nadu has got 3 directorates. Importantly, we have a Director of Medical Education, Director of Medical Services, which handles the secondary health care, and we have Director of Public Health. So Director of Public Health handles the primary health care. So we get a close guidelines and cooperation from the Directorate of Public Health so that they people guide us what are the primary health care activities should be happened. So all the policy guidelines we get it from the Directorate of Public Health, and implementation entirely goes with the corporation. So this is how we get it up. So in other ancillary services, we have 6 diagnostic centers. We have other facilities to diagnose all the super specialty tests, and also we have 8 dialysis centers. So these dialysis centers are functioning in the primary health centers or our community health centers. So we have 8 dialysis centers working for the under a PPP mode. We are working it out. And next one is about the 15th Finance Commission funds. So here under the 15th Finance Commission, we established 140 urban health and wellness centers. So most important thingly, the location and siting functioning are being decided by the local councillors. So these councillors identify the place where we need to establish centers. Accordingly, the centers have been built, and now they are in the process of implementation or functioning now. So this is the broad overview of Chennai Corporation, how it functions about. So we have 140 urban primary health centers, 16 urban community health centers, 3 maternity hospitals, 1 communicable disease hospital, and the functioning is overall supervised by the zonal health officers and other paramedicals. In addition to that, our councillors, our standing committee also supports us. So I just want to brief you about what is things. When a discussion comes, we'll detail it more. Thank you so much.
Thank you all the panelists. I would like to understand particularly from Dr. Lakshman Gofne, the model PHCs which you have established. What are the ingredients of that? What are the processes you have followed? And also particularly the tech initiatives you have taken. I think if you can elaborate on that, it will be useful.
So basically, model PSC which are grown in PCMC, they are all funds are generated by the PCMC only. Where make 1 medical officer, 1 staff nurse, 1 pharmacist, paramedical staff, and along with their field staff, ANM, ASHA, they are along with the area which was there in 5,000 people, 1 ASHA, and 1 PHC is 1. That was a dispensary we called in PCMC. Now it is of UPSC. That was generated around 5,000 to 10,000 population. All areas, ASHA, Anganwadi, all are connected with the UPSC. These are the structure we have generated in PCB.
Dr. Balsundar, I would like to understand from you what are the challenges you're facing with respect to the number of last mile workers or the grassroots workers we have, and also the synergy which you are trying to establish between the recently established Namma clinics and also the existing urban primary health centers.
Sir, the grassroots level workers in our city corporation or these ASHA workers, and we have a set of male health workers provided by state government, sir. And ASHA workers are provided by Government of India. So we are trying to, like presently we have around 1,000 plus ASHAs, but for the city population we may require up to 5,000. So we are in the process of giving a proposal to the government to approve another 3,000 ASHAs, so that it is not that only the poor should get the services. We also want the middle class and upper middle class people also to get the services. So we are in the process of that, sir. And even in our C&R rules, we are trying to propose to increase the number of HR in all cadre, so that health should not depend on any contractual thing. So it is a continuous, and we want our permanent staff to be there, sir.
Okay. Dr. Jagdishan, I would like to understand from you, how have you onboarded your public representatives in the decentralized healthcare system, and what are the initiatives you have taken for strengthening their participation as such, so that the capacity building is there, so your public health objectives are met?
Yes, sir. See, all our 200 divisions have councillors, and we directly interact with the councillors. Basically, what happens when there is hierarchy is there. So mayor and council is there, then we have standing committee as I explained, then we have zonal committees are there. So each and every health activity happens on the ground level. It's been informed to the local councillors for involvement. For example, what something happening in the PSC, primary health center of the particular division, the council is involved. So all the activities have been particularly informed. We have the, for example, we have the WhatsApp group for the councillors. So is there any important health events are happening, so immediately publish it in the WhatsApp group so that all the councillors reaches it. So they each and every information about the health activities or what is happening in the health inauguration or specific health programs or Beti Bachao program, whatever program which we do is been clearly informed to the public. Not only for health, also vector control, even for vector control activities or all the other activities, councillors are involved, so that when they are getting involved, they want to take a pride of their own divisions. They want to actively, they want to show that the people that they are doing something for the people kind of thing. So they take their ownership and they want to come forward to help us, and they also be in active participation of this particular activity. So similarly, the standing committees also will discuss about the various health activities, health programs, and also more importantly, whenever we propose a program to the council, so these programs will go through the standing committees only. So in the standing committee, we'll discuss about the programs, about the even tenders or even policy decision activities. So they are taking the cognizance of what is happening in the ground and what is happening in the administrative level, all these things, so that they'll help us as well as they also provide the constructive criticism as well as suggestions to improve our services.
Okay, thank you all the panelists. Now I would like to throw open the floor for any particular questions with respect to these three municipalities from the audience.
I would like to learn from the panel about how the people's intermediation participation takes place. See, what I can read from the presentations was that you are trying to create an efficient, say, typical government system at the urban level. That's very important, absolutely no doubt regarding that. But there is no attempt to go beyond the representative democracy to get people to directly participate either in the program making or in the implementation of the program. Not to elaborate, but just to give a contrast. So the best international practice accepted by UN Habitat is a Porto Alegre program of urban development, which has been replicated in all the Latin American countries and so on. So how would you compare with the participatory budgeting program of Latin America with the urban governance system that is coming into India?
Sir, I would like to share the experience of Bangalore. We have these regular ward committee meetings which happen. So in that we have institutionalized a particular format in which the agenda has to be placed, and also proactively disclose all the budgeted items, what are the schemes or what are the works which are going on in the particular ward. And particularly with respect to healthcare, they discuss about the functioning of the PHCs or the maternity homes or the NAMA clinics which are there. And if any lacunae are there, they point it out so that immediate remedial steps can be taken, and later on in the next meeting they can take a action taken report on that. So that is the basic feedback loop which is there. So, and the ward committees are free for anyone to participate and express their opinions on that. And it is open for public scrutiny also. And the people, they regularly visit these places and also point it out to the concerned as to what are the lacunae and what are the shortcomings, so that it can be addressed in a proactive way.
In Pimpri Chinchwad also, sir, we have made a Mahila Arogya Samiti. Almost 400 to 500 Mahila Arogya Samiti is there in ward level. Around 100 of houses or 500 people, one Mahila Arogya Samiti is there. We are state government giving the some incentive for that. Basically, Anganwadi workers and ASHA are the key roles of NHM. Their approach to the people, and along with it, ASHA we are taking in that local areas. That's why the participation of ASHA with the population, that general population is very important. तो हमारे यहाँ PCMC में हमने around 400 आशा हमने जो select किया है sir, that was in that area only, and महिला along with that महिला आरोग्य समिति and our ANM, they are coordinating on above the ANM. We are having medical officers and PHN. They are also the key. The population of PCMC is only around 25 lakh, and we made our UPSC almost we are crossing 40. They are around 10-15,000 area one PC. The elite population which is there, we are not coming to the public sector. They are different. We are our base is toward the slum-like and child-like population. They are our basic role. Elite population, they are going to the private sector, and public sector, they are all these people. We are focusing on that area only, sir. Thank you.
Sir, with respect to Chennai, so all our divisions have the councillors. So there are two parts we can say that. One is about annual budgeting. So when we prepare the annual budgeting kind of thing, there are a lot of discussions happens with the standing committees. Standing committee has got a council, 15 councillors will be there in each standing committee. We have health standing committee, taxation, finance. So many standing committees are there. So these committee members will discuss about the various provisions of budget and what things should be going for a budget, and they will be detailed and summarized. In addition to that, there are inputs are being taken from the councillors. So what are the things should be added into the budget so that we can plan for new things. So accordingly, budget has been allotted. This is about annual budgeting and progressing kind of activities. When you talk about ongoing activities, when maintenance activities or improvement activities, these are all discussed at the ward committee levels. So we take councillors as a people's representative. They are giving inputs during the ward committee meeting. These are the improvements to be made, and they have been accordingly budgeted. When the ward committee approves, the ward committee has got a power up to 10 lakhs. They can do the activities from at their level. If it is beyond 10 lakhs, it comes to headquarters. Then there is standing committee approves. Or if it is going beyond 50 lakhs, it goes to council to approve. This kind of several financial delegations are there, wherein they can always participate and they can always get their work done at their level. This is about the financial allocation activities. Coming to the actual people participation kind of number, the residents. Now the GCC is creating the area sabas. Area sabas include the local people to talk with. So every division will have Below the counselor, there will be a lot of small area sabas will be there. There also, this is for overall, this is not exclusively for health, this is for all the activities. There will be area sabas also will be discussing about various aspects of governance, various aspects of services, kind of things will happen. So this is how we take the services or the inputs from the people and the people's representative to the overall governance of health system.
Hello. I'm Dr. Padmaja Keskar. I was Executive Health Officer in Mumbai Corporation earlier, and now I'm with Sneha. I would like to know about Nama Clinic, what you have started. I think Mumbai Corporation has started HBT clinics, Hindu Hrudaya Balasaheb Thackeray clinics. It must be similar to that, I believe. But I would like to know whether those Nama Clinic provides any NCD care or geriatric care, palliative care, or any other specialty services. And if these services are made available, how do you retain those specialists in the clinics? What are the special efforts made? And sir, you said you are anesthetist. We face a lot of problem keeping anesthetist round the clock in various institutions. So what are the special methods used to use these anesthetists round the clock? That I would like to know. Thank you.
Two parts to it. One is with respect to Nama clinics. Basically, they are, we are modeled on around 12 basic services they are supposed to provide, including NCD screening, the basic treatment for that, urban family welfare and family planning services. Even the primary focus, because since we are not posting specialists in these Nama clinics, so we are encouraging telemedicine in a big way. In fact, BBMP, we are the top performing unit in the state. In fact, Karnataka as such, they are number 2 in telemedicine consultations in the country. But BBMP, we are all the urban primary health centers, all the Nama clinics have been given a telecomponent so that whatever issues are there, they can immediately escalate to the next referral center and they can get their services. In fact, under the Smart City project, we have established 27, each assembly segment. Bangalore has 27 assembly segments. So we have chosen one best primary health center and established a smart virtual clinic. And a central command center is there where all the specialists sit there and immediately they're available for teleconsultation with the patients coming into these primary health centers or the Nama clinics as such. So NCD screening, we are giving a lot of importance, as all of you are aware. The disease burden for diabetes, hypertension is escalating in a very rapid way. And most of the subsequent complications and referrals to higher centers happen because of the untreated NCDs. And also during COVID also we saw most of the mortalities was with respect to the untreated NCDs as well. So with respect to anesthetist part, we have around 26 maternity homes and 6 referral hospitals in BBMP area. All the referral hospitals are running 24/7 and some of the maternity homes also. So wherever we have enhanced the capacity by recruiting under contract basis and honorarium basis also, we have taken more specialists so that round the clock services for OBG is available and unwanted referral outs don't happen. So we have a regular audit of the referral outs from these facilities so that the staff utilization is complete in these facilities.
One more thing, along with the search, we are taking this contract, all the specialists on contractual basis in Pimpri-Chinchwad also. One more thing we are doing that we are do the one panel. There came only for the cases. They came for the major cases and minor cases. We remunerate them and you can release. ये करके भी आपको sustain करना पड़ता है because the specialists we are coming in government sector very poor. That was not in the Pimpri-Chinchwad all over Maharashtra and India also. तो हमको ऐसे ही करना पड़ेगा कि उनको सस्टेन करने के लिए वी कैन टेक द केस बाय केस ऑल स्पेशलिस्ट except gynecologists, we require the 24-hour in maternity cases ki wo on floor रहना चाहिए. All other specialties you can take on the panel. You give them the specific remuneration of each and every cases, including pediatrics also, physicians also, and anesthetists as well.
Ma'am, regarding your question for anesthetist, you asked me directly that you are an anesthetist, why you are not utilized. So for this, I would like to answer in one line, ma'am. I said 2009 there was an executive order passed by the Bangalore City Corporation withdrawing the SWM. So we were more concentrated on the secondary level as well as the primary health center level cares. So I was DHO that time. So we had 6 referral hospital, but only 3 anesthetists. We had, sanctioned posts of 17 anesthetists, but they were not recruited. So that time I thought I should not do anesthesia and help these hospitals. So I went to anesthesia in service and did MD and came back. I was doing anesthesia work. But right now I am seniority wise, I have become the chief health officer. Otherwise, right now we do not have any shortage of anesthetists because we have recruited all the anesthetists recently, and we also have some anesthetists given from Urban Health Mission, and we also have a panel of anesthetists by local practitioners in and around our referral hospital who work in the panel, and whenever on call they come, we pay some amount, honorary amount to them, like per case 2,000 or 3,000 like that. So we, as of now, we do not have any such problem.
I'm Advocate Rajiv from Kerala. Being the chairman of CWC, I would like to know how you are addressing the child health issues like learning disability, then addiction to digital instruments, then health issues like speech, etc., and early disability issues, so on, it's coming. So how you are addressing such issues related to children?
So basically we have RBSK programs. We have, so RBSK programs, we have 30 medical officers we have for 15 zones. Every zone we have 2 medical officers, and these doctors are being supported by early intervention centers at the medical colleges. So these RBSK doctors and paramedics visit the Anganwadi centers as well as schools, visit there, they identify the disabilities, disorders, deficiencies and diseases. Then they have been referred to the respective DIECs. So they have been followed up, and we are also having tie-up with the education officer, district education officer and corporation education officer, so that we can identify children with as a learning disability. So education department also has got a block education block unit for this kind of children, the children with a learning disability kind of thing. So our district early education centers, as well as there are another center is called intervention center by the differently able department. So different departments work together, and also we refer the children together. We will properly follow the children up.
So to add to that, we have in BBMP partnered with NIMHANS. Since it's located there, we have as part of their national brain initiative, they have trained all our PHC doctors in identification of various mental issues, including learning disability, early symptoms of depression or any other such kind of issues the patients come up with. So based on that, there is a clear referral system that is in place. And also, as I said, the e-Sanjeevani, that is the telemedicine component, is also active. So any kind of further escalations and referrals, it is facilitated through that.
Digital addiction?
Yeah, including that, all addictions also. So in case NIMHANS as such, they have a digital addiction center itself, or de-addiction center. They have, they are regularly having a ongoing study on that. So any such referrals are attended by that.
In Pimpri-Chinchwad, now in Maharashtra, one Mohim is going on. 0 to 18 years, all the children we are screening. The new initiative taken by the since last month. We are having a PG institute in place in our only. In that there is a pediatric unit, there is pediatric, all the batches of professor, associate professor, assistant along with the students.
there is also the psychiatric unit, and all the medical officers of all the zones, which are having 8 zones with 7 multi-speciality hospitals, all the doctors जो है उनको हमने screening के लिए बाहर रखा है. Those having any problem, they are referred to the PG Institute. They screen and do. Now both, as you said, both type of physical handicap or any mental handicap, yeah, addiction, they are taken by the PG Institute of YCM Hospital, which is there by postgraduate institute.
So we have time for just one more question. Yeah.
This is Dhananjay from Uttar Pradesh. This question is more related to, I think, Janagraha, since they're working in multi-states, and then the understanding towards the urban health program is also completely different from the other perspective. My question is basically, does this urban health model for in India is the right model what we have currently? Like the urban health is basically some extent replica of a rural model, which may not be feasible looking into the transforming of the urban, over a period of time, very quickly. That is faster than what we expected. And then the second one is basically we encourage the decentralized model because the health is a state subject. And then looking into the state, how the center can give inputs, the model, the urban health model should look like this. So any thoughts on this? Thank you.
Thank you for the question. This is something sort of we are also exploring while we were conducting our study. Because, so one more thing, urban health was not a pressing concern like 2 decades before. Because people always used to think urban hai to everything would be fine. They have access to private sector clinics, they have access to private hospitals. So when we were conducting our study, so there's a socio-economic line which is being ignored a lot of times when it comes to urban health. The slum, the notified and non-notified slums, they are being ignored. So yes, when you say what urban health model India has, we are lagging a little bit on it. But through the recommendations and the grants which have been offered by the 15th Finance Commission, they are giving us an opportunity to take a leap forward in next 5 years, because a lot of funds now have come into picture, and we do have a lot of opportunities where we can work for next 5 years, and we can actually we can actually take a leap forward and a great change in terms of urban health in this course of time. Thank you.
So, I'd like to thank all the panelists for their insights into their respective municipalities' health system functioning, and also to the audience for their very insightful questions. I hope they were suitably addressed. So, thank you all, and I think it was wonderful interacting with all of you. I hope we come up with a better understanding of the health system, and also as the last question with respect to one health model for urban India. One is I think first thing is as per the 74th amendment, the urban health system should be given back to the local municipal bodies. That is the first, I think, goal, because many of the states still that doesn't happen. So I think that would be the first step. And financial devolution is very, very important. Most of the states are between 2 to 3% of their budget for the health system as such, whereas we should be targeting minimum 6 to 7%. That will go a long way in giving financial autonomy. Third, I think the most crucial aspect is with respect to the HR itself. There is no formal the posts created for most of these facilities which are being created. Post COVID, lot of multi-speciality units and also the facilities have come up. But the challenge is going forward, maintaining them. The OPEX is, as I said, important, but also the state should support the municipalities in creating the cadre posts for them, so that they can be sustainable in the long run. Thank you, all of you.
Thank you very much. Dr. Chandra. If I could request you all to please remain on stage, and I'd like to invite Dr. V. Raman Kutty, Chairperson Health Action by People, to please present mementos. Sir, from here, sir. We'd like to present small tokens of appreciation to our speakers. We can begin from there, sir. To our chair also for having ably steered that session for us. To Mr. Gofane. Astha, go forward. And to Astha. Dr. Kutty, if I could request you to please join them for a photograph from the center. Yeah. Thank you very much, ladies and gentlemen, for that session. Thank you for the questions. We've got our speakers here with us, so you can take some of those questions that remain to be answered offline during lunch. We'll now take a break for lunch and return for the sessions at 2 o'clock. 2 o'clock we will start on time, so please ensure that you finish. If you're going to leave your belongings at your table, please make sure that you are leaving it in such a way that you can identify it, because there might be a lot of common material. Please ensure that you take care of them. Thank you.
Hello. Hello. Check. Hello. 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 Hello.
हेलो
Hello. Hello.
इसमें कम आ रही है, वहां से आ रही है, यहाँ से नहीं आ रही, यहाँ से नहीं आ रही। हमारी आवाज आ रही है, उधर से यहाँ, उधर की आवाज नहीं आ रही है।
Check 1 2 check 1 2 sound check 1 1 check check 1 2 check
ऑडियो
परफेक्ट है सर? ठीक है सर.
Yes, clear.
Ladies and gentlemen, may I request you all to please be seated. Please be seated. We'd like to start our session. If I could request our speakers, Dr. V. Raman Kutty, Dr. Rekha Ravindran, and Dr. Biju Soman, to please Dr. T.M. Thomas Isaac, Dr. Kutty, Dr. Ravindran, and Dr. Soman. Nothing is complete without him.
And keep this for him.
Let me first start. Put it there if you want. So welcome, ladies and gentlemen, to the session that examines in detail the decentralization of health in Kerala. To moderate and chair this session, we have with us the former Finance Minister of Kerala, Dr. T.M. Thomas Isaac. Our speakers, as I explained before, are Dr. V. Raman Kutty, Dr. Rekha Ravindran, and Dr. Biju Soman. Although I've introduced them before, I'll just give you a little more detail about our speakers. Dr. V. Ramankutti, Chairman of the Health Action by People Group, is a health economist and epidemiologist. Dr. Ramankutti was instrumental in setting up the Achyuta Menon Center for Health Science Studies, a public health research institute which pioneered the concept of interdisciplinary training in public health in India. And before this, public health was considered a subspecialty of medicine in most universities in India. Dr. Ramankutti will share his insights from field research on decentralization and public health in Kerala. Dr. Rekha Ravindran is a medical doctor turned public health professional. She's currently working as a senior research officer at the State Health Systems Resource Centre in Kerala on deputation from the Department of Health Services, Kerala. She's also an executive member of HAP, and her area of interest includes health policy and systems research, geriatric health, injuries, and non-communicable diseases. Dr. Ravindran will speak on the impact on health service delivery. To tell us more about improving access to the marginalized population is Dr. Biju Soman, professor at the Achyuta Menon Center for Health Science Studies of the Sri Chitra Tirunal Institute for Medical Sciences and Technology, Kerala. A medical doctor with advanced training in public health from India and abroad, Dr. Soman believes in the proactive adoption of digital technologies for public health action. He has been associated with HAP from its inception and presently serves in its executive body. He was actively involved in the decentralization campaign in Kerala during its early phase. I'd like to request the chairperson, Dr. T.M. Thomas Isaac, to please set the tone now, or do you want to go straight into the presentations? Okay.
I think I have already stated what I want to say in the morning, so I don't want to stand in the way of Professor Ramankutti, please.
Good afternoon. What I'm going to present is a very concise overview of what we did in the field and summing up of what we found from the field research in this project on decentralization in the health sector. Can I change the slide? Oh, okay. Okay. Yeah. So just to set the tone, Health Action by People explored the experience of decentralization in the health sector in Kerala. And there was a reason to this. We had completed 25 years after the legislation had set in. So we wanted to look at what happened in the health sector in the period in between. As has been explained in the morning, health is one of the important functions which had been decentralized to the panchayats by this legislation. So, I mean, this is just theory, I don't want to, but just want to point out that most of what happened in Kerala is devolution, that is handing over of functions to the lower level, not much of delegation and privatization, etc. So, we had this team of multidisciplinary people consisting of public health experts, social scientists, NGOs, and we divided the whole broad research question into sub-themes, and each sub-theme was handled by a team. So they did the field work, they got the results analyzed, and then we, one or two people, put it together, knitted the report together from the various feedbacks or reports. So we had field research assistants, PhD scholars, NGO representatives, all of them helped us. So compilation was done by the PIs. So coming to the frameworks we used, we searched the literature on decentralization, especially decentralization with respect to health, There's a lot of international literature on decentralization and health, interestingly. Actually, it was a very great learning experience for us also. So then we tried to find out what we could fit into. So we kind of surveyed or looked at various paradigms. One was a principal agent paradigm suggested by Bussert, which means that there is a principal which is the central government and the agent is the local government. So the principal is actually trying to work more efficiently by delegating some work to the agent. So in this paradigm, the agent has is not independent, not completely independent. So we were thinking, does that fit our experience, or does it fit the rights perspective, which is like people from the bottom, that is demanding their rights and they're finally getting more power in the local level. Then of course there was a whole background is the social determinants of health, which is very important, and sustainable development goals. In the background of all this, we looked at this experience, and we also looked at the literature on Brazil, Philippines, the NHS in UK, Karnataka and Andhra in India. So all these, lot of interesting work has gone on. So we had used several tools, mostly qualitative. We reviewed published statistics, we did document reviews, whatever is available. Then mainly we did focus group discussions, key informant interviews, in-depth interviews, case studies. All these were these are the major sub-themes which we looked into. I won't go into all of that. So as you can see, it's a broad, a lot of sub-themes were there, like the NHM, the hospitals, the NACP, the TB elimination, Nipah. These are, I think there are more, but we just to give you a feel that we had several teams looking at different aspects. And so actually we had 79 doctors and researchers actively involved in research, and there were about 30 people supporting the field work in various capacities. We did about 450 interviews, and we did several case studies of local government. So this is how we completed the work. So findings, Kerala succeeded effectively, that is what we feel, in creating a three-tier system of local governments. And these were also empowered to intervene powerfully in local governance and health, and modify if necessary the instruments of power sufficiently so that they could make the system more responsive to the needs of local people. That's a very major finding, that they were empowered and they did rise to the occasion. So secondly, the government came down to the people. That is, as somebody put it I thought that was a very beautiful metaphor, that the surface area of contact between the government and the people was increased because of local governments, because they could really reach out. People could easily address their grievances and seek redress. Local governments in their turn were sensitive to people's needs, partly because of their own survival, because if you want to get re-elected, you cannot be insensitive to what is happening at the local level. So, but in spite of this, there was a range of successes and failures. We found both successes and some failures. Many local factors influenced the outcome. It is not that it had a same level of success everywhere. Naturally, we feel that the local factors interacted with the decentralization process. In some areas, in some governments, very successful, some not so. And there was so many factors, and one of the factors which came up again and again is the confluence between the local government and the health personnel. That is, the doctor and the panchayat got together very well, then things happened. So if one of them were not happy to work with the other, then things did not happen. So that is something which we see again and again. So there was resistance on the part of the traditional bureaucracy, which means the doctors in the health system, which I think continues even now. They are not fully accepting the fact that the local government is really in charge of the system. So that has led to a lot of tension. But younger and more junior members of the staff, that is the doctors, they were more accepting, and they thought that this is a slot for us, that is we could do something at the local level with the help of the panchayat. So many people utilized that opportunity. So improvement of health infrastructure was very important, and as somebody pointed out, by the mid 90s, the Kerala health system, the infrastructure wise, was really going down. Maintenance was bad. We had no money for anything. But then one of the factors which kind of improved the infrastructure is the decentralization, so that the panchayats could plan expansion and of facilities and improve the people's access to high quality healthcare. Nowadays we have very high quality healthcare being offered in the public system, thanks to this the help of the panchayats at all levels. Something which has been noted in a lot of publications also. Surprisingly found the Ayush stream, that is Ayurveda, Yoga, homeopathy stream, which made use of those opportunities offered much better than the modern medical stream. Again, I think somebody in the morning also pointed out, partly because of the resistance from the part of modern medical doctors, but these people saw that this is an opportunity for us to expand our facilities and our services. So their central bureaucracy accepted the spirit behind decentralization and worked with the system, and they improved their status. So they have a lot of new initiatives under. But the modern medicine system was a little reluctant, but it did pick up steam. But on the other hand, they resented their power and the loss of status. So decentralization improved primary health care. That's a very important finding, especially now we find that we have the family health care system coming in. Of course, it's a new initiative. We don't know how far it will go, but it is a very important initiative. But if you look at what are the projects which came under decentralized planning, you find that a lot of it can be classified as preventive and promotive health care, like vector control, safe sanitation, better water supply, etc. So all these are not really curative aspects, but more of primary healthcare aspects. So national disease control programs were implemented with augmented funding, because we could do that under the rules of decentralization. They could put in more money for instance, like NCD prevention and all that. Specific programs such as Ardram, which is a new initiative of the government, which is actually a very interesting experiment, extending the facilities and the hospital services to the people beyond the normal working hours. And health planning by local governments and health planning in the NHM proceeded in parallel and independent of each other. That is one major finding, that they did not get on well together for some reason, technical and logistic and many other reasons which I don't want to go into now. They are even now existing as, there was a good opportunity lost that to integrate these two. That is one of the findings that we had. Coming to the setbacks and failures, the most important failure was that in spite of all this, we find that in Kerala, a state which has achieved the maximum possible in terms of health in many aspects, still the Dalits and the tribes and the coastal fishermen lag behind. They still have low, comparatively poorer indicators of health, and this is something, in spite of local planning, their needs were not met. And this is something which I think people have to take seriously and look into. So the failure of empowerment reflected in the poor health of these communities, in spite of improvement in material infrastructure. That is always there. So, but though reproductive health indices look good, women's health also, access to health resources are poor. That is another finding which we have recorded in the and the lack of participation in Gram Sabhas, except as claimants for benefits, that is another important finding. That is, people do not now come to the Gram Sabhas as they used to. The expectation is that they should take part in the planning, but that is not happening. They are coming only if they think that they get some benefit. Participatory planning is really not happening at that level. So to conclude, the effect of policy of decentralization on Kerala's health and health sector seems to be mixed. There are a lot of impressive gains, especially upgrading of public health facilities, improved access, new initiatives. But however, several groups are unable to claim their rightful legitimate share of the fruits of development because of various structural and other reasons, which is something that we should take note of. So that is why we still say that we still need to go a long way towards participatory democracy. Of course, I think we will achieve it sooner if not later. So with that I close. Thank you.
Good afternoon all, respected chair and my co-authors and co-presenters and distinguished guests on the dais and off the dais. First of all, let me thank the organizers for having me here to present the findings of a study done by our team in collaboration with HSTP. So, little different from the topic in the schedule. I will be limiting my presentation to the programs rather than the health sector as such because of limitation of the time. So I will be presenting here the role of decentralization in the implementation of national and state programs in Kerala. I am selecting a few programs for the purpose of this presentation. So, okay. Okay, so going on to the background, as sir already has mentioned, we have had a larger study on decentralization, especially the experiences from Kerala in health sector, and so since there is a technical problem, I will. Yeah, maybe. Can I connect my computer then? Okay, no issues. So I'll be continuing with my presentation. So going on to the background, the healthcare institutions and their personnel in the public sector were transferred to local governments in 1995 as part of the Panchayat Raj Act and Nagarpalika Act. And the health sector has been greatly transformed by the decentralization of governance, and this can be seen reflected in various indicators, health indicators. So, and the national and state programs are in general aligned with the decentralized governance in such a way that it can complement the health system in implementation. So, I'm not going into the details of the methods we adopted because sir has already mentioned it was predominantly a qualitative approach, and the document reviews and key informant and in-depth interviews were done. Deductive coding using schema or theoretical framework, and the programs I am going to mention here, there were separate studies, sub-studies of the larger study. So, and thematic analysis was done to arrive at the inferences. So, going on to the key findings, first it will be, okay. So, It's not moving. Yes, thanks. No. Stop now. So, the findings from the National Health Mission. So, National Health Mission, as already all of you know, it's a national rural health, initiated as National Rural Health Mission in 2005, and it's not me. It's going on its own.
I suggest you use your text.
Yeah, that's better. Actually, I will be the only person who confirm with them that it will be working during my presentation. So, and it went wrong, rightly. Anyway, I'll.
One of you.
Sorry for the interruption. Yeah, thank you.
PPT and use.
So, sure, sir. Thanks. So, the National Health Mission, initiated as National Rural Health Mission in 2005, which adding the urban component in 2013. Now it's called National Health Mission. So, what we found that the decision space for local governments is determined by the rigor of guidelines and bureaucratic elements. Determines, and decision space, for your information, is defined as how much authority for making decisions on different functions is delegated to local authorities from above using their official policies. And decision space mainly depends on the level of motivation of the individual involved. So, we can see that innovations are happening wherever the local government was given flexibility to perform a crucial role in planning. And community participation, which is crucial in the case of decentralization, is possible with enhanced integration with the local body, augmented by improved awareness among elected representatives. So, as Sir has already mentioned, we have missed opportunities. So, the state has missed the opportunities to align the activities along with the existing decentralized framework. And significant gaps were identified in utilizing the possible options for integration of NHM implementation with the decentralized structure. So, going on to the next program, that is NPCDCS, NCD program, we can generally usually call as NCD program. So, we see that the local governments have assisted in tackling the social determinants of health through intersectoral coordination and increased community participation. And with the new guidelines, local governments could appoint human resources at their discretion depending on the demand from locally. That has benefited basically mainly the non-communicable disease control program. And they have often stepped in when there were drug shortages at health facilities, especially in the case of non-communicable diseases, because they have to continue with their medication lifelong. And we can see many successful models in NCD control integrating with the local governments were identified, which can be replicated in other states and middle-income countries. So, but what we could find is the lack of sustainability of intervention and heightened emphasis on secondary prevention were some of the gaps identified with the programs that was done locally. So, next program, I would like to deal with this National Vector-Borne Disease Control Program, and that the involvement of local governments was important in adopting flexible implementation plans for the program, and the LGS has brought significant improvement in the quantum of workforce. As I already mentioned, the revised guidelines allows that, and finance available at the local levels of the health system. There was improved community response and societal roles, and lack of monitoring was one of the gaps identified. Going on to the next program, National TB program. Kerala is moving to elimination these days. And we see that the local government stewardship has helped Kerala in accelerating towards eliminating TB, and it has led to establishment of solution based on local problems. So, and it has improved reach of services to socially vulnerable individuals, and treatment support to patients with TB, community ownership for TB elimination activities, and also reduce stigma. The local governments, the involvement of local governments has really tried to improve the stigma among the population towards the TB. And institutional mechanism in terms of local government TB elimination task forces, formal guidance in planning interventions, and appreciation of their performance in form of towards the facilitators for local government involvement. So TB is one of the program which actually has not much of differences in most of the local governments, because other programs we can see a person dependence, but here yes, it is there, but still it has well integrated with the program, so that it's almost everywhere it's same. And going on to the National AIDS Control Program, we can see that the local governments have the commitment of local governments in adopting the HIV/AIDS policy, facilitative interdepartmental coordination, and local innovations. And there were interventions for improving awareness about the disease. So we can see that the local governments were taking up programs, projects to improve the awareness regarding about the disease. And fund shortages and poor visibility of the benefits due to the preference for anonymity were challenges with the implementation of this program. And with the support of LSG by overcoming the stigma factor, we can actually reverse the AIDS epidemic as it is intended. And another program, RMCHA. So we could see that there is further boost for this program through decentralization. And in most of the areas, the LGs took an active role in recruiting additional manpower in regard to this. And involvement of local governments improved the access to services. And somehow the monitoring part of the local governments was better in case of this program as reported in the study. And it has improved the quality of services. And LG support has resulted in improvement of infrastructure facilities in PHCs, sub-centers, and Anganwadi, as already mentioned in the earlier presentation. And additional funds, that's one of the area mentioned as, for the nutritional programs and all. Additional funds were being arranged by the panchayats to support this program. So another state-run program is Ardram. It's a mission, it's in the mode of mission, implemented in a mission mode, and it's intending to bring holistic improvement in health sector at all levels, giving a focus on primary health care. So with Ardram, a lot of changes, transformation has taken place in health sector. I'm not going to describe all that now, but we can see that strong political commitment combined with bureaucratic competence has facilitated implementation and functioning of Ardram implementation. So different from the training sessions that are happening in the state, we had a team training for the local elected representatives along with the healthcare staff from each institute. They were coming as a team and undergoing the training. So that training, insight developed through such trainings helped local governments to get involved and engage with the health system as a team. And this facilitated re-engineering of PHCs by mobilization of resources, infrastructure modification, and enhanced community participation. You can see that there are tremendous improvement in the infrastructure, and with the, as I already mentioned, human resources are supplied by the local government. They are appointed by the local governments through projects, through the keeping the project local government projects, and with community participation and resource mobilization. A tremendous improvement in the quality of services through infrastructure development. It's going to the service, service provision as well, and the project is ongoing, and even now the training sessions and are happening. And then one thing we noticed is that non-uniformity of commitment. It's already mentioned. Yeah. So suboptimal engagement of urban and local governments and issues of sustainability and monitoring were the shortcomings observed. So going on to the implications, I'll take 2 more minutes because I have lost a few minutes in the beginning. So, decentralized governance structure in Kerala had positive influence on implementation of various national and state health programs, though mixed, but predominantly positive changes. Many successful models could be identified, and of course the reach and quality of health services have increased, and the local government involvement has addressed the social determinants of health. So the decentralization process provided a robust platform for committed and inspired leaders and officers the freedom, resources and space to evolve and implement healthcare programs or projects. So it acts as a more approachable point of governance and enables mobilizing volunteers and other local resources. And going on to challenges, as already said, non-uniformity of commitment among the leaders as well as the healthcare workers and person dependence. Local governments still focus on hospital infrastructure and visibility for political benefits, and mostly knee-jerk reactions instead of a proper planning based on a public health perspective that could reap long-term benefits, and lack of awareness among the community leaders and healthcare workers as well. Medical officers not that predominant, but still some of the medical officers find their power curtailed when decision making is done by the elected representatives, and a lack of sustainability of the initiatives and overemphasis on secondary prevention, lack of monitoring and evaluation of the implemented programs from the local government side, and missed opportunities as already mentioned, where the structure of decentralization could have been utilized for more efficient implementation of the program. And this findings reconfirms the weakness of the state in failing to expand decentralization to its full potential. And recommendations, training is important, and there should be some measures to systemize integration with local governments for uniformity of implementation, and there should be some measures to revisit the program strategies to tap the potential benefits of decentralized government. Thank you.
Respected Chair, co-presenters and others. First of all, let me thank the organizers HSTP for giving us this opportunity to share some of our observations. I'm waiting for the slides. Meanwhile, let's begin. What I'm planning to give you, from this exercise of looking at how decentralization has affected the health sector in Kerala over the last 25 years. We have found many positive things and many failures, as Ramankutti sir has rightly pointed out. Today I'll be mainly looking at one of the so-called, where we understood that decentralization has not played well. That one area we want to take and highlight. That's what I'm planning to do. Before doing that, as it was very evident that, next slide please. Yeah. Where? No, yeah. Okay. Yeah, next one. Yeah, first, this slide, I thought actually we should tell you what's our position for this observation. Like, this is mainly a qualitative exercise, so where we stand is very, very important. As such, HAP was a pro-deep decentralization group. Actually, most of us believed in decentralization, and most of us were actively involved in the decentralization process and all. But now, actually, this HSTP has given us a opportunity to look back and reflect upon from a believer to a sort of researcher angle. So that's what we have tried to do. Next. So it is very evident that overall there were quite a lot of improvements in the infrastructure in health sector in Kerala. If you walk into any of the public health hospitals in Kerala, be it in Wayanad or anywhere, you can see the difference. Actually, the infrastructure has become better, and we have better staff. And overall, the improvement is there, and that improvement, next slide, is getting reflected in the marginalized sections also. Next slide, please. Yeah, for example, I've just given an example of poverty ratio. Actually, the poverty prevalence among the SCS scheduled class in India, if you compare various states, actually you can see that Kerala is having better indicators. And only this is with the poverty ratio. If you take any other health indicators, actually we have done, Achyuta Menon Center has done many studies on that. We could see that be it tribes or scheduled class or even coastal people, their overall health indices are better than many other states. Actually, so that is there. But when we look into what is happening within Kerala, next slide please. You can see that there is lot of difference. Like when we looking at the population, the SC population is 4% and ST, scheduled tribe population is 1.5%. And the growth rate, just look at the growth rate. Overall, Kerala growth rate for the last 5-year period is 4.9, whereas the growth rate in tribal people is 21.3. So that is quite high. And literacy rate, in Kerala, literacy is one of the stepping stone for advancement or social upliftment in Kerala. And so literacy rate in Kerala total is 94%, but in ST population is 67%. It's in spite of so many schemes and all. And even poverty ratio, you can see quite a lot of difference. Actually, overall, if you take 7%, then in tribal population, almost 50% of them are below poverty line. Next slide, please. But many of the studies, when we are looking at health indices, you can't see much difference. One of the study, our own study in 2017, we have done a study, and we couldn't find that health care access, there is no difference. Actually, many of the antenatal mothers are being screened by JPHN, both in the general population and the tribal population, it's alike. And when we are looking at vaccination coverage, there were no difference. And many of us who are taking up positivist traditions of research, actually we may not see much difference. Next slide, please. But the crucial thing, like when we are looking at education, because education is a gateway for social mobility in Kerala, and there are so many schemes, tribal-based schemes in education, but you can see that of this, we have fared very badly. Actually, we haven't achieved the required school enrollment for disadvantaged populations, be it tribes or SC or even other backward sections. Next slide, please. And this difference is very acute in tribal belt. In marginalized sections, actually, we take 3 groups: tribes, scheduled caste, and coastal fishermen as 3 marginalized group and all. When you are taking coastal fishermen or Dalit caste, actually, there are some sort of movement going on there. Actually, they are coming up. There are conflicts, but they are coming up. They are arguing for their demands, so their rights. even in the ST community that's happening. So in the fisherman community and SC community is coming up, but in ST community who are quite backward is not coming up. So that's why we are looking at the ST community in detail. Next slide, please. This is in spite of huge investment. Like if you take 2023 allotment, you can see that out of our state budget, around 2.83% is given for tribal sub-plan. So tribal population is 1.5%, but our financial outlay 2.83% is given for tribal sub-plan. And if you add the centrally sponsored schemes also, around 947 crores is there. And of this, around 201 crores is given to local self-governments for their decision to how to spend on tribal welfare schemes. But, next slide please. But still, we haven't achieved much. Actually, that's what we have seen in the earlier figures, looking at the education or school enrollment ratio and looking at the poverty ratio and all. So it seems that many of the tribal schemes are just like giving things and all. So we are looking at, they are not got into the participatory planning process per se. You see, tribes, usually we say that lions are the kings of forest. But the tribes living there, they are the real kings of the forest. They were the people who are having a lot of freedom and all. But now with sort of modernization, we have made them like they're waiting for our pettiness and all. So we were not addressing the dignity of them and all. And when you look at sort of giving things also, we are not giving them what they deserve. Actually, we are giving them something which we feel like they should have. For example, look at the toilets. Actually, these are some of the toilets which are given as part of decentralization process. And the toilets, actually, they have you can see there is a commode there. And the commode is filled with sand and they are using it as kitchen. So that's some of their demand which we were not addressing. And this is true with many of the other interventions also. Next slide, please. And then looking at what they demand, actually the sort of health system or the government which they see is not only and then not at all understanding their demands, but many often there are a lot of conflicts. Look at their marriage culture. Once a boy and girl, they love each other, they start living together and all. But now around 10 of them, actually 10, 15 of them got arrested for this prevention of sexual atrocities against women and all. So this happens when they go to register their pregnancy in the hospital, then only it will come to know that they got married and then the boys got arrested and all. These kind of things are occurring. I'm not against that act as such, but probably can we have some leeway? But in this case, actually, even Panchayat are helpless. Actually, they can't do any sort of things. And the poor tribal people, they can differentiate between who is the police, who is the health person, who is that coming up and all. So this is some sort of our own confusion regarding what is sort of welfare, what is sort of mainstreaming or what sort of development we are aspiring for the tribal or indigenous population and all. And the second picture is a person who has hanged himself. Actually, he has taken his wife to medical college hospital, and then somebody lost some mobile phone, and then people accuse him of stealing that and all. And then he was beaten up, or he was accused, and then the poor fellow hanged himself. So he accompanied his wife for delivery, and that's what he ended up. And this is what's happening. So we are not really relating to them, and so we feel like what my main content here is that why we haven't achieved decentralization or the positive things of decentralization in tribal area is mainly because we were not addressing their demands, and at the same time, there are a lot of social problems or sort of discrimination existing in the community, which is a hindrance to for tribals to come actively into the decentralization planning process. Probably in the local level, when we are looking at the Grama Sabha, there are not sort of participation in the Grama Sabha. People who are coming in the Grama Sabha and all. Like in the decentralization at the local level, most of the decisions are taken by the middle class, and the middle class ethos are being taken up. And many often the weaker sections are left out. But that might not be very true. Like in palliative care and Austria programs, many panchayats are doing wonderful work. But when it comes to tribes, actually, like the tribal population in Kerala is distributed across various states. Actually, we have only one tribal predominant Grama Panchayat in Kerala. Probably that's why they don't have the voice to raise their demands and all. But beyond that, probably the real confusion among us, actually, as the sort of planners or academics on what sort of development we can aspire for tribal people. That could be the major reason, I think so. Next slide, please. So, in conclusion, I want to stress that actually when we are looking at the marginalized populations, how far decentralization has helped them, I would say that overall, the overall improvement in infrastructure could be helpful to them as well. But we are not seeing any particular benefit for decentralization for this vulnerable groups, especially in the tribal groups, and that could be because of the so-called, when we are looking at social determinants of health, so many other wider determinants which is beyond decentralization process. Probably we have to address that way. Then only, because decentralization, in order for decentralization to effect, we should have a baseline infrastructure, baseline awareness program, or baseline democracy in place, which is lacking with the marginalizations, especially with the tribal people. That's what I have to place before you for discussion. That's my last slide. Thank you.
So, we have just, we have got time. Yeah, we have got time. So while you get ready with your questions, I have 3 questions to the panelists. While you discuss them, the other questions can come up. If you want, you can also send notes which can be distributed. 1. Even under best decentralization, what we are discussing is a multi-level governance system or multi-level planning system. There will be central plan schemes, state schemes, and local schemes. But most important element is that all these schemes must be integrated at the local level. That's where finally the action takes place. Now, what's happening is, say in the health sector, the central sector or centrally sponsored programs are becoming more and more important, and there are also state programs that are inevitable. My question to you is, what do you consider the most serious factor contributing to lack of integration at the local level? Okay, that's the question, first question. Now, the second question is particularly to Biju. It's true, those facts are undisputed. But the allocation has increased. The notional flow which used to characterize allocation for SC/ST has been entirely stopped. Money is given directly to the department, and if any other department wants to spend from that, they have right to present the scheme and discuss the scheme with the SC department or ST department. And over time, rules have been also changed how to make local plans for SCP and TSP, where for tribal sub-plan, for example, the decision made by the tribal village cannot be changed by the local government. Now, SC, well, they have the separate group in the Gram Sabha or separate task force at the development seminar stage and so on. My question is, why aren't the community organization, forget about other organizations, involving themselves in this decentralized program? We have legal right to decide. What is standing in the way of that participation? In fact, this can be used as an instrument to ensure greater participation. I am speaking about all, not only community organizations, but all political parties and so on. If you look, there are struggles in front of the state government office, but no struggle in front of the panchayat, only these issues. So that's my question, second question, what is standing in the way? Third, the effectiveness of decentralization differs from locality to locality. What factors account for that? What are the key factors? So these are my three questions. I would like you to respond to them.
Hello. Yeah, the first question Dr. Isaac raised was about integration of plans at the local panchayat level, which is very important. I don't have a complete answer. I think we have discussed some of these things in the report. But I think part of the reason is that over the years, when we started the planning process, we had a very good structure, and we had a, what do you call, a protocol or a format, or I would even say, I don't know what that word is. Yeah, I mean, so that is now over the years we have kind of, so there was a lot of training given to the panchayat members, a lot of involvement of local level experts. So these things have kind of eroded in over the years. These have taken a back seat, and now I think more and more it has become a kind of a statutory mechanical process in many cases. That is, we have to have a plan. So we have to produce this by such and such a deadline. So, and this is kind of, sometimes it is even the job of a particular person to do this, and there is no involvement. I mean, this we found in some of the case studies also. So this may be one of the reasons. I think that is, but I think it's a very important thing that he pointed out. But to me, that also raises this whole question, which I think we should seriously consider. What contributes to success in local planning? Because you might find, in fact, in the early years also we had skeptics in Kerala saying that this won't work because nobody is going to do this. I mean, you may do it in the first few years, and later, you know, people will have fatigue and they will just go back to doing routinely the things they were doing all the time. So is that, I don't know how to address that. I think, is that the truth? That is what is happening now? I don't know. But I think this is something that we have to seriously take note of. I think part of the reason is this lack of training and the involvement of local experts and all that, which I, in the morning session in my recommendations, I had pointed out that we need to revive the local expert bodies and the planning process at the local level, which I think should be a very important priority in the future. The other thing, one question was, I think, specifically to Dr. Biju's presentation. What was the last point?
Tribal participation.
Huh?
Tribal participation.
Yeah, that.
Thank you, sir. When we are looking at why tribal organizations are not coming into the planning process. First and foremost, actually, as you know, I think. Is it? Okay. There is no, not much of organization there. Like the Urukutams and all. Actually, they are not. They are not very much aware of our rules. And tribal population is they are spread out. Actually, they are not organized. And if you ask me what is the real reason, I would say that lack of political activism there. All the major political parties, actually, they have namesake groundwork there. But probably it might not turn out to be a very good vote bank for them and all. And what's happening in Kerala now, actually, the education session, although there are quite a lot of schemes to ensure that children are studying in school, and the enrollment rate is quite high, and there are a lot of social assistance schemes. Actually, if you are a bright student who got into college, then there are schemes in which government can give money to these tribal kids, and there are tribal schools which are not properly manned. But at the same time, what's really happening to this sort of awareness building in the tribal areas? People, even activists who are working there, actually they will be noted as actually they are extreme left units, or even urban people who are arguing for them would be urban Maoists, or that kind of targeting is there and all. And probably lot of parties, actually I have a couple of pictures where top politicians are going to the tribal hamlets where in Murugan's house, actually, who was lynched recently, and in this particular person, Binu, who was hanged himself, the chief minister himself is going to the household to console the wife of that and all. But this is, I think the main purpose of this is to ensure that they won't miss out the vote bank. But apart from that, what earnest efforts are taken by the major political parties for empowering tribal people to tell them about the rules of the land. And I think mainly this is coming out of our own confusion. What we want tribes to come up when we are telling them about mainstreaming, whether we want them to be living like us, or we are ready to give some time for them to adjust to our lifespan. So, for example, the marriage pattern and all. If we can have some leeway for the tribal people to adapt to the modern life, actually then probably we have to be much more considerate for them. Now, we are advocating institutional delivery, but when they are registering for institutional delivery, then only we are realizing they are underage, and then they are penalized. So that is going on in one stage, and then we are trying to engage them with the planning process, and there is lot of confusion there. That could be the major reason.
I would like to add something to what Bisu had already told. Thing is, they don't trust anyone anymore, because many people were exploited, and they don't give any more signatures on any document. So that's one thing I would like to add to Dr. Viju.
Just 20 minutes left.
So I'll give my response to the last. Now the questions, please, the panelists.
We just have 20 minutes left for this session, so if you have questions, just raise your hand. The microphone will come to you.
20 minutes.
Sir, 20 minutes. Yeah, that's what I said. No. I said 20 minutes left. Somebody's on the phone. Just identify yourself, please. Yeah. Your mic is not working. There is a question in front. The gentleman in the blue shirt. Yeah, please ask your question. In the meantime, Hamai can get started.
Sir. Madam, you told that after 1995, both institutions and personals were transferred to the local bodies. Actually, only institution, the infrastructure only hand over to the local bodies, and the HR management still vested with the parent departments. That's the major reason for poor implementation, especially. I am a doctor. I am posted by LSD department in the corporation as a health officer. So my boss is my secretary, commissioner, and my director of urban affairs, and my principal secretary. But in case of health service department, they are independent. So in a panchayat or municipality, if local body want to implement any health related programs, they are directly depending the medical officers. The medical officers are many times won't implement the projects because they always think they are from different departments. The local body cannot take any actions. They can just recommend or suggest to the DHS, this person is slowing the projects. Many times, reason for the slowness of this project is because of their establishment is vested with their parent department. That's the major reason. And another ones are SCST department. And in the survey, many times we missed scheduled caste people because those who uplifted already as a professionals or in bureaucrats, they never disclose their identity. So the person with the scheduled caste origin, they already mingled or they mixed with other community like other backward caste. So in educated persons, in a common stream, many times they are from scheduled caste community. Once they get converted to some other
you have to be brief. Questions have to be brief.
Religion, they lose their identity like scheduled caste or Dalit identity. They usually considered as OBC. So in survey many times we lose their identity because they far uplifted than what we are expecting. In scheduled tribe, they are sorry sir, scheduled tribe there are some identity issues.
Just give us the question, sir.
Okay.
The question is?
Yes, my question is, our survey I think not penetrated up to our expectations. They are uplifted more than our expectation.
Right. Can we accommodate her question as well, and then we can have the answers together? Please. You're still not visible, ma'am. It's working. Can you just quickly?
Yeah, this is Vaishnavi from National Health Systems Resource Center. Thank you to the panelists for the insightful presentations. I just wanted to understand your opinions on how emigration from Kerala has impacted decentralization.
Immigration from Kerala has impacted. I don't think the study did adequate work on that area. If you can answer the question.
No, the question was how did emigration, I suppose you mean migration to the Gulf for employment and all that, right? Actually that was not a topic or purview of our study. So from a strictly academic point of view, I can't answer that question. You have to do another study to do that.
I would like to answer Dr. Shashikumar's question. I think personals are also transferred, but it is actually dual control. Maybe Ramgudi sir will be able to comment on that. Personals are also
See, this is a very important question that has been raised. One, the best results come when the local level departmental official would cooperate with the local government to implement the programs. So if you look at the local government's areas where the program has been more successful, they are precisely where the doctor or medical officer has cooperated with the local government. So there is a big if there. For the simple reason, the hierarchical departments, whether of the center or the state government, including the political leadership of the ministers and so on, they are reluctant to give the powers down here or give greater autonomy, integrate the program at the local level. It is because of this reluctance to break the reluctance that decentralization was implemented in Kerala as a social mobilization. You need to mobilize the population and opinion so that reluctance can be overcome. But what has happened over the last 25 years is that as mass participation has declined, the hierarchical order has become more and more powerful.
Yeah, with regard to tribal population, I feel like we can't have the same yardstick with which we work for decentralization in other areas with the tribal people. One of the study finding of one of a PhD student, Sabu Ulhannan, actually he went to one of the Gram Panchayat in Wayanad. Wayanad is the sole aspiration district in Kerala. So he went to one PHC area, Nulpura, which is having very good infrastructure, very tribal friendly schemes and all. But from one cluster of the population, he got the idea like tribes are reluctant to come to the health center because they feel like all the health workers, especially nurses, are wearing white uniforms, and to them white represents death. That's their no. It's during one of his participatory survey, he got this idea and all. And actually the PSC responded to that. Actually then when we went next time, actually the PSC was saying that actually they done away with the need for uniform. Actually they were not in that white uniform. The clerical, the nursing staff also could wear casual dress and all. And that probably this kind of small changes might be needed. So that's why when we want to get the buy-in of the tribal population, we should have some clarity, we should have more in-depth research into, we can't just expect that if we invade them for getting involved in the planning process, they will come forward and all. We have to do some sort of background work which is coming out of real. So it can't be done by the government alone. It should be done by interested parties. So that's why the involvement of civil society organizations, so NGOs have a role. I think so.
No, this is about what Rekha was saying, and I think what Dr. Shashikumar raised. I think it's a very important point, and I also need some clarity on this. He says that the staff is still under the DHS, which I don't think is completely true, because the Panchayat does have the power to take disciplinary action. At least, I mean, we have a Chief Secretary and an additional Chief Secretary right in this audience, so they can also clarify. At least one instance I know in Pathanamthitta Panchayat, where there was a major project on type 1 diabetes. They issued insulin to the patient, which was opposed by the technical staff because it cannot be done. It has to be only through the pharmacy. So finally, that person who refused to do it, the Jilla Panchayat president put an order disciplining him, and it stands. That is what I understand.
Any other questions? Would you like to?
You are going to end minutes before.
No, I mean, we can still have questions then generated by you, sir.
Now, let me come back to what the issue Biju was raising. I agree with you. It's a huge communication problem. I don't know if you have read the thesis of Manjula. TIS, she's a professor in TIS. She has compared the Women Component Plan program and Tribal Sub-Plan program. Women Component Plan program initially was not successful. Then over time, well, it is improved, and it was one of the most shining example of People's Plan with Kudumbashree and so on and so forth. While tribal sub-plan, despite the various modifications we continuously did not take off. And she makes the very similar point that you made, that the whole communication system in the Women Component Plan was very elaborate and detailed and so on, while it was very poor in the tribal sub-plan. Having said that, what does decentralization provide? It provides an opportunity for Dr. Biju to intervene. You have a right as a citizen. Go to organize the tribal, fight for the right. A right which you wouldn't have if there was no decentralization. Then you could have to go to capital city and make a dharna over there. No, who's going to listen to you? So, decentralization expands the democratic space for intervention. And if there are activists, organizations, or political parties interested in intervening in this space, well, things improve. Unfortunately, this is not happening. And why I cannot go into and so on, but this is an issue. But this is what democratic decentralization does. It expands democratic space for an activist to intervene. And regarding the central sector programs, see, look at the guidelines. Do the guidelines accept that there is a local level planning process? Without that, how could a local government integrate it? See, there is already a state bureaucracy who doesn't want to give that power down. Like, for example, what Vijayana said about Jal Jeevan Mission. Though there is a clause in the central guidelines about involving the local government, and though the state government has taken a position on that, but KWA bureaucracy wouldn't want that, you see. And they have managed to avoid that. So, democratic decentralization is a process of constant mobilization and struggle, you see. It is something to preserve your democracy at the local level. And this is not given as a gratis to by somebody else. So this is the lesson as an activist I would draw from this. So I think, well, no, question. Srikanth.
So I was thinking about decentralization and what we are observing as lack of trust between state level politicians and local politicians and state level bureaucrats and local politicians, where the general impression that's created, even in states where the same party rules at the state and the local government level is the same, even there this lack of trust is there, as if rent seeking only happens by local politicians. So in some of the states we are seeing de facto an increasing role for divisional commissioners and district collectors in urban governance, which purely from ideological lens, because there is no provision for a elected district government in the urban scheme of things, the involvement of the district collector in some ways is not good. But I'm beginning to wonder if chief ministers of states are relying so heavily on district collectors and divisional commissioners because of lack of state capacities, particularly for the long tail of 4,000 odd small cities. Do you see the feasibility of some kind of training, awareness building among these district collectors relatively early into their tenures on the significance of decentralization? Or are you saying that it's only through mobilization and struggle that this can be achieved?
No, I think S.M. Vijayanand answered this question in his presentation. See, there are many actors who enter into the decentralization process, academics. So all of us, Vijayanand or even Ramanguti, all of us were connected somewhere or other with the Center for Developer Studies, with a strong tradition of studies in decentralization. We had a UNFPA program of population and development. So many people were trained there, went over to Achyuta Menon Center, and therefore, you see, there was a minimum academic thinking which went to it. Second, it's very important that a few bureaucrats, I would say, S.M. Vijayanand, and you see, it just cannot be done by political leaders. Who knows the nitty-gritty of, say, the financial rules? For the first time, the Panchayat manual does not have a word code plan, and you are giving 1,000 crores to the local governments, and you need to have a system, or anarchy. So there must be some people, that's a condition, totally committed to it also, you see, who are activist bureaucrats, I would say, who have a vision, who are willing to spend some time. And then there are political people. There are also, it's a gelling of these three in the People's Plan campaign that is responsible for its dramatic success. So, I'm not saying just mobilization is possible, but without mobilization it becomes difficult, It becomes very difficult. To create a political will, see, 1 year it took for preparing the plan. He said, okay, you prepare a plan and we give you the money. Then you lay down certain procedures making plan and mobilize people. Planning, which is normally a technical process, become an instrument of social mobilization. So every political leader goes to every Grama Sabha, every meeting of the plan campaign for 1 year, saying, okay, 40% of the plan funds are going to be devolved, See, it is like you cross the bridge, then break the bridge, there's no turning back. That choice is not there. That political option is foreclosed by mass mobilization. That's where mass mobilization becomes important. But that is a necessary condition. Sufficient condition is without some committed officers who are willing to take the risk. Vijayanand has, if you take in the 1 year, first year of the People's Plan, we have 3 volumes of orders printed, huge volumes, because see, you don't need, it's not an almighty paramount lawgiver giving the law down. You are experimenting, doing, then translating what you are doing into orders. And therefore, as your practice improves, you have to change it. So some secretary has to sign it. No minister can sign that, you see. And there is a risk involved. So, and the beauty of Kerala was there were people who were willing to take risks. Thank you. Yes. Last question. Only 5 minutes left. Yeah, raise. Ask.
Sir,
Hi.
Otherwise, we can ask the question later.
can I 1 minute?
Please.
Yeah. No. No. So was asking like what academic institutes like Achyuta Menon Center, why don't we get involved with the tribal program? Actually, we have looked into that and we have initiated a program. I just tell you that we have a tribal mobile telemedicine program. Thanks to Rajiv sir, actually he only has sanctioned us to take up that program. Because in Wayanad, what we have seen that tribal people are coming to primary health center because they're familiar with the staff and all. But whenever we were referring them to the next Taluk hospital, and there are tribal promoters who will accompany them, and the cost will be taken care of by the tribal department. But still they are reluctant to go there because when we looked into that and when we interviewed them, they said that when we are going to Taluk or district hospital, then everybody is looking at us. Actually, they are not very comfortable to go there and all. So that's where we brought in this using some of the newer technology, telemedicine. We made it into 2 mobile vans so that on every month on regular days, actually, this van goes to all the peripheral centers, in primary health centers, and where the tribal who require referral care are taken care of. Through telemedicine, they are connected with the specialist and all. So this kind of custom-made program should be delivered to the tribal area, at least for some time, so that they will come in tune with our sort of customs. So that's why actually I'm requesting that we have to give some leeway for them to come into the same platform and then get involved in the planning process.
Very much, Dr. Soman. Ladies and gentlemen, we have to close this session as quickly as possible now because we've got Professor Balabanova standing by. If I could request the CEO of Janagra, Mr. Shrikant Vishwanathan, to please come up and present mementos to two of our speakers. Come this way. Go up. To Dr. Rekha Ravindran. Come back. Give it to him. Or to Dr. Biju Soman. Come back. A quick picture with all of you. Just join for the picture. Yeah. A round of applause would be welcome here. Thank you. The smiles get bigger when they're clapping. Thank you. Thank you very much. Thank you, sir, to please step down now and we'll make the arrangements for the next session. So, ladies and gentlemen, as I had mentioned earlier, we're now going to be joined via Zoom from London by Professor Dina Balabanova, a professor in health systems and policy at the London School of Hygiene and Tropical Medicine. We're just making the checks to make sure that all the systems are in place for the session. Just a couple of rules to keep in mind. Please do not talk while she's speaking from London. She can hear you and it might disturb her. So we're asking you to please remain silent in order to hear her well. We've also asked her to spare some time to answer a few questions towards the end of that session. Now, being a virtual session, we're completely at the mercy of the God of connectivity, so you will have to be prepared for any likely disruption or disconnection. So please bear with us as we set it all up. Put the name, please.
Recording in progress.
Where is Mr. Sadananda? Tell me when she's on. Mr. Sadanandan, may I request you to please come up? I don't have her on the screen. Can we have her on the screen? Come. There is a microphone.
Nina, can you hear us?
Professor Balanova, if you can hear us.
Yes, I can hear you.
All right,
But
thank you very much.
Speaking just a minute before and I couldn't hear them.
Okay. Dobrie utra. Good morning, Professor. It's morning for you.
In Russian, that's not politically correct.
Right. So we have a hall full of people waiting to hear from you. And on stage, we have Mr. Rajiv Sadanandan, the CEO of HSTP, who will interact with you at the end if we have time. Allow me to introduce you to the audience here. Professor Balabanova is a professor in health systems and policy at the London School of Hygiene and Tropical Medicine. with over 25 years of experience in research on governance, effective delivery models, and health systems strengthening. She leads a portfolio on good governance and anti-corruption research in Bangladesh, Nigeria, Tanzania, and Malawi, research on health systems responses to the NCD, and on creating learning networks. She led the Good Health on Low Cost project, examining how some countries, including Ethiopia, have made major advances in health and access to services more than others with similar incomes. She was a Health Systems Global Board member and sits on the technical team of the Lancet Commission on PHC Financing for LMICs, working on political economic issues. So, Professor Balabanova, I request you to now please share the international experience on decentralization in health.
Thank you very much. It's a real pleasure to be here today, and I'm sorry I couldn't be there in person. Can you hear me?
Yes. Yes, Dina, we can hear you.
Okay, that's great. Technology gods are with us. So, thank you very much. Thank you very much for inviting me to share the international experience. And in preparation for this talk, I discussed a little bit with some of my colleagues who have worked on these issues, and I noticed that there isn't very recent work on this area in my university, so I was quite curious about this. And I'm learning a lot with this talk. The experience which I'm going to share, it's quite diverse, and there isn't very well agreed sort of view internationally on the impact on decentralization. There are a lot of arguments, so I'm going to try to a little bit reflect some of this work which is going on internationally. So, sorry, I'm just trying to remove something. Yes. So why do we talk about decentralization? How does this come in? And my talk is going to also touch on high-income countries, or middle-income countries, and low-income countries. So generally, health systems often mirror patterns of administrative decentralization. For example, countries that have a lot of layers of decentralization, this will be many countries, even in Europe. Italy is much more decentralized than UK. In terms of governance structures, administrative structures. So very often the health system follows. Again, most of the reforms that we see internationally, the big large-scale reforms, involve some level of decentralization or devolution. And we're going to talk about these different forms in a minute. And this seems to be part of the wider reform to make health systems more equitable, more responsive, more accountable to local needs. So it's always this drive to do a little bit to talk about decentralization. Again, transformation also follows in countries that have experienced power shifts or some sort of transitions or turmoils. It's a lot of impact on health systems. So sometimes it's not by design, it's by default, by what's happening in the country at that time. So it is accidental decentralization. So we have a lot to learn from that as well. And I think the difficulties in assessing and evaluating the role of decentralization is that, and the institutions who should be involved in it, is that a lot of it is happening in triggered outside the health system. So we very often don't know what exactly is, we can't isolate the role of the decentralization in health systems. So a few reflections just to remind us, so maybe you covered this earlier, but internationally we look at these 4 areas of decentralization, which are quite different from each other. We have the concentration, which is shifting authority to regional and district offices. Devolution is a shift to state, provincial, municipal government of health services or responsibilities for health. Then we have delegation, where we have semi-autonomous agencies who are handling, for example, delivery facilities, so they're handling financing, so they have autonomy and they have new powers. And the final, the most extended one is the privatization, which is where ownership is completely transferred to private entities. So I think some of those are quite different from each other and have different implications. So I'm going to cover some of that. So when we look at internationally, what are the policy goals to introduce decentralization in health system? Why do we have this as a part of almost every reform out there? So the first is to enhance governance, to improve decision making at local level, to improve management of resources, of essential medicines, human resources, and to ensure that service delivery reflects local needs. A lot of countries are very diverse. We have even countries such as UK. We have a lot of diversity in areas where there is the ethnic makeup of the population is completely different. So you have to design services which better reflect to local needs through commissioning of such services. Another big goal is accountability, ensuring, so decentralization is often kind of conflated a little bit with citizen participation. It is almost accepted that if you bring the accountability closer to the population, to grassroots, you have more opportunities for community involvement and engagement of different grassroots actors, organizations and individuals. And this would make ultimately the services more responsive. Again, the final big one is improving efficiency, ensuring that the money and resources go to the right place without interference maybe from higher levels. And so these are the main areas internationally for decentralization. But I would like to spend a little bit of time talking about the impact. What do we know about the impact? And there's been a lot of work, a lot of publications. So I look at the overall learning, and I would like to summarize it. It was new for me as well. What's interesting is that a lot of the studies who are trying to track that with different methods, they're recognizing how difficult this is because decentralization is very intertwined with political structures and administrative structures, so it's difficult to disentangle the impact on health. As I said earlier, some of the changes in management structures or resource flows could be due to administrative decentralization, not decentralization in health. So it's difficult to track and to link actions to outcomes. However, there are some studies that have tried to do that. And one of the big things, and we see this in high-income countries as well as in low-income countries, the intention versus outcome. So in terms of there is intention to decentralize, but when the actual reform or transformation of health systems is implemented, it is not done in full. So this is very often due to institutional capacity, and I'm going to give a few examples of that, but also political will. So the reform states we're going to do decentralization, this is going to be a big thing, but then it doesn't happen to the extent that's planned. Again, decentralization spans multiple sectors, which is, again, difficult to diluting the effect. So one example that we often give is the example of Brazil, where they have a very interesting model, very successful model, which the way it works is that the municipality is the main agent structure, which is implementing decentralization. They fulfill different functions. So it's not just health. They have these committees of funds which are covering different areas, health, social security, anti-poverty, or nutrition even, climate change initiatives. So everything, urban development, everything is mixed together. So what they do, the way they do it, they have these stakeholder committees, which include representatives from different settings, from different sectors, who every year, and maybe 2 years, they sit down and make a plan. This year we're going to spend this on health, and they allocate resources between different sectors according to the local needs. So the committees are quite large actually, so they involve a lot of policy, different, not just policymakers, but also community representatives of civil society organizations, communities. So every year you have a bit of contestation, what's going to get funded. Generally, so when we looked at the impact of all this, it's really difficult to establish, but I'll give you a few highlights. There was a study I found which is looking at what facilitated successful decentralization in 26 countries, and then there was another review which was centered on structures in decentralized structures and devolved structure in sub-Saharan Africa. So what they argue, and a few other papers, but generally these are the main cross-cutting things. So you need to have the capacity, you need to have the technical skills at local level in order to perform decentralized tasks. It's not possible without that, and we all recognize that. In the case which I'm going to talk in a minute in Kenya, this was not the case, and that was a main impediment to reform. So effective, so how do you, so it's not just sending resources. I think that's one of the problems in decentralization initiatives. It's about the decentralization is used as a way to bring resources close to the population, but not the decision making. The decision making could be done somewhere else. So that's important, that the decision making should also be decentralized and goes to the periphery. Again, decentralization very often focuses on process rather than outcomes. So a lot of countries, for example, have implemented decrees, they've implemented regulations, the administrative sort of frameworks to allow decentralization. But in practice, the decentralization has not been implemented fully. So that's the problem. It's almost making the first step, but then losing the political will to continue. Or not being able to continue. Then the will, as I said, the will of the government to actually, the central government to let power go to other levels. For example, to make the legislative changes, administrative changes possible. And I think that's really, it's easier in countries that have had traditionally high level of decentralization. For example, in Italy or some other countries in Europe. But in Nigeria or lots of other places in Latin America, Chile, but places where they are starting from scratch, I think it's really difficult. The central government doesn't always implement the right framework to enable decentralization. So when the decentralization happens, people at local level are constrained in their actions. Again, the final one is the presence of effective governance mechanisms. So decentralization is dependent on good governance and what needs to happen in order to ensure that there is this responsiveness to local needs. Very often in some countries, decentralization is being used as a mechanism for local government to prioritize service delivery types or spending which is favorable to them. We see this in Nigeria. Local governments have incredible amount of power to co-fund health services, but sometimes they decide not to do it. They decide to do something else instead, and there is very little accountability. So when you don't have a good governance mechanism, bringing the services lower down to population could be actually counterproductive, and that's really important to bear in mind. So now I would like to deep dive into the example of Kenya. Kenya is interesting because Kenya is almost like a natural experiment for us, something to observe. They had a new constitution in 2010. They created these semi-autonomous devolved county governments who are completely responsible for health, for education, for a lot of other public sector expenditure areas. And then the idea was that this would help to involve communities, would facilitate priority setting and improve equity in health sector budgeting and resource allocation. However, this was done really fast. This was done before the local capacity existed, and this created a lot of tensions, and actually some of the functions had to be re-centralized. By the way, we see a lot of this in other countries as well, when very fast and this decentralization process is a bit stalled, we see re-centralization. Before, in the 90s, 2000s, we saw the same in Russia. They had a massive decentralization to each province. However, this was later reversed because they realized that they can't control what happens in every area. Therefore, we see this in a lot of places. So one of the kind of learnings from the Kenya experience is that it's important to clarify the roles and responsibility of the different actors from the start. So that was not done in Kenya. And there wasn't capacity on understanding what each actor's place would be, because they have the central government, they have the county government, but they also have sub-counties. So they have multiple levels, and it wasn't clear. So at a certain point, there was a standstill. They didn't know who should be doing what and how do they relate to each other. So again, the fact that some functions are shared doesn't mean that all financing should go to the counties, or all financing delivery should go to somebody else. So it was possible actually to do a better match between the task, for example, management of human resources, allocation of budget, budgeting, match it to the capacity and decision space of each organization. So that was really important, and establish accountability relationship, because some of those were not there at the time. For example, a particular structure would be tasked with, say, for example, paying salaries or negotiating with health workers, but they didn't have the accountability to some of the other actors above them. So that had to be built at the start, and it wasn't there. Again, the technical strategies didn't take into account political context. I'll say a bit more about that. So the first, it started with decentralization, but it was about devolution, which kicked in 2013. It was seen as a shock to the system. It really changed almost every aspect of the system, and it was seen by actors in the system as too fast. And however, some of the studies are showing that there was a positive impact. There was a positive impact on human resource management. There was a positive impact on essential medicine and medical supplies management. There was fewer stockouts. That was the eventual outcome. But initially, what happened, there was a major disruption. Actually, people didn't get salaries. There was a political interference at facility level. And there was a lot of confusion, as I said, around the roles of different actors. And these delays in procurement led to stockout and population protests. And so what was interesting, the devolution created the opportunity for health workers, nurses and doctors to be unionized, but it didn't address their grievances. So what happened? There was this famous strike, 100-day strike for doctors and 150 days strike for nurses, where there wasn't anybody in facilities for all this time in 2017 as a result of this process. So I think there were a lot of things that were not addressed in terms of how do you manage the transition period. Also, interestingly, when we think of, I said already that one of the main aspects and goals of decentralization is to actually improve accountability. However, we see something very different from the position of local staff who works at facility level. Actually, they really pushed back. They pushed back against local oversight. They said, we don't want people, say managers or local politicians who are corrupt, to come and ask us to do things. We want to be accountable to a national framework. So the doctors were not happy with this local oversight. And I think there was a real clash of values, clash of trust of where this should be. And the doctors was, at that point, there wasn't the human resource collective bargaining document, which says what the salary should be, what the conditions of work. This was not signed at national level. So doctors suddenly became very exposed. They were saying, you're not giving us anything, but you are demanding services and you're controlling what we do. So this caused a massive standstill. So that was the most dramatic case we saw. And it caused lasting system damage, which took quite a few years to resolve. So again, a few words on what do we know about high-income countries. So there was a very interesting study which used quantitative methods to try to unpack this, and I think it's quite interesting. I found it incredibly interesting to look at how they connected decentralization to health system performance, but also to life expectancy as a key health outcome. So what they found, it was OECD countries, so they found that there was an effect, definitely statistically significant effect, and they found, interestingly, that moderate decentralization is associated with lower public health expenditure and higher life life expectancy, so than most centralized systems. So was it due? They don't have the power to explain because there are so many countries. But is it due to services being more efficient, or people or more providers emerging and people paying in private care? We don't really know. But so in highly centralized systems, public spending is higher, but life expectancy is lower. So that's again interesting. So there must be cost saving. Reversing is reversed, but the outcomes seem to be better. And maybe that's one of the issues, is the ability of central governments to implement agreed, coherent national policies. Or if you have different provinces or different units in the centralized systems, this may be more difficult. Again, the hypothesis of this study is that decentralization may have helped to improve efficiency and incentives through competition of the different structures, but excessive decentralization may lead to fragmentation and reduce efficiency. So, but ultimately, then the outcomes were better. So we can think again, what are the goals of the decentralization? It's really important to understand that this is a political act. A country may decide that equity is the most important outcome, or a country may decide that cost saving is most important. It's really whatever is, it's the main goal of the reform. So in my final part, I would like to suggest something. I would like to suggest that given this difficulty in measuring the impact of decentralization and how it works in different countries, and it's very, very diverse, you find a lot of studies that found negative impact or neutral impact or positive. So it's really mixed and there is no conclusive evidence. But I'm thinking that maybe we have evidence that maybe it doesn't matter the whole decentralization process, the way it's implemented. Maybe what matters is the nature of the organizations who take over, and there is a bit of evidence on that. So we find that there is quite extensive literature on looking at situations, countries where improvements in district health management. So building up the district, their capacity to deal with resources, to do budgets, to deliver services, to have good information systems, has led to improvement in access to health facilities and also integration at district level. So there is a lot of literature, and a recent alliance, flagship alliance, WHO Alliance for Health Systems and Policies, they have a report on district health systems looking at the promise. And many of you will remember that in the 90s we had a lot of promise around district health systems, but this, after that died, the reason it being after the big reports on health systems, there is increasing interest towards oversight from central level. So all this attention to district was a little bit lost, but now it's coming back. Now it's again thinking that the district is actually an appropriate place to decentralize, so to build this institution as a vehicle for decentralization. Then another, I already mentioned Brazil. So we have studies showing that in Brazil, again, it's not just municipalities, this is a great model. I think we should be more granular and say some of the municipalities who used population participation, participatory budgeting, studies are showing that they had better outcomes, that they had a better match with the citizen preferences, improved health outcomes actually. While if we compare to Indonesia, where again, there was mandate for participation, as I said from above, it was mandated that you have to have participation, but it didn't really happen. It didn't influence the budgeting. We didn't say it's good results. Again, in Honduras, there was a large-scale decentralization, which was evaluated with proper quantitative methods. So what we saw, it's not, say there is a very, very large variation within the decentralized model. So the municipalities, some of the municipalities had leadership, which was led by NGOs and collaboratively with governments. And some of them were just led by governments. So the ones that were led by NGOs and government had much better outcomes. They improved facility utilization. There was, actually we saw improvements for some services, but not for others. It was not across the board, but still there was a significant improvement. So again, it's important not just to talk about decentralization generally, but to think about what's the best institution and the strongest and highest capacity. I would just like to propose a model which we've been using quite a lot. It comes from political economy perspective. It's looking at the power. It's very much similar to stakeholder analysis, but with a little bit more depth. Looking at the, if you're going to have decentralization, thinking about, okay, who should hold the power? So why would they do what they're supposed to do? Why, what is their interest? Because again, we have to think about the interest of different actors. This is increasingly, we work with political economists, because I think in health, we sometimes don't go in depth into this to understand why would certain organizations work as they expected. And we saw this in Nigeria. Local governments were supposed to co-fund and supposed to take power and participate in health sector delivery, and they didn't. They just said, why would we do it? There are new money coming for universal coverage. Why would we even participate? So they withdrew. So you have to think about why. And then capabilities. Capability is the key, the third key block. If the organizations don't have the capability, they will not be able to do it. So finally, a final concluding bit. So what we have done, what we have seen so far, there has been a lot of reforms trying to implement decentralization, and many of them have been very technocratic, trying technocratic solutions. For example, building capacity, information systems, improving resource flows and supply chains. But the results are inconclusive. Really, we don't have good understanding of what works. Similar initiatives in two countries, completely different results. Again, there is a feeling that decentralization by itself, maybe it doesn't matter whether by itself the way it's done, but what matters is whether there is a good management practices, many structures, and of course, to what extent the results of decentralization are mitigated by socioeconomic disparities in populations who are maybe more, there is a high inequality and people are not involved, they don't have voice, they cannot participate in any way in health service planning and delivery. It will be very different from places where there are strong structures. For example, in Latin American countries where there are low level of income, but there are structures for population to participate. So that's very different from what we see in many other countries. Finally, so what's emerging and what's interesting as the future? So again, as I said, it's important to really understand the political economy, and that will differ from country to country. We need to think about what are the actors in the broader space that influence the health sector. Health sector is very small compared to all these other interests. We find that this is very visible in places where we have looked at, and the recent commission financing primary healthcare, on which Dr. Rajiv was commissioner, we saw the same. We had a whole section trying to really understand what are these broader influences. Decentralization can be perceived as a shock. That's why the process of conducting decentralizing particular tasks is really important. So then there is something called everyday resilience, building relationships. We find that, and this was seen in South Africa, Kenya, various other places, where they studied places where there were better relationships, including informal, between the different structures, had a better outcome. So that's another thing to think about. So finally, concluding, to allow a little bit of time for questions, as I said, we know that the results are mixed. However, what is clear from the literature that it is very important to have continuous building of technical and institutional capabilities, because actually the situations, the context are changing, and the tasks for each of the institutions is changing. So we need to work on that constantly. A lot of the literature talks about political will, but I would like to move away a little bit from that and say, yes, this is very important, but what we need is operationalization. We need to actually this political will to operationalize into legal, administrative sort of structures, to have a clear roles of different actors, to have all agreement of who is doing what. And this is often not what we see in countries. There is constant contestation. Again, I already mentioned that, but who are the institutions who are carrying out key tasks? What can be done to support them? I think that's a really important point, and maybe not everything can be decentralized, and some things can and some can't. That's what we see as evidence. Again, the political alliances, again, that's part of the political economy. It's important to understand what's feasible and what's the health sector follows. So it's part of the broader sort of mosaic of institutions. And strengthening governance remains important task. I think this has been argued in quite a few papers that that's one of the key intermediating factors for successful decentralization and devolution. Thank you very much. I'll be very happy to take a few questions.
Thank you, Dina. Can you hear me?
Yes.
Thank you for a great presentation as usual. Now, a few clarifications. One is, you made a statement that decentralization hampers implementation of national strategies. And you also made another comment which says that the impact is better when not functions, but decision making is transferred to local governments. Aren't they kind of contradictory? That that you give the decision to the local governments and you would like to ensure that national priorities are implemented. Now, how do we reconcile these in a functional level?
I don't have a clear answer to that, but I think maybe I'll turn to you and I say, what is the example from India? I think what we find that very often when you have different sort of provinces doing different things, in a democratic system, it's very difficult. But when we think about the example of China, for example, China has it's organized around provinces. Every province has quite a lot of freedom to plan services, to implement different pilots, innovative pilots. However, they're bound by this national strategy. But that's China. That's China. I think in other places where there is more freedom, the democratic model is different. For example, if we take Brazil, if we take Nigeria, if we take the big states, but also Ethiopia is one of those, you could have national policy because that decentralization is not, in a way, they have decentralized system, but they're very bound by these central strategies. So I think I would say that the model of government in a country is essential and how the accountability structures work. Say, for example, in China, a province can implement very novel strategy. And even the central level is learning from that. Very often we have the central level inviting people from provinces to present their experience, and this is being scaled up. So we have described this in papers. It's a very positive way of working. Well, in Ethiopia, this would never happen because the central government controls everything. They allow the provinces to implement, but they don't allow them to come up with new strategies. So I think there is a tension between having a national coherent strategy which has to be implemented and allowing a little bit of innovation at local level to penetrate and inform feedback loops. What do you think?
No, it's interesting that you mentioned China, because China, that's a question that was raised here also. The administrative control is with the local government, but the technical control is entirely with the central government. So the technical, there's very little technical leeway that is given to a local level functionary. Now, one last question. You mentioned Brazil. And Brazil has a large number of indigenous population, which varies from different state to state. One of the questions that's been raised here while looking at the decentralization in Kerala has been that the decentralization process has not helped the marginalized, the poor population. Whereas, what's been the Brazilian experience? How have they dealt with it? Because they also have a large indigenous population and the income disparities are almost as bad as what is in India. So how have they dealt with it?
I have to say that I don't know a huge amount about that particular question, but I do take your point. What I've heard, for example, areas such as Manaus, areas which are part of the Amazon, which are much more deprived, and they have a larger percentage of indigenous populations without access. Again, Brazil is one of the good examples. Within municipalities and within the local government, they've managed to include representatives of such groups and to ensure that there is more funding for healthcare. So Brazil has had a massive improvement in maternal and child outcomes and outreach, really exemplary. But what we learned recently even is that there is a lot of contestation at national level. So what happened, the central governments are going to the capital and arguing for more resources, the province governments, and that's where these areas with more disadvantaged populations don't do so well because they don't have such a political clout. They can't get resources. Otherwise, within them, they have a lot of good models for participatory budgeting, for involving population. So Brazil is almost unique in that sense. If we think about Ethiopia, there are populations that are very different, disadvantaged. For example, pastoralists. They're not settled, and we don't have a good example from Ethiopia in a sense because the government has not been very versatile in terms of offering different kind of models of care to allowing different models to develop. For example, for pastoralist population, they were very much wanting to clamp down and almost say they have to fit with this existing primary healthcare structure. They were not supportive of local innovation. So I think, but even in China, you're saying that it's technical sort of issue, but actually the governments, the province governments, had enormous freedom to do things. The oversight was not as large, and we published on this. It was quite surprising. So I think it depends again on the political settlements. Are these groups and the structures that represent them able to argue for more resources from the national pie? Are they able to access more resources? Otherwise, within the state or the province, I think we see a good examples of involving population, usually through grassroots pressure. In Brazil, you have this massive grassroots movement. And in other countries in Latin America, actually, there are poor people who have groups, they have pressure groups, they're collectively organized. So I think that's maybe different in each place. When you have these collective organizations, there is opportunity for them to put pressure on local governments, to involve them.
Thank you, Dina. I think
I would love to hear more about the Kerala experience. I don't know whether this will.
Next time you arrange a webinar for us in London School, we'll be happy to present over there on what our findings are. Thank you, Dina. But I think in all fairness, we also need to inform the audience that in the Lancet Commission, when we looked at this question, we could not come up with a definite recommendation of whether decentralization is fully beneficial or not. In fact, the evidence that we came up was mixed. Thank you very much, Dina. Thank you for joining us, and it was great listening to you again. Thank you. And
thank you very much.
And I'll hold you to that webinar in the London School that we'll do for you if you invite
will.
us. Yeah.
Yes, very good. We would love to learn about your experience. As you know, we're always looking to India, and Kerala is one of the places of interest for us.
Thank you, Dina. Thank you.
Thank you very much.
Spasiba, Professor Balabanova. Ladies and gentlemen, we've come to the close of that session. We now have tea and coffee for you to essentially wake you up if you're asleep. So please be back here for the session that will be our last session of day one of the conference.
Stopped.
It's okay.
Yeah, it was said in jest, so it was not.
She's a friend.
Five chairs, and then that chair will go behind over let me see, skippy chair. So, yeah, we can sit there so that Ladies and gentlemen, may I request you all to please come to your seats? I almost feel like the class monitor. May I request you all to please take your seats? We're at our last session now. Please be seated. Those at the backbenchers as they're called. May I request you all to please return to your seats? Speakers, may I request you to please join the chair who's here already. Mr. Bhagat Rufus, Mr. Saju Xavier, Mr. Rajiv N, Mr. Radhu Singh Bhuria. Calling the House to order, may I request you all to please take your seats quickly. Either. So just for the audience as well as our speakers who are on the stage, may I just share with you that Mr. Radhu Singh Bhuria will be speaking in Hindi. We do have a translator, Sanmeet, here, who will try to translate whatever Mr. Bhuria will be sharing with you. I'll quickly introduce our speakers. Mr. Bhagat Rufus is the District Panchayat member from Venganur Division of Thiruvananthapuram. A mechanical engineer by training, his interest lies, however, in community work in agriculture, health, environmental, and social activities. Mr. Saju Xavier is the president of Payavur Grama Panchayat in Kannur district, adjoining the state of Karnataka. He has served the community as a Panchayat member 2 times. He's trained in law, and Advocate Saju Xavier has also worked as the central government counsel at the Kerala High Court. Mr. Rajiv N is an advocate turned community leader, currently chairing the Pathanamthitta District Child Welfare Committee for the government of Kerala, a recipient of the Prime Minister's Award for Excellence in Public Administration while he was Panchayat President of Iraviperur Gram Panchayat, Kerala. Several innovative projects have been implemented in the Panchayat under his leadership. Mr. Radhu Singh Bhuria, former president of the Block Panchayat of Jhabua in Madhya Pradesh. Rama is a tribal block in the hilly area of western Madhya Pradesh with poverty challenges from healthcare to livelihood. And as president, Radhu Singh Bhuria worked on improving the health infrastructure as well as access to health. He also established an e-library and computer smart classes for improving the learning platform in schools. As I explained to you, Mr. Bhuria will be speaking in Hindi, and we have a translator, Sanmeet, who will translate for him. I will now hand over to our chair, Mr. S.M. Vijayanand, to conduct the session.
Friends, the format is for about 5 minutes. We have discussed some issues on the topics. The 4 speakers will speak for about 5 minutes. Of course, Mr. Bhuria's speech will be summed up in Hindi. The first will be Mr. Bhagat Rufus, who will talk on Bud School. It's a unique thing, of course he will explain, which was started by a panchayat and government adopted it about 20 years back. Incidentally, it was started by his father, who was then the Gram Panchayat president. Mr. Saju Xavier and Advocate Rajiv, they will speak on the Family Health Center, a concept which Rajiv was also there when it initially was operationalized. It essentially means, how is it different from a primary health center? Primary health center, people come for treatment. In family health center, you go out to the community and identify. Panchayat has played a big role in rolling out of the family health centers. And incidentally, Mr. Rajiv is his panchayat is the only panchayat ever to have got Prime Minister's Civil Service Award. no panchayat in India or no local government has ever got a civil service award. He got it in 2015, I think. And Mr. Radhu Singh Buria, they have done wonderful work during COVID, particularly the Genpad, the second level. So first I invite Mr. Bhagat Rufus for what he did for the Bud School, which is a community-run, panchayat-led school for mentally challenged children.
Good evening to all. Myself Bhagat Rufus, District Panchayat member of Trivandrum from Kerala. First I would like to thank the organizers for inviting me to participate in this workshop section and giving me a chance to share my experience as an elected representative. I have been asked to represent the BUDS, a special school for the mentally and challenged children. And before coming to the topic, I have to remember my father, Sri Rufus Daniel, who was then the Panchayat President and later became the Vice President of the District Panchayat, who initiated the idea and led to the start of the BUD School. The Venganur Gram Panchayat is now in my service area division and also my birthplace. It is also the birthplace of the well-known social reformer of the upliftment, Mahatma Iyengali. 40% of the population mainly engaged in the farming activities. Health weaving is another major employment sector. In the year 2000, Venganur Gram Panchayat was elected by Kudumbashree Mission Poverty Reduction Program. Kudumbashree has started innovative poverty reduction program in the Panchayat. We know the SQ formula adopted for this: self-reliant, self-sufficient and sustainable. The concept, it has been well said that the local economic development will foster prosperity and reduce poverty. In practice, as part of the poverty reduction efforts, the Panchayat has decided to address the multiple deprivations faced by the poor family, which consist of food, health, education, basic amenities such as shelter, drinking water, safe toilet facilities, employment, etc. While addressing these issues as a package, it is the experience of the Panchayat that poverty reduction will foster local economic development, as it has a strong bearing on poverty reduction initiatives. The project envisaged to address the problems related to the following sectors: child development, geriatric care, mentally and physically challenged, education, women empowerment, enterprise development, etc. The SQ Panchayat has launched in 2003, and all the BPL families were brought under the network of community-based organization of PURE, which consists of 273 neighborhood groups, 15 area development societies and 1 community development society. Detailed sectorial plans were also prepared for each sector by consolidating the micro plans prepared at neighborhood level. One being the anti-poverty sub-plan, the Asraya, the destitute identification and rehabilitation, the Bhavanasri, the home for the homeless, then the micro enterprises for employment generation, then the child-friendly Panchayat. So when we talk about the child-friendly Panchayat, we look into the all child or all the children of our Panchayat. And there comes the importance of our school, BUD School, which is the special school for the mentally and physically challenged children. The integrated approach to address the poverty reduction in the Panchayat, revealed in the health surveys and medical camps at an emergency intervention, is indispensable to concentrate on the welfare of the children. The serious consequences among the children's future force the Panchayat committee to do something for them. This thought leads to the way to establish BUD School. The child development is an important sector. The Panchayat has identified for urgent intervention. The Panchayat has organized 10 rounds of medical camps in different wards of the Panchayat for the children at the age of 0 to 10. In the medical camps, 1,012 children attended, and out of this, 72 children showed symptoms of development delays. These children were brought to the special medical board meeting conducted and presided by the district medical officer and attended by different specialist doctors. The board then certified 53 children having disability. Out of 53 children, 32 are in the age group of 2 to 5, and these children, if brought under constant treatment and care, can be corrected. All these children belonged to the BPL families. This aspect led the Panchayat committee to think of launching a special school for the differently abled children. With no time, the Panchayat committee decided to establish a special school for the children. The Panchayat committee took lots of efforts to fulfill the dreams of the school. They approached pillar to post for raising funds and support from various agencies. And the Panchayat committee decided to establish the school in an existing building, and this led to the start of the first special school, that is BUDS, which was then initiative project of the Venganur Grama Panchayat, and for which it got many awards globally. Thank you for giving me the opportunity, and hope we will build a better nation with the ideas we share each other from different places of our country. Thank you.
This is one real example of how care and compassion schemes, the Panchayat seem to be performing very well. And this was innovated by the Panchayat itself. And I think now there are more than 70 such schools in the state. And it's a model. Next, I invite Advocate Saju Xavier, President of the Payyavur Gram Panchayat, to speak, focusing on the Family Health Center.
Good evening all. My name is Saju Xavier. I am from Kerala, Kannur district. My focus area is PHSC and FHCs in our state. After the advent of decentralization, our health sector has tremendously developed and popularized. In 80s, our PHCs are known as Dharma hospitals. That means a health center reserved for economically weaker sections. But now that trend is changed, and our PHCs developed in a tremendous manner. In PHCs, we provide 2 doctors, ensures 2 doctors service, and OP timing is fixed as 9 a.m. to 1 p.m. We provide primary care for the patients. Our Panchayat provides 10 lakhs rupees for medicine, and 1 doctor, palliative nurse, and a pharmacist for our development of our PHC service. How we different PHCs and FHC? In FHCs, minimum 3 doctors service ensures. OP timing is fixed at 9 a.m. to 6 p.m. in the evening. We provide observation facility, laboratory, X-ray facilities, and all facilities we will provide. Next focus area is palliative care system. Palliative care has been raised to an admirable level. Twice a month or more, palliative nursing systems arrive at the homes of deserving patients. Qualified palliative nurses, people's representatives, ASHA workers, volunteers, all of them are participating in the palliative activities with great interest. In my Panchayat, there are 196 bedridden palliative patients. Our palliative system provides catheterization, wound dressing, limbotomy, trichostomy and colostomy. This is the specialities of our panchayat in connection with our FHC primary health center. Thank you all.
Thank you for us to note how the panchayat tops up what government provides by increasing the number of staff, extending the OP hours, and also medicine. What he said needs to be noted. I found out that the Medical Supplies Corporation gives about 8 lakh worth medicine to a PHC, and the panchayat purchases another 10 lakh medicine. So the panchayat does contribute significantly. The second part, palliative care, is actually become a movement in Kerala. Even some political parties have launched palliative care movement, which means every person who is bedridden is assured of home-based care, and that is an assurance, and a nurse goes at least once a month, which is an impossibility in most parts, which used to be an impossibility even in Kerala maybe 10-15 years back. So these are the two important highlights of that panchayat. Now I request Mr. Rajiv to highlight the FHC, but he will highlight different aspects.
First of all, I am thanking to HSTP to share our practical experience with all of you. Within the time limitation, I am trying to brief what all a local self-government can do in health sector. Initially, I am trying to give some brief description about our Gram Panchayat. It's established in 1950 and the area is 18.64 kilometers. And the population is 25,000 odd numbers. And the point I am stressing is the gender ratio. Female population is 13,460, whereas male population is 11,740. And health institutions were established in the year 1947 as a general rural dispensary, and then it's upgraded to primary health center. Now it's as family health center. A citizen starter based service we are providing in the health sector, especially in family health center. We are having a modern lab, computerized lab, fully automatic biochemistry analyzer, then hematology analyzer, urine scanner, etc. Equipments were arranged by LSGD as part of the annual plan, and a minimum of 52 tests can be done with these equipments. And pharmacy with air conditioned and modern infrastructure, nearly, as Vijayan sir said, nearly 8 lakhs rupees government supplies there, whereas the LSG is giving 10 to 15 lakhs rupees medicine supply in different sectors like for old age people, palliative, then antenatal, and so on. And for public health sector is also working there. Palliative is there. Then we established an Ayush. Ayush since 2014. Ayush is working. Ayush Subcenter is working within the compound of PHC. Then PHC. Now it is upgraded as FHC. And we started yoga class. Nowadays, yoga classes conducted by PHC is not a big issue in Kerala, but since 2012 we have started it, whereas such a direction is not there in the guideline of the annual plan. We started this yoga classes. So around 4,000 people were already trained under this program. Now we are trying to build up a co-location center in FHC compound itself. And we are having a quality management system. 4 departments are working: OPD, then lab and pharmacy, public health, general administration. A citizen charter has published, a quality circle is built up. Habitual, the employees, all the employees in the FHCs are habitual with SOP. And then on evaluation of this, the institutions without the support of state government, which all can be upgraded to FHC. On evaluation of that, our PHC has selected for upgrading to FHC, and now it's functioning as FHC. And when it came to FHC level, best effective, affordable care to enforce the health of the family without discrimination, of the health of the family. while it is PHC, it's focusing on the health of the individuals, each and every individuals of the panchayat, whereas family health center is focusing the health of the family and the community as a whole. And HMC is effectively working there. Once in a month it's gathering a monitoring, it's working as a monitoring system of quality management. As I said, the quality management system we are adopted, and HMC is the monitoring system for it. And prioritizing the needs of the institutions. So many infrastructure development, then so many needs may come raised in Gram Sabhas and from public also. So HMC is fixing the priority of the needs of the health institutions, and the LSCs are formulating the project accordingly. And HMCs are acting as the implementing and monitoring agencies. HMCs can be decided, or they can directly implement a project of NHM also. If the institution is in lack of employees, then HMC can be appoint employees, even the doctors also. And if we goes for some innovative ideas we adopted in the health sector, Arogya Sabha is the main one. Arogya Sabha in all the 17 wards of the panchayat. We conducted in the, since 2014 we are conducting it. PHC, yeah. Then the health activities were evaluating in Gram Sabhas, that is the Arogya Sabha specialty. So once in 6 months, the report of HI, health inspector, as well as the JPHN has to be submitted before the Gram Sabha, and the people of the ward, the ward members are discussing on the report. So that is one innovative idea, and another one is Sayam Prabha. Sayam Prabha is addressing the old age people, a club of old age which is gathering in an Anganwadi, and their activities were taken by local self-government, and we are in discussion. We are having a plan to do so and so activities, but we had a discussion with the old age. They demanded for their art festival in their old age. They demanded, we are singers, some of us are singing. So we conducted a arts festival, tour program for them, and medical camps for them, and nutrition program for them. So it's a Sayam Prabha is let them shine in their old age. That is a concept. So Sayam Prabha is an innovative idea, and some other NCD fitness center. As part of we provided a quality NCD facility in our FSC, and apart from that, in addition to that, we started a futsal, then open gym, then indoor shuttle court. Everything is provided within the FHC compound. So NCD Fitness Center, a solar energy providing system is working in FHC. Yeah. Then IEC with mural painting, free Wi-Fi, then medicine counseling center is an innovative idea in FHC. On evaluation of this, we acquired ISO certification, ISO 9001-2018 in the year 2015, and we achieved NQS in the year 2019 with 93% score, and 2022 we improved it to 96%. And so many other things we did in COVID time, community kitchen, then robot service provided first line treatment center. That's first time in Kerala, two robots were facilitated in a first line treatment center. So they are going to room and giving the facility over there. And community kitchen.
So there are a lot of achievements.
Yeah. Due to time constraint and briefing it. Thank you very much.
So this shows that a panchayat can do certain managerial innovations, quality circle, quality certification, and citizens charter and all that, and different initiatives. So given the freedom, in spite of the framework, you have freedoms. That's what the 3 presentations show. Now I request my friend from Madhya Pradesh, Sri Radhu Singh Budia, to speak.
सम्मान्य मंच, मेरा नाम राधू सिंह भूरिया है, पूर्व जनपद अध्यक्ष जनपद पंचायत रामा, जिला झाबुआ, मध्य प्रदेश। हमारे
Distinguished guests, I am. I think at the end you just sum up the entire.
Just sum up in.
Okay.
Not the meaning of it.
मैंने हमारे कोविड के समय हमारे क्षेत्र के ग्रामीण और गरीब तबके के लोगों के लिए जो डिजिटल एक्सरे मशीन का निर्माण कराया, वो हमारे मध्य प्रदेश में हमने प्रथम बार हमारे रामा बिलाक में मैंने स्थापित कराया। उसको स्थापित करने में हमें काफ़ी समस्याओं का सामना करना पड़ा, जिससे स्थापित करने से काफ़ी लोगों की जान बचाई गई, जिसके लिए इंदौर, झाबुआ, रतलाम ऐसे दूर दराज के क्षेत्रों में जाना पड़ता था। उसको मैंने सरलता और सुगम स्थापित करने के लिए हमारे रामा बिलाक में मैंने स्थापित कराया और उससे
I'll sum up. Don't.
You can summarize.
Yeah.
Okay. I just want to say that at the time of COVID, we established a digital X-ray machine, which was first of its time at the block level in Madhya Pradesh, and people had to go to Ratlam, Jagua, and all the far-off places to get this done. But we, with the efforts, many efforts were put in to establish this machine at the block level.
उसको स्थापित करने में हमें उसका जो हमारे उसका इंजीनियर नहीं मिलने से हमें उसकी काफ़ी समस्या को देखते हुए जीएम पोर्टल के द्वारा उसका डिस्कशन निकाला गया और हमारे ग्रामीण क्षेत्र के बच्चों के लिए हमारे पूरे मध्य प्रदेश में नहीं अपितु हमारे जनपद पंचायत रामा में कंप्यूटर का जो वर्तमान समय में कंप्यूटर की आवश्यकता को देखते हुए बच्चों को आगे की स्थिति कंप्यूटर से अच्छा ज्ञान प्राप्त करने के लिए मैंने स्कूलों में कंप्यूटर की स्थापना, लाइब्रेरी बनवाए, जिससे हमारे रामा बिलाक का नाम यहाँ नहीं पूरे मध्य प्रदेश में हमने इसका नाम उज्जवल करा।
Actually, a whole computer lab was set up at the school level for the future of the children, and this enlightened not only in our own district, but the Gram Panchayat was highlighted in the whole of Madhya Pradesh. Just because of the future of the children, we had to establish this computer lab.
इसके पश्चात हमारे सौर ऊर्जा के स्थापन के लिए हमने उसका पूरा प्लान बनाया, लेकिन उसका इंजीनियर नहीं मिलने से मेरा काम वो अधूरा पड़ा।
We had planned a solar power system in the block level, but due to the lack of civil engineers, the plan is just ready, but we are not implementing it due to lack of civil engineers over there.
और इन्हीं शब्दों के साथ अपनी बात समाप्त करता हूँ। जय हिंद, जय भारत।
With this, I thank you all. Jai Hind and Jai Bharat.
So it shows where the panchayat has a will. It can do things extraordinary in a very difficult context. I don't know how many of you have visited Jabua. I have visited. It's a very, very tough area to do all this kind of work. Congratulations. Now I think I'll open for a discussion, and at the end of it, if something is left, I'll ask the panelists some additional questions. So please, you can raise your questions one by one. Yeah, please. Mike.
है मेरे जी 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 हमारे जनपद स्तर पे महिलाओं की महत्वपूर्ण भूमिका है।
Women play a very important role in our Janpat.
जो कि जैसे आशा कार्यकर्ता,
like ASHA workers,
और आंगनवाड़ी कार्यकर्ता, एएनएम इत्यादि जो महिलाओं का सहयोग रहता, जिससे पंचायत और जो अस्पताल से संबंधित कार्य मिलकर जो करते हैं वो सुगम और सरल हो जाता है।
So women play a very important role like Anganwadi workers, ASHA workers. So participation of women makes it very feasible for people to visit the hospitals.
That's a very important point. Women, frontline workers facilitate some kind of better participation of women or access by women. Any other question? Yeah, there.
Hello, am I audible?
Yes.
I am Tejal. I am in Healthcare Financing Division in NHSRC. My question is to Panchayat representatives. I want to understand when incorporate their needs in terms of planning process, and also what are the challenges that you face in terms of allocating the financial resources. So how are the resources also generated? Are they own resources, and what is the nature? Like for example, if there are devolutions from the higher levels, so what are the challenges that they face in terms of maybe the allocation in the lines of the needs of the people?
I would divide the question among the two presenters. I'll request Mr. Xavier to describe briefly the planning process for health. How you do the planning. Then Mr. Rajiv will say how the resources are allocated and raised.
We have strong planning committees, working groups, Grama Sabhas. First of all, we put our ideas, discuss our ideas in planning committee. Then we will move to working group. We will discuss there. And Grama Sabha, we will take their decision to implement such and such programs, and we will reserve certain funds from plan fund also. We will provide for the development of our health system. Grama Sabha is what what are the dreams of the common people that we will follow. Okay.
Explain the concept of the working group. As a core function, working group is headed by an elected member, a standing committee chairperson normally, is convened by the medical officer, and his membership includes the vice chairperson has to be a non-government professional from the sector. Then its members, one of them have to be from some CSO or activist, and one from the community representing the stakeholder. So not one, it can be more, 5 categories of members. And they discuss all this, they consult people, analyze data, analyze past performance, and come out with a draft list of suggestions, how and what are the implications, from which the panchayat can form its view and take it to the Gram Sabha. So it's a very, very critical thing which can be replicated all over India, a working group to support panchayats because they may not have the technical know-how. Now on the financing part, I request Mr. Rajiv.
As Vijayan sir and Isaac sir said in the morning session, Kerala's Gram Panchayats are local self-governments. Local self-governments in the sense, not alone with the functions and functionaries, but with the fund also. 30%, nearly 30% of the state budget is giving to the 3-tier system in Kerala. And among this 30%, almost 70% of the 30% is getting to the Gram Panchayat. So with this fund, a focus-based administrative committee can plan either in health sector, in agriculture sector, which all the committee is focusing, they can utilize the fund. So in our tenure, we focus, 5 years we focus in health sector, and I'll give a brief description of that for the last 3 years. Since 1819, health sector fund was 25 lakhs. And in addition to that, NHM fund also we received as 13 lakhs. 1920, 52 lakhs was our health sector plan. And that year NHM fund was 2 lakhs. 2021, 33 lakhs was our GP's health sector plan. And NHM was supported by 2 lakhs. And in addition to this, we had nearly 21 lakhs of rupees we received as awards, then to maintain the quality, what is that, checklist, I mean, which was suggested by NQS, then cash and all. They are supporting us financially also. So last 5 years we received 21 lakhs. And we are having our own sources also, like our own fund, building tax, then license fee, building permit fee. These all are collecting by Gram Panchayat. So we are having budget allotment as well as our own fund, our own revenue. So these funds, how we can utilize, that depends on the focus of the local administrative committee or the local self-government. So the main aspect, as Vijayan sir noted, 3F, fund, functions and functionaries. When it's functioning very well, then these things can be done.
Yeah. Yeah. There.
Sir, I am Dr. Damana Ahuja. I work for Advisory Group on Community Action. This is a group made by Ministry of Health and Family Welfare. And this question pertains to the Panchayat presidents. Can you throw some light on Ardram Arogya Puruskaram, which is meant for health only? What role the panchayats would play into that Puruskaram?
Yeah.
Ardram Puraskaram is given by the state government, and it's purely based on the quality service management in the system, I mean in the health sector. And we achieved the same award once in the year, it seems, 2019. And obviously it's for the service, evaluating the service delivery. Apart from that, what all innovative ideas we adopted as part of annual plan, and how the people's participation, and what all priorities we given, and the priorities decided by whom. These all are the evaluating or the checklist or evaluating points, and based on that we got it. And I may especially say effective as well as modern, and then too without any discrimination and a transparent way. This is the service aspect we adopted in our institution to get the Ardram Award.
This Ardram Award, before Ardram also, this Arogya Puraskaram started in 2012 or something. 12. Two things. First, it was made part of the NHM. So NHM came to know that panchayats have a role in health, and they allotted some funds for local planning. Second, it set off a competition among good panchayats. Until that time, the focus was on infrastructure. For the first time, the focus shifted to service delivery and other innovative things. Once a panchayat gets a Puraskaram, others also try to emulate. So in a sense, it really had a lot of positive effects in getting into service delivery of health, moving away from just infrastructure. In a sense, that was a trigger. Yeah.
One condition is there, once winner cannot apply next year or coming years.
Yeah. Dr. Biju.
Seems to be spending lot of money.
Iravi
Perur, both spending lot of money for purchasing medicines. Whether that is something which can be promoted, because medicine can be purchased from the light department, like health department. Only limited amount of money is given to local panchayat for planning. Whether spending lot of money on purchasing medicine is something which can be taken up.
Shall I? The purchase of medicine is not directly by LSGs or PHCs. We are depositing it to the government agencies. KMCL is the main agency, otherwise Karunya. So through them only we can purchase the medicines. We couldn't purchase it directly. Even in a worst stage of shortage of medicine, we couldn't go for that. And to overcome that shortage in an emergency situation, we adopted a system of buffer stock. Buffer stock system. So with a buffer stock system, we can anticipate the necessity of medicines, and based on that, we will have some sort of stock by purchasing from Karunya, and the annual purchase is from KMCL alone, a government agency.
I'll also add a point. See, in a large, there's an impression, there's no scientific evidence, where medicine supply is regular, people come more to the hospitals. That's what everybody says. Otherwise, they go away from the public. It's a voting with the feet. So this is a very critical kind of thing. There's a limit in, ideally, health department should supply everything. A former FM is there. The government cannot afford the full cost. So panchayats were allowed freedom to supplement, and they have been supplementing very well. And then since they adds to the people coming and as a positive health impact, generally it's been encouraged. Ideally, yes, health department should give its full quota. Yeah.
Our challenge was from nearby panchayats also people are coming to our FHCs.
Yes.
Yeah. Thank you. My question is related to the question that Professor Biju Soman had asked. When money is limited, panchayat and the health center may need services beyond medicines. So, and we can't, I think I can justify spending money on medicines because Kerala has a high problem of non-communicable diseases, hypertension, diabetes, which requires uninterrupted medicine. But when medicine draws away all the funds, what about funding for other health needs? Sanitation, infrastructure, preventive health services. How can you share some experiences in that? How is fund or resources identified for something specific to women and children health or elderly health, which is not medicine?
We have the stock of medicines for the demands which is coming up from 6 clinics. From Monday to Saturday, 6 clinics are there. So when the demand comes from clinics, we have to address it. And when the interventions are coming more, then the flow of people to FHCs or relaying the people FHCs are coming more. So when we are interfering in public and we are awareness are giving to the public, like health sector, government health sectors are getting much better, and they are, based on that, they are coming to the FHCs. If the medicine is not there, then it will give a bad impact. We have to address old age people, antenatal, women, pregnant ladies, then palliative patients, so on it is, and disabled medical camps are also there. Even for palliative bystander medical camps are also there. Their health also has to be addressed. So for these, enough medicines has to be stocked there. And as I said, the challenge is when the service is getting better, nearby panchayat people are also relaying the better one.
Yeah.
I will try to ask this question once more. So, sir, I fully agree the need for medicines, and that is really great. But you were sharing the example of yoga classes. So we need a trainer for the yoga class. Then you were mentioning about the driver for the palliative care. Then you were mentioning about gym. So the gym equipment needs maintenance. There has to be trainers. So there are health related expenses which are not medicines. So how is money identified for such activities?
For yoga and all, we are having HMC fund. HMC fund is arising from lab. HMC has appointed a lab technician, and lab is functioning effectively. And it's though it's a nominal amount, 3-4 lakhs rupees we are getting per year from lab itself. And for gym, futsal, open shuttle court and all, we fixed an agency to receive a nominal amount from the public or youngsters and can maintain it year by year. And we are providing an electric auto for old age, absolutely free of cost. And about the solar energy, I said now, we are having surplus energy that we are giving to KCB in net meter, through net meter. On end of the year, the balance sheet is calculating the balance sheet. We used to get 1 or 1.5 lakhs rupees from KCB, right? So then what else you ask? For yoga, as I discussed with Rajiv Sadanand sir, since 2012 we are conducting it. We charged a beneficiary contribution also. Yeah, this is the way we are adopted it. Yeah.
See, the planning means fixing your priorities. You don't have money for meeting all the needs. Now, who fixes the priority? The local government fixes the priority, not somebody sitting there. So we don't have money for everything. So they discuss, and yes, medicine is more higher priority, they would allot more. But then the process is such, it creates demand from below. They want yoga, they want that, this, etc. Then the local government will be forced to go for additional resource mobilization through various ways. Say, Punuru Taluk Hospital is another celebrated case. They mobilize more money than the grant given by the government, including salary to the hospital. They have collected 30 crores from service charges, additional they give. People are willing to give the best service. He said about 1.5 on the lab, not 1.5, much more higher. Or say 9 crores as reimbursed from the insurance program. Say in the Ayushman Bharat insurance program, each hospital can take the money, the insurance premium they get, compensation they get. Government doesn't take. So this, suppose your hospital is good, it brings you additional money. So this is the process. Everything cannot be done. But the priority will be fixed by the government, the local government, but not by some bureaucrat or health ministry, but they fix the priority. Pardon? State government is not taking up the responsibility, even to the local panchayat. Yeah. Surely, even for the state government, there is not money for everything. So what has been done? There are two ways of doing it. You can give down the responsibility and not give the money. But in the case of Kerala, responsibility was given, so an proportionate allocation was given. In fact, I would say many departments were fairly devastated in the first year. So now this is the money available, but the needs are much more. Then the process of participation is such, it generates demand, and local government will attempt to raise more resources.
One important point taking off from what Dr. Isaac said, resource mobilization innovative ways of resource mobilization. When there is a public demand, they resort to resource mobilization. So that way it's positive. Second, from a technical professional angle, what is this medicine for? If you make a quick analysis, most of it is for NCD, elder care, insulin, those kind of things. That's my impression, talking to panchayats and doctors. So in a sense, it's not a bad investment. Then one more point I want to tell the audience. How did Kerala ensure accountability of officers? It didn't come very clearly. Not through disciplinary, it's all there. But what comes was all the non-plan allocation for maintenance, which was with the DHS and different departments, were pulled out and collapsed into a single fund called maintenance fund, which and given to the local governments on the presumption that their allocation efficiency is better. Now if the doctor wants to improve, repair his thing, there's no money with the DMO, there's no money with the DHS. Very little money, not no money. So it's easier to go to the local government and get it. So there is a fiscal route to accountability and relationship. And you get it immediately. And if it's a good doctor, you get it double. So that it was not anticipated when we brought this. But now, in hindsight, that has improved the relationship between the doctor and the local government. It's a circular, positive relationship. Yeah, somebody wanted to ask.
I just wanted to make add a point what Dr. Isaac was saying. Demand generation and participation. There's also a layer of what is called ascertaining the demand. Very often the demands that are made are not carried through, sir. They do it on, there's a lot of peer pressure to make a certain demand, but it doesn't crystallize. There's a whole process by which a lot of local level planning needs to go into ascertaining the demand and then, segmenting all the demand. I think that's a process that we need to look into.
In a sense, that process exists as part of the overall thing. Yeah. The doctor makes an impression, this is there.
The government also does this kind of feedback.
But here the local government's sharper.
Yeah.
Exactly, they know this medicine, so many patients, last year this happened, go to the panchayat. Panchayats get pressure independently from the people. So that way the process is going on.
No, the government also sets priorities on this kind of, first level of demand generation.
Yes.
They don't go and find out whether it is really crystallized or not.
Yeah, you were asking a question.
Yeah. That's true. But the demand is generated, there is a deliberation going on in the Gram Sabha where we should have this or that. But then there are at different levels of deliberation. You have working group where it's more technical, objective discussion takes place. But the demand generated from below is taken into consideration. So there are different levels of participation. Participation in Gram Sabha is not the ultimate, you see. There are different levels. And the challenge of decentralization is to design such microfora for where people of different talents can participate meaningfully.
So there are communities that are quiet. They've been quiet for centuries. So it's very difficult to filter everything under that level of, what you
I fully agree with you. You mentioned the tribals in Kerala. Because of their silence, quietness, lack of power, probably their things have not been taken care of as they should have been. You wanted to ask a question? Yeah, from Jan. Yeah.
मेरा सवाल भूरिया जी से है तो जो स्वास्थ्य से संबंधी जो काम आप कर रहे हैं उसमें जो बाकी भी जिस बात पे अभी चर्चा हो रही है कि आप संसाधनों की व्यवस्था किस तरह करते हैं उसकी प्रक्रिया क्या है उसमें आप अपनी प्राथमिकताएं कैसे तय करते हैं
priorities in that how do you decide on your priorities
ये तो मैडम जैसे हमारे इस कार्य को करने के लिए हमारे ब्लॉक स्तर पे जो डॉक्टर होता है सीएमओ उसके द्वारा जो आशा कार्यकर्ता आंगनवाड़ी सहायिका और एनएम सभी को निर्देशित करता है जिसके अनुसार हम मासिक बैठक लेकर विभागीय बैठक लेकर और मासिक बैठकों में इनका निर्णय लिया जाता है
monthly meetings. You wanted to ask a question?
Meetings.
Good afternoon. Good evening, rather. So, sir, one of the things in a health system like Kerala, where utilization of primary healthcare resources, if you were to sort of just take an average of OPDs per day at a PHC level or even at a sub-center level, would be reasonably higher as compared to the larger sort of states. Now, I mean, it's more of a comment and a question. Is, sir, for systems where the OPD utilization is woefully inadequate, and one is aware that usually in the larger states there is examples of almost just 10 OPDs per PHC, right? Now, the challenge is it's a vicious cycle. You don't have services, you don't have drugs, and you don't have human resources. Therefore, the utilization of the services are not there. So the demand generation is not there. And then often what happens is then there are other mechanisms of creating resource like a Rogi Kalyan Samiti, which can get into areas of user charges. But then the question being that, sir, how do you decide? How do you, I mean, what is the way, if at all, to break this vicious cycle? Because if you were to empower the Rogi Kalyan Samiti, which obviously sits, as Mr. Bhuria said, every month they're supposed to be sitting and, you know, evaluating as to what needs to be done. Now the power is there for them to decide what is the user charges which can be charged for, let's say, a lab service, or for that matter, even an OPD, right? I've seen examples in states where they charge 10 rupees per OPD. Of course, BPLs are left aside, but then there are examples where just 1 rupee token, etc., right? But the idea, I mean, the question being, how do you break this vicious cycle? And how do you sort of, you know, also empower the local level governance mechanism to create this demand because of want of lack of resources, either through user charges or, for that matter, even funding which comes from the government?
If I may take that question. First is, you have to provide the basic minimum services through the public system. It can't be outsourced to a Rogi Kalyan Samiti. Rogi Kalyan Samiti can supplement, but the core thing has to come from government. Initially, patients may be low, but that vicious circle will be broken if services are there and people start getting it and realize the importance. And in COVID, briefly they realized the importance of going to a governmental system, getting the relief and getting the benefit. So I think it can be set off only by a doctor going there, treating. Then demand creation now becomes easier. For example, Kerala demand creation came through literacy extension in the 30s, 40s and even before. But now with the SHGs being active, India has nearly 80 lakh SHGs, that's 8 crore people. Through them, Sakis can easily sensitize why you should go to hospital. And that itself can, if the facilities are there, access will improve like anything. That's my understanding. Yeah. I think that's the last question.
Needs to be junked, one. Second, I don't agree that resource generation through user charges. Nowhere it has been shown that user charges will complement the finances either at the local level or at any level. In fact, it creates a problem. I think that needs to be put in place, one. Second, I don't know about Kerala, but definitely I've done some studies in Malappuram and Palghat. Utilization of PHCs is not so great in Kerala. It is the Taluka hospital and the district hospitals where the utilization is high. Okay. Now, as it is, no one is coming to our primary health centers. And you are going to get into all kinds of this user charges, World Bank dominated and supported crap. We have given that away for a long time. So I am really putting it on paper, on the table, that please do not get into this thing about resource generation through user charges. Thanks.
Anyway, that information that people don't come to PHC is not correct. But it's only OP, not for inpatient, nobody will come to a PHC. For OP, it's very high footfall is there. Yeah, please. I think that will be the last question. We are fine.
So given that the local communities are empowered,
given that the local communities are empowered, we can expect certain grievances. So is there a formal grievance redressal mechanism in place? Second, if there is one, if a grievance is not addressed at the level of the local government, can it be escalated to one level higher than the local government?
We are we are having a grievance redressal mechanism in FHC also, as well as in the Panchayat office. It's chaired by the medical officer. It's chaired by the standing committee chairman of Health and Education Standing Committee, and the convener, I mean the secretary, is a medical officer, and one public servant as well as an HMC member is also a part of this grievance redressal mechanism. Once in a month they are gathering, and some boxes were fixed in sub-centers and health centers like Ayurveda, Homeo, then FHCs are also, boxes are fixed. And once in a month, these boxes are opening. And even a register is also kept near to the front office of FHCs. So, as we know, it's, the grievances are redressing month by month.
But there is no appellate system in Kerala because we didn't want somebody to sit and judge over a local government. But there is a system which is not that easy. There's an ombudsman. Anybody can write a letter, not a formal complaint, and the ombudsman can take, but there's only one person body. So thanks a lot. We have concluded on time. Excellent presentations, and we got an overview. What we learned: innovations possible, resources mobilizable, and kind of managerial systems, and even in difficult locations, you can, with a will, get even out of the way electronic things in. So that is a big learning. So we stop here. Thanks a lot.
Thank you very much, Mr. Vijayanand. If I could request all speakers to just remain on stage and invite Ms. Pallavi Gupta, Specialist Health Systems Governance at HSTP, to please present tokens of appreciation to our panelists. Mr. Bhagat Rufus, Mr. Saju Xavier, Mr. Rajiv N, and to Mr. Radhu Singh Bhuria. Mr. Vijayanand, you already have your token of appreciation. Thank you very much. If we could request all of you to just pose for a photograph, a group picture. Yes, move closer in. So ladies and gentlemen, thank you for being with us and participating in the conference. We have another day of work tomorrow. We will begin at 9:30, so please be here on time. A couple of announcements for those who are staying in this hotel, at Ashoka Hotel.